So I would like to invite our first speaker for today's session, who is going to give us a topic on the early detection programs for chronic kidney disease, reducing the risk and preventing complications. Our first speaker, he is the unit chief in the Department of Medicine and the Manipal Academy of Higher Education in India. He has been involved in teaching and training graduate and postgraduate students for over 2 decades and has a notable publication in national and international journals. I would like to introduce and welcome to the podium Prof. Dr. Vasudeva Acharya.
Good morning to all. Thank you for the nice introduction. At the outset, I thank the Merck Foundation for inviting me, especially Dr. Kingsley and his team calling me here. I come from Manipal, which is actually in the southern coast of west coast in the southern part of India. So if you travel just south from Mumbai, it's around 1.5 hours in the flight, you get Manipal. Manipal is a small town, but it's an educational hub. It has an institute, university, plus almost all kind of training, medical and engineering, everything else. I'll be talking on early detection program for chronic kidney disease, reducing the risk and preventing complications. Before going to that, we should know what is CKD or chronic kidney disease. So there is some change in the terminology. Originally, when I was studying my post-graduation, we used to call it a CRF, chronic renal failure. There's a subtle difference in the terminology now. Those days, we used to call somebody who has an abnormal creatinine for more than 6 months. It's called CRF. That is simple definition. But it has been changed for good purpose only. There are different bodies, which actually scientific bodies, which defined it. In simple term, we are not just looking into only the creatinine or GFR now, but we are looking into other issues also. That's why the name has been changed. So it's defined as either a GFR of 60 ml per minute per 1.73 square meter area, less than 60 for more than 3 months, or the above one which I mentioned there. So kidney damage for more than 3 months confirmed by either by biopsy or by the albuminuria or abnormal urinary sediment or even electrolyte abnormalities. So all these are included in a newer definition of CKD. And technically speaking, somebody is having an abnormal urinary sediment for more than 3 months, still can be called as CKD. Originally, we are not calling these people as CKD. They should have an abnormal creatinine in those days. This is that KDIGO, which is the international body for defining chronic kidney disease. It has staged the chronic kidney disease in a different stages, G1 to G5, in between A and B. This part is based only on the GFR or a glomerular filtration rate. So more than 90, it is normal or high. That means somebody has a 91 GFR, but he also has some abnormal urinary sediments, will be called as G1. Like that, 60 to 89, 45 to 59, and goes below. Less than 50 is called a end stage renal disease. So this is based on this. But recently, they have also added what I call a proteinuria or albuminuria to this grading. So presently, we call somebody with CKD grade 3 or class 3 or class 4. In addition, we'll write it as A1, A2, A3, depending on the proteinuria. Or albumin, AER is albumin excretion rate or albumin creatinine ratio. Both are kind of same. So if it is less than 30, it's kind of normal. So we call it as A1, A2, A3, depending on the amount of albumin which is excreted in the urine. So more than 300 per day will be called as A3. So given patient will be graded as maybe class 3A2 or 3A3, A8, A1, like that. Why we need to actually talk on this issue? So goals of early detection. Why you need to detect chronic kidney disease early? So there are some issues about what are the problems with the detecting it, which I'll show in the last slide. There are some issues with detecting them also, but I'm mainly concentrating on we need to detect. That is my idea for the first, except last 1 minute. So prevent the progression of CKD, prevents the complication. CKD has a lot of complications, subsequent patient outcomes, and of course, the reduction in the impact of CKD on healthcare resources. This is an extremely important issue because once they go for an end-stage renal disease, It's very expensive therapies, whether it's going for a transplant or a dialysis, peritoneal dialysis, whatever it is, they are very expensive on the healthcare issues. So the rationale for an early detection of CKD is well proven. So overall, it should be an improved patient outcomes for identifying, particularly in identifying in a high risk people, which I'll mention a little later. Who are these high risk people? And we target particular patient. For example, somebody with a diabetic with a CKD, we have some specific medication to target them, unlikely the other CKDs like that. And end of the day, it will be to reduce the incidence of adverse effects of progression of ESRD. And the last part, that is cardiovascular event. Though I'm talking about kidney, you must be knowing the most common cause of mortality or death in a patient with CKD is cardiovascular mortality. So if you prevent the progression of CKD, indirectly, you're actually saving people from cardiovascular deaths. So that is the idea of early detection. So there are many programs. So different bodies have different kind of programs. I will not go to the details of this as such. These two are the example ones, like NKS sponsored kidney early evaluation program is called KEEP, or NIH National Institute of Health's kidney disease education program is called KDEP. Almost they are all same. You can look into those things in detail in the online. It will be available these things. I will not go to each program as such. So now, how do you screen for these people? How do you screen and when do you screen? In general, these are the 5 components you are looking into when you are screening a people for a CKD. So you have to check the blood pressure. You have to calculate the eGFR, that is estimated glomerular filtration rate. Urine ACR, that is urine albumin creatinine ratio, or in general, you can take it as proteinuria in simple term. Urinary sediment and imaging kidneys. You look into these are all cost-effective things. You're not spending too much on this. In fact, on ultrasound, on urine testing, on proteinuria testing, calculating AGFR, that means you need on serum creatinine, and checking blood pressure. All these are actually very cost-effective method. That's why you can use this terminology for screening. I'm not saying that identifying this, but you can screen. Next question comes, whom do you want to screen? I think in overall, there is no national consensus in our country. I think in most of the other countries also, whom do you want to screen for all these things? In general, people who are at the higher risk, it's a must. So these are the 4 or 5 important points, important diseases who are at higher risk of CKD. You know, diabetes mellitus is the most common cause for CKD all over the world, maybe contributing for around 35, 40%, in some countries, even 50% of the CKD people on dialysis are due to diabetic renal disease. Hypertension, autoimmune diseases more common in women and a younger generation. And any cause of acute kidney injury who are recovering should be screened at least at a recent interval, frequent interval, to check into whether they go for CKD. Because some of the AKI, acute kidney injury, though they almost always recover, they may end up in later CKD. Of course, people with the family history of CKD. These are the important risk factors for progression of CKD. The most important point to look at here is almost all are reversible. So except maybe the first one, persistent activity of disease responsible for CKD. For example, classical example I'll give is SLE, that is systemic lupus erythematosus. The primary disease has to be treated and activity has to be controlled. Otherwise, they go for CKD. Suboptimal prevention of diabetes and hypertension control, persistent proteinuria, high protein intake. Of course, there are some other diseases which can be kind of treatable, like UTI, reflux nephropathy, systemic infections, smoking, obesity, both are kind of treatable, hyperlipidemia. So these are the higher risk factors for progression of CKD. Why there is actually, when somebody has a mild renal failure, why do they further progress? The most important thing there is actually, there is something called a surviving nephrons will undergo adaptation and they function more. This is very well studied in diabetic nephropathy. In fact, the first stage of diabetic nephropathy is called where the GFR is elevated than normal. So that's called super functioning of kidneys. There will be a single nephron raise in GFR. Individual nephron, if you take, they are functioning more, whereas some of the nephrons are not working. So this will end up in the glomerular hypertension, hyperfiltration, and further perpetuate the glomerular injury. So there's something called a rapid progression, when there is a eGFR falls down more than 5 ml per minute per year, which is called a rapid progression. The most important molecule we should know about, that's why I put angiotensin 2. There are many other molecules. I just skipped those slides probably. This angiotensin 2 we should know. This is the central mediator for a glomerular hemodynamic changes. The angiotensin 2, which causes actually the constriction of the efferent arterioles. So if there is an increase in angiotensin 2, there will be effective glomerular pressure will increase. So that's the idea of actually giving an angiotensin 2 blockers, like either you reduce the production of angiotensin 2 by ACE inhibitors or directly ARBs we can use. But they also have some other effect like oxidant stress. They increase the aldosterone, which is actually not good for kidneys. And of course, upregulation of many cytokines, which I mentioned here, it's not very, very important for us as far as because it's only for the research purpose. But primarily we should know is the hemodynamic changes which happen in angiotensin because of angiotensin 2 and the treatment when you're giving angiotensin 2 blockers, which will reduce the intraglomerular pressure. So how to detect early CKD? I think I already mentioned. So serum creatinine and estimate the GFR, that is eGFR, check for proteinuria, check for urinary sediment. Maybe you can include an ultrasound abdomen to detect any structural diseases of the kidney. So calculate the, you have a serum creatinine which is checked in most of the places. There are different formulas to calculate eGFR. Most commonly and most widely used is Cockcroft-Gault formula. It is just nothing but the you calculate depending on the age and weight. So you minus 140 minus age into the weight divided by 72 into creatinine in milligrams. That is the formula. It's available everywhere. That is the most simple formula which is available to calculate the creatinine. But it had some loss of other issues, like it may not be an exact calculation depending on the weight which changes. MDRD is actually the most accepted, probably the method to calculate creatinine, but it is very complicated. So in general, bedside, nobody can do this MDRD formula, which is very complicated. It's a US modification for diet in renal disease, but it is the one which is used for most of the research purposes. Somebody doing some study, research purposes, we have to use the MDRD formula. There's another formula called CKD, epidemiology collaboration equations. But in general, bedside, we use Cockcroft-Gault formula. Proteinuria, you can do something like an untimed because sometimes patient comes for just an outpatient visit. It's very difficult to get a first morning urine or a 24-hour urine sample. But you can do just untimed or a first morning void urine to detect proteinuria. But ideally, before diagnosis, they should undergo confirmation. That is by the estimation of the 24-hour urine or at least estimating the random sample for creatinine and albumin ratio. It's called ACR. Albumin creatinine ratio of a single sample. So once you quantify it, you call it as between 30, below 30 is normal, 30 to 300 is called microalbuminuria, more than 300 is overt proteinuria. So this microalbuminuria stage, if you can, there are some dipsticks available, which just detects the microalbumin, that also can be used, not very expensive in India at least. I'm not sure about other countries. We have a dipsticks to detect only microalbumin also. There are many other biomarkers for glomerular injury. Practically, these are all used only for a research purpose. So I will not go to the details, just put some names. We are not doing this day in and out. Here also, I think you must have heard, we are not testing only the glomerular because eGFR calculates only the glomerular function. We need to test the tubulointestinal function also in the kidney. For that, we have some of these molecules. One or two are available in Indian actually setup here. Actually, the first one, it is called KIM1, Kidney Injury Molecule 1. And second one is also available in many hospitals, neutrophil gelatinase associated lipocalin, NGAL or NGAL we call it as. Remaining three are not commonly used. The first two are used in some of the patients, not in everybody. But in the research purpose, we are doing some studies, probably should be able to use some of this also. Because they are primarily detecting the tubulointerstitial injury, whereas eGFR or proteinuria, you're looking only at the glomerular part. This also, again, most of the time, we don't use this omics in early detection, like genome, epigenome and all. But whatever example I have given here, what is called anti-M type phospholipase A2 receptor antibody. This is the one actually very specific for a membranous nephropathy. You must have heard one type of glomerular disease called membranous nephropathy. And this antibody is very specific for that. So this may be useful with somebody with proteinuria when we don't have an obvious cause for a proteinuria. So this is again done in many of the hospitals in India, including in our own place also. There are a lot of studies, a lot of research going on microbiota in different diseases, including CKD. And there are good papers on that, a lot of papers on that. I just given one example here, which is published very recently, that specific microbiota like Ruminococcus and Roseburia, which have a very high diagnostic value in the early diagnosis of CKD. And there are many papers on microbiota. If you just put microbiota on CKD, you get at least some 15, 20 recent articles on this. A lot of studies going on this. MicroRNAs in detection of CKD. Again, most of these are actually the research purpose. Practically, we are not able to do, but these are all published articles. There is something called a personalized medicine approach to a kidney disease. That means this patient has a diabetes and he has a CKD, and you have a very personalized approach to that patient. Another patient has an SLE, has a CKD, we have a different approach. Practically may be difficult for each patient, but there are some example I put here. MicroRNA 451 is for an early diabetic CKD, like that diabetes with proteinuria, or another microRNA which 181A, it's also significantly reduced. These are reduced in patient with the diabetic kidney diseases. Okay, fine. So when what are the requirements? When you go and look at this patient, like in a community level, go and check the detection of CKD programs. If you want to introduce a CKD programs in your country, these are must. So we should know the document, the burden of the kidney disease in the country. For example, it's very rare, probably not worth doing. But I think in most of the countries, it's there. So I think there is not any big issue here. Leadership from the kidney society, because they are the one primarily leading here. Each country probably will have some specific societies for the renal disease. Maybe even provinces will have. In our country, we have an Indian society. Even each state have some society divisions of that. There should be a government partnership, because many of these tests are expensive. Funding is required, and ideally, maybe universal health care. In our country, actually, people are trying to do that. There is some program is there, something called an Ayushman Health Program, which gives actually universal health care to people. But of course, there are some issues with that, like all hospitals are not linked. It's a government-based system, like that will be there. Then there should be a method of early identification, like screening, which I've told already. Focus on high-risk group. This is an extremely important point, actually. We can't do screening for everybody. For example, Indian population, 140 crore people. We cannot do screen for CKD for all 140 crore people. Follow the standard guidelines for CKD along with the local needs. Then, of course, intervention and implementation through the public, patients, and healthcare providers. Actually, this is the where actually I am very much interested into. So what I call a health literacy or health education is more important nowadays. We are actually all these days concentrating on a medical education, but nowadays we have to concentrate more and more on a health education and health literacy of the common people. Then, of course, integrated management, like for example, diabetes, they have a diabetic society, they have CKD, what to do, something like that. Integrated management we should follow. How frequently you have to monitor? That means whatever put the number, it means number of times per year according to the stage. I have written G1 to G5 here, and also the A1 to A3 depending on the proteinuria. So 1, 2, 3 means once a year. 1 means once a year. For example, somebody is maybe G2 and A3 twice a year you have to do. G5 almost maybe 4 times or maybe monthly. Whatever star mark I put, that means they have to be referred to a specialist or a nephrologist, because something has to be done at that stage. The last line, A3 means they have a significant proteinuria. That means they have to be immediately referred to nephrologist, probably for a renal biopsy or something else. So that way we should deal with this. These are the traditional measured outcome of CKD. Like why we should do? Simply I told you in the beginning itself to prevent complication. But any study, if you look into, they look into these things. These are the 4 important measured outcomes of CKD. There are a lot of unmeasured outcomes. Measured outcomes, the most common people use in all the studies is progression of CKD. That means doubling of serum creatinine. Second thing is progression to end-stage renal disease or requirement of a renal replacement therapy. RRT is renal replacement therapy, dialysis or a transplant. Then the third thing, I've been telling cardiovascular morbidity and mortality, because there's a strong link between the chronic kidney disease and the cardiovascular mortality. Then development of a complication due to impaired renal function, like calcium, phosphorus, all those things. They're all smaller ones. The first 3 are the most important ones. If you look into the diabetic kidney disease, why the CKD progresses there? There are 3 different mechanisms which have been explained. The hemodynamic, which I've already told you, the first one, this actually talks about a renal angiotensin aldosterone system activation, renin-aldosterone activation. Angiotensin 2 levels will be high. Arterial constriction will be there, as I told in the beginning, efferent arterial constriction, and there will be vasoconstriction causing increased glomerular pressure. And you deal with using a drugs which blocks it, like angiotensin receptor blocker like losartan or a telmisartan. Metabolic pathway, hyperglycemia, glycolysis, and multiple other methods, you treat it by controlling blood sugars. The third one is very important because recently there are some molecules which are coming against the inflammatory pathways in kidney in a diabetic patient. I'll mention about the drug little later. So slow the progression, reduce complications. So these are the steps which we have to do: nutritional, lifestyle changes, medical management of blood pressure, diabetes, and albuminuria. In the meantime, the next 5 components which I'm not addressing today. So monitoring the associated complication, cardiovascular disease, mineral metabolism, anemia, depression, all those things as monitored. I'll just deal the first 3 things only. So elevation of the glomerular capillary hypertension is the common denominator. Whatever you do, the intraglomerular pressure has to be reduced. That is the primary aim in treating a patient with the early diabetes or early kidney disease. Nutritional, what we can do is reduce the salt to 2 grams of sodium or 5 grams of salt, depending on the area we take. For example, in my area, people take almost 10 grams of salt per day. Because we're in the seashore, many people eat seafood. So salt intake is more, but we reduce it to 5 grams. There should be a minimal reduction in the protein intake, because for more the protein, there's a more damage to the kidney. Though you are losing protein in the kidney, giving more protein will not help there. So you have to reduce the protein intake. If the GFR is between 25 to 55, you can give 0.8 grams per day. If it is still less, you reduce the protein to 0.6 gram per kg per day. And phosphorus, potassium you have to reduce, and weight reduction obviously for the obese patients. And other lifestyle intervention like smoking stopping, physical activity, weight reductions are important components. Okay, now I move on to the most important issues in the CKD prevention. Further progression rather, not prevention, is actually the blood pressure control. So ideal target for BP in a patient with CKD is not very clear. There are different studies quoted different thing. There is one trial which is called SPRINT trial, which used actually 120/80 in the intensive arm. BP should be less than 120/80, which had a very significant cardiovascular benefit. But in that particular study, kidney benefit was not proven, kind of. So we are not sure reducing to 120/80 will benefit the kidneys. ACC, that is American College of Cardiology, at present says about 130 to 80, or some people say 135/80 for CKD is probably the most appropriate blood pressure. So the KidneyGo, that is a standard kidney society, which every year it publishes the newer guidelines, which mentions systolic BP of less than 120 as only class 2C recommendation. That means not a very high level recommendation. So in general, probably 130/80 should be okay. Why that class 2C? They are mentioned here about uncertainties about their diastolic blood pressure. Because when you reduce systolic to 120, diastolic may further come down 60, 70, which is probably not very good. And in patient with a very advanced CKD, there is probably not much use in reducing further BP and causing them symptoms or something. And even in diabetes patient, will have some issues. And the drug of choice is always ACE inhibitors or angiotensin receptor inhibitors, like drugs like enalapril or ramipril, or an angiotensin receptor blocker like losartan or telmisartan. Use the maximum tolerated dose. Only thing is there is a concern about K means potassium. Both the drugs can increase the potassium level. So keep checking potassium level. And early CKD, irrespective of etiology, drug of choice should be either ACE inhibitor or ARB. Further is not controlled, we can add other drugs like diuretics or a calcium channel blockers. So next issue is the blood sugar control in a diabetic patient. As I told you, diabetes is the most common cause of CKD all over the world. There should be an optimal blood sugar control, HbA1c of around 7 or even 6.5, depending on the patient's other morbidities. We need to choose the drug correctly in a patient with early CKD. And at this point of time, we have drugs which work independent of blood sugar control. That is called SGLT2 inhibitors. The classical example is empagliflozin or dapagliflozin. They are probably the most popular drugs which have come to the market in last 5 years or so. They have multiple indications other than diabetes. Primarily used for diabetes, but is used for CKD, used for heart failure now. So everywhere they use their drugs. So what is the advantage or what is the proof for the blood sugar control and slowing the CKD progression? Advance is one of the big trial which is published around 15 years ago, which clearly show that intensive blood sugar control, that means HbA1c of less than 6.5, which reduce the ESRD risk significantly and also reduce the macroalbuminuria rather. And there is a further continuation of advance is called advance on. There also there is a further reduction of ESRD, even though HbA1c rose there. After the study, they continued follow-up on this patient. There also, there is a further benefit. Whether it's a legacy effect or not, we don't know, but there is a definite improvement in the further reduction of CKD progression. All these benefits are more if the GFR is slightly higher, not probably for a GFR of 25 or 30 or something. Benefits are obviously less. Okay, now how do you reduce albuminuria? So albuminuria is not just leak of protein in the kidney. It's actually a sign of system-wide endothelial dysfunction. So there is a problem elsewhere. As I told you, independently, albuminuria is associated with the cardiovascular mortality and morbidity. Irrespective of whatever may be the cause, definitely more if it is diabetic. So higher the baseline proteinuria, more rapid the GFR decline. This is well studied in many trials. Classical study is called RAIN study. And then another study is called Reassure Consortium, which said 30% reduction of albuminuria reduced the risk of ESRD progression by 24%. That means significantly improvement will happen. So drugs that reduce albuminuria by at least 30% should slow the progression of the disease. Again, originally, we had only ACE inhibitors like enalapril or amipril. After that, the ARBs came, losartan, telmisartan, those group of drugs. And now, since last few years, we got SGLT2 inhibitors, GLP-1 receptor. These two are diabetic medications. GLP-1 receptor antagonists like liraglutide or other drugs. Semaglutide is also available now. And of course, the last drug, which is called non-steroidal mineralocorticoid receptor antagonist, something like a spironolactone, but it is non-steroidal, which is called finerenone. I'll put one slide little later, which has also come, which will reduce the albuminuria or renal disease. The very popular anti-diabetic drug like DPP-4 inhibitor, I think you must have heard. One example is sitagliptin. They also have some effect, but not as good as the above mentioned line, but it can use sitagliptin also. There are maybe around hundreds of studies showing the benefit of AC inhibitors and ARBs in slowing the CKD progression. I just put few slides here. RAIN study, APRI, INDT. They use different drugs like ramipril and benazepril. They are AC inhibitors. Irbesartan and losartan, they are actually the ARBs. All reduce the ESRD progression and including mortality also. So there are newer drugs. New means I'm talking about maybe last 3 or 4 years, maybe recommendations the last 3-4 years they come. Newer therapeutic agents for slowing the progression of CKD. And the most important ones are actually SGLT2 inhibitors. So these drugs came to the market as an anti-diabetic drug, serum glucose and sodium transporter inhibitor there, SGLT2, they work in the kidney. So generally they cause increased glucosuria. They cause a loss of sugar in the urine. That is their primary function. That's why actually they used in diabetes. But after some time, they found that they have additional benefit because one is because of a sodium loss. They are beneficial in heart failure patients. They are beneficial in hypertension patients. So they came for a class 1 recommendation for patient with heart failure. So cardiologists started using these drugs. Now, since last 2-3 years, we have enough studies to show that both this canagliflozin and dapagliflozin are beneficial in patients with chronic kidney disease. Finerenone is the other drug I was telling you. This is a mineralocorticoid receptor antagonist. I think I have one more slide little later. GLP-1 receptor antagonist also been tried. This is the proof for SGLT2 inhibitors in the kidney disease. You can look into these trials. So EMPA-REG outcome, CANVAS, DECLARE-TIMI, CREDENCE, and DAPA-CKD. These are the most important trials. We can, if you're interested, you can go through that. All said there is a significant reduction in the CKD progression. And it's just the sentence why I put. There is nothing specific about that. If you're interested, you can read this. This is a very good, what you call Kidney International Report, journal review publication on the prescribing SGLT2 inhibitors with a patient with CKD. K is actually Kidney International Report, it's called as. And this GLP-1 receptor antagonist are very new recommendations. This is 2022. There is one article published on this, review article published on American Diabetic Association or KidneyGo practice guidelines on this. We are not using GLP-1 analogs as a first-line diabetic medication for a kidney disease. First line is always SGLT2 inhibitors, but these drugs also have been tried. They are slightly superior to DPP-4 inhibitor like sitagliptin or vildagliptin. This is a drug I was telling you, finerenone. This is for a diabetic kidney disease they tried. There are 2 trials. One is called Fidello and Figality, I think the other one. Both tried for they are basically anti-inflammatory and anti-fibrotic effect. Probably they are more useful for a tubulointerstitial disease than glomerular disease, because glomerular disease we have all other drugs which are available. And this trial actually, I'll just go skip these things. They looked into the kidney failure, end-stage renal disease, sustained decrease in the GFR, all the hazard ratio is towards the use of phenrenon here. Then all patients with CKD, probably we should supplement oral sodium bicarbonate. So there is a class 2B recommendation from KDIGO. Other issues in CKD also has to be addressed. I just looked into the only blood sugar control, blood pressure control, and albuminuria, but these are also important. Treatment of hyperlipidemia by statin, anemia managed by erythropoietin, intravenous iron, where underlying disease has to be treated, diabetes or SLE, whatever it is, infection, obstruction, lifestyle changes, and probably the referral to nephrologist. This is a slide I was telling you in the beginning itself. We do everything, but why we need to do? The question mark comes with this slide. You can look into these things. What are the challenges? Why we should do, or what are the issues we're doing is, we don't have a specific biomarker till now. We can just look at the proteinuria. We can look at the EGFR. They are not a specific biomarkers for the early CKD. And the GFR, what we're calculating, may not be very reliable. It might change to some extent. Next 2-3 issues. Diagnosing an early CKD in an asymptomatic person. You're probably not doing anything, but you're labeling him as CKD. So that will be the problem. Disadvantage of early detection, unnecessarily invasive procedure. You end up in doing some biopsy or something. Probably may not be required in all patients. If you do an imaging, find one solitary cyst in the kidney. What to do? You have to tell the patient that you have a cyst. Whether to pursue it or not, whether to do a CT imaging or something else on that or not. It may be a benign cyst. Nothing going to happen for next 10 years probably. But that is the issue with that. And end up in multiple specialist consultation. You send them to cardiologist, nephrologist, everything cost. And labeling them as CKD, which has other issues, social issues also like medical insurance, work performance, and maybe a choice of occupation. So these are the questions to be answered if you want to do a community level screening for CKD. So concluding, we should target the high risk group. That's what I am not straight away recommending that do community screening for all. Maybe in India, if you take 140 crore people, probably not advisable, not possible, but target group has to be, specific high risk groups should be targeted, measure the serum creatinine and estimate the GFR, then look for albuminuria. Optimal blood pressure and blood sugar control, and very low threshold for using ACE inhibitors or angiotensin receptor blockers. And the newer drugs like SGLT2 inhibitors have almost come as a standard guidelines for using CKD now. Even if they're not diabetic, we are using nowadays. And probably GLP-1 alongside phenrenon are promising agents. They are not yet used as a, for everybody kind of, treat the primary disease. And of course, we have to formulate a national program focusing on the regional issues. Thank you so much for the patient listening. This is our university building, and this is the Arabian Sea, part of Arabian Sea, what you can see in Mumbai also. Same sea we'll see in our place also. Thank you so much.
Thank you very much for the presentation. I mean, these screening things you mentioned now, are they also applicable for the pediatric group? The screening group things, are they also applicable for the pediatric group?
Hello. Pediatric group.
The pediatric age group.
In general, I'm not a pediatrician, but I think it should be, because if somebody has a baby has a child has a proteinuria or abnormal creatinine, it should be investigated. But the high risk group definition probably changes in pediatric, because we can't labelize that. For example, diabetes is not very common in pediatric compared to an adult medicine. And probably the other diseases like maybe cystic disease of the kidneys, probably I personally feel probably imaging and doing an ultrasound probably matters a lot in pediatric, because cystic diseases are very common, and probably hypertension may be same in pediatric group. Again, we can't actually recommend. The only thing is choosing the high risk individual changes from adult medicine probably to pediatrics.
That's exactly my second part of the question in terms of the age group in them. So when you discover, because at times it changes with age, there are some asymptomatic proteinuria that you have. How do you go ahead to make that diagnosis in them? I mean, patient just having this asymptomatic proteinuria in pediatric age group. I mean, I just like you said, the stepwise manner.
Yeah, one of the slides which I had shown you that what is the level of proteinuria. If somebody has a proteinuria of more than 500 milligrams per day in adult, pediatric probably they have a different calculation, I assume. He has to be referred to a nephrologist, and plus or minus probably he would need a renal biopsy. But if it's between 300 and 30 and 300, probably you have to keep a follow-up. Once a year you have to reassess. But if the person has a primary disease, for example, if a child has an SLE, then that changes. It actually changes. We have to go by the SLE guidelines or what to do for an SLE. Then you have to maybe more frequently to treat probably.
So in the last part of my question, you mentioned something about the dietary modification. I mean, predisposing factors.
Adult medicine.
In a general view, what are the things that could predispose in terms of the diet, apart from, you mentioned things that could lead to the progression. I mean, what are the dietary things that you think is common generally that could predispose to CKD?
Progression to CKD. Okay, fine. So actually, in general, unless there are diet which is so-called nephrotoxic, I don't think what we consume day in and out is not nephrotoxic. I assume that unless there is something is added. That means if you go for a junk food or a prepared processed food, we don't know sometimes what preservatives to add. So that is the one thing we have to take a concern. Second thing is, of course, protein. So somebody has already a proteinuria, definitely you have to restrict the protein. What is the level of restriction? I already told you, 0.8 or 0.6, depending on the renal disease. So we should not probably eat too much of a protein. This is the only two things which will help in preventing the progression. Whereas other things like, for example, of course, person is obese, you have to reduce the weight. That's a different issue. But otherwise, conventional other food, probably restricting or adding will not have a much effect on the progression of the renal disease. Only the protein plus maybe some preservative which are maybe nephrotoxic. And medications wise, probably have to avoid the drugs like non-steroidal anti-inflammatory drugs, which are over-the-counter medications everywhere available. I think I have not mentioned about that part. So we have to avoid the drugs which are toxic to the kidneys.
Good morning, Professor.
Good morning.
Thank you so much for the insightful presentation. I just wanted, I have two questions, they are just clarifications. I'm Dr. Gideon Chongo from Zambia, an internal medicine physician. On the sodium GRUT2 inhibitors for CKD, is there any specific GFR at which we may not consider using them in a CKD patient? And then the second question is on finerenone. Are we specific to this particular drug, the MRA, or are there any head-to-head studies that have been done to compare finerenone with, say, eplerenone?
Yeah.
To say that any of them can be used, or we are very specific to this particular.
Yeah. Thank you for that question. I'll answer the second question first. His question is whether to use finerenone itself, or there are many other already available MRAs, mineralocorticoid receptor antagonists like eplerenone or spironolactone, which is the original drug. But this study was done on finerenone only. So which actually, why they chose finerenone is one is because it's a non-steroidal drug. Second thing is the chance of hyperkalemia. Whenever you use MRAs in CKD, the risk is hyperkalemia. You're worried about hyperkalemia. So this study, which compared even eplerenone also, which actually did not, the evidence of hyperkalemia, of course, it was slightly high in a placebo control part, but it was not very high. So that is the reason actually finerenone is chosen. Second thing is the mechanism of action. The mechanism of action of finerenone, supposedly, I have not gone to the details of chemical structure and how do they do. It is actually anti-fibrotic and anti-inflammatory versus steroidal MRAs like eplerenone or a spironolactone, which are steroidal drug, and they have other steroidal issues, like for example, side effect of gynecomastia, all those things, but they are beneficial in heart failure. We are not yet sure whether finerenone is also has same benefit in the heart failure. We don't know. So that's why finerenone is preferred here, probably because of less hyperkalemia, less steroidal effect, and more anti-inflammatory effect on the kidney. That's why I told you it's more for a what you call a non-glomerulocentric kidney disease. Even in the diabetic disease, probably it won't be preferred over ACE inhibitors or maybe in even SGLT2 inhibitors, because this drug is more useful probably for a diabetic kidney disease, which is probably tubular disease. So we have to choose correctly the patient. Probably somebody with a massive proteinuria already on ACE inhibitor, I won't probably prefer that. So first question you're asking about is SGLT2 inhibitors, and correct? Yeah, sodium just SGLT2 inhibitors and use in a stage of CKD. Originally, when the drug has came, actually they told actually we cannot use it for less than eGFR of 45. Then they reduced it to 30. We can easily use with the 30 now. In fact, canagliflozin, one study said even 25 we can use, less than 25. But somebody is already on a canagliflozin and developed an ESRD. They say even you can continue that. So in general, 30 for a dapagliflozin, 25 for canagliflozin. If they're already on, probably will continue because the benefits are too good.
Thank you for your presentation. Just this question. Given the fact that elevated creatinine may not be exclusively reliable for kidney disease. What are your thoughts on incorporating these new biomarkers you mentioned earlier? What are your thoughts in incorporating them beyond research and into clinical practice, like in the near future, especially considering their value in the detection of early kidney disease?
I didn't get the question correctly.
I'm saying given the fact that the elevated creatinine might
Okay.
not be exclusively reliable for kidney disease.
Oh, elevated creatinine is not exclusively. Okay.
Yeah. So why your thoughts?
Originally, we are using it. That's what you're asking now. Why we are using additional factors? Correct?
So what are your thoughts on those new biomarkers you mentioned earlier? Like
Correct.
in the future, when do we incorporate them into clinical practice? Because you
Clinical-
mentioned
oh,
that they are
yes,
now
yes.
just being used for research. So what are
Yeah.
your thoughts in incorporating them into clinical practice in the near future, given their value?
Yes. So originally, as I told you, around 22 years when I'm doing my post-graduation, using only elevated creatinine as a marker for this. Slowly, we started using other components like the urine protein, all those things. The newer ones, what I'm talking about, only the two of them we are using. That is, one is called KIM1, that kidney molecule 1. Second one is NGAL. These two are used, but they are expensive. So I don't think they're feasible to use these things for everybody with the mild renal disease to look into that. Still, in clinical practice, if you ask me, I follow only serum creatinine, urinary sediment, and albuminuria. These are the only three things, maybe an imaging. These are the only three things you do. NGAL and KAM are the two which are available in Indian market. There are many other things which I mentioned. They are not yet available, not yet used, only for the research purpose using. NGAL probably lacking a lot of importance. There are a lot of studies on NGAL.
Okay, thank you very much, Professor Sir. Would like to thank you again for this wonderful presentation you've given, and would here like to release you of your duties.
Thank you.
Thank you.
Thank you, everyone. Good morning, all, and welcome to Mumbai and the Tata Memorial Center. So anyway, that's who I am. So I'm a little bit of a disadvantage because I don't know who you are. So all physicians, or do we have some surgeons in the audience? Okay, terrific. Any unfortunate orthopedic surgeons? All right, so terrific. So yeah. So anyway, let's get started. That's how, and this is the first time in India for most of you all, or have you all been here before? Terrific. So, all right, that's how we greet everyone. This sort of became all the more ubiquitous and famous following COVID, where everyone refused to shake hands, and this was how they greeted everyone. But that's how we've greeted everyone for centuries anyway. Right? So this is Mumbai. I hope some of you, or most of you, do get a chance to visit some of the beautiful spots that we have here. We are not really too much of a tourist attraction. We are more the financial hub of the country. But even then, if you know the right places, there are places that you can go and enjoy and watch things. A little bit about the hospital that I work in, and that's the hospital you're sitting in right now. So we are very happy to host you. We've been here for more than about 80 years now. We are currently a 700-bedded hospital. We also have another campus about 40 kilometers from here, which is a large one, and we are expanding much more. We are fortunate that we don't work under the Ministry of Health because of radiation. We work under the Ministry of Atomic Energy. So they really don't understand what we do, and we get what we want. So we see about 40,000 new patients and about 450,000 follow-up patients that visit us every year. The important part is that because we are an aided organization, 60% of our patients are treated free of cost or at a highly subsidized cost. And all of you know that cancer can be a very expensive treatment modality. So this is what really helps our patients and makes sort of what we do meaningful. And being a tertiary referral center, we have patients that travel across a large distance, more than 3,000 kilometers. That's a sort of heat map that shows you where our patients come from. We are centered in this sign, which I have shown you where is Mumbai. So a large percentage, about 30% of our patients come from that local area. But we still get patients coming all across the country carrying this huge burden of cancer. I am an orthopedic surgeon. And for the physicians among you, that's just medical terminology for a glorified carpenter. And right, so that's the tools of our trade. And most of you are aware that this is what we deal with when you have a knee pain, when you have a fracture, when you have backache, and when you have wrist ache, and this is what we do. But courtesy of the hospital that I work in, I deal only with this. We deal with only bone tumors and oncology over here. And bone sarcomas are very uncommon. I mean, here, because of the institute that I work in, we see a large number, but they are very, very uncommon, and therefore they are best treated at specialist centers. And I'll give you an example of how uncommon they are. We look at the pre-COVID era, say 2 years in the UK, and we had 56,000 women diagnosed with invasive breast cancer in the UK. That's 56,000. In the same period, there were 250 women diagnosed with bone cancer. So that is the ratio that we are talking of. That when you talk of them being uncommon, they are really, really very minuscule. And therefore, the specialty and the specialized nature of the treatment makes it best for the patient that they are treated in specialized centers, because experience with them is rather limited. Now, courtesy of the hospital that I work in and the huge population of the country that I work in, we here see a large number of cases. We see close to between 2,000 and 2,500 cases every year. And we operate about 450 to 500 major bone tumors a year. So that is a large number considering any possible standard. The problem with bone cancer is when you let someone know or when you let their family know, the first sort of reaction is complete despair, fear, anger. Why me? What have I done? Because unlike other cancers, there are no inheritable bone cancers. It's not that you have smoked. It's not that you have chewed tobacco. It's not that, and these are generally children. So obviously the first reaction is going to be that what have I done to deserve this? And the anger, fear, despair is part of the problem that we deal with, making the patients accept that, yes, this is a problem, but fortunately it's curable. And this fear largely stems from the thought process that a bone cancer means amputation, means I have lost my limb, a part of me is gone, and I'm disabled all my life. But that, fortunately, is not true nowadays. Yes, amputation is the most merciful of surgeries when that is the only resort. And we still do amputations here for large tumors, fungating tumors, stuff like that. But that is not the only resort now. We do have options. We do have a lot more options. And to use an amputation when those options are available to us is absolutely cruel. And that is why we sort of take these talks to make people aware, because the awareness that limb salvage is possible also needs to disseminate among the general medical community so that they are aware that there are options beyond that and referral can occur to specialized centers. And today, limb salvage is the norm. It is not the exception. It is not the odd case that we are going to be doing limb salvage in. A vast majority of our patients actually get limb salvage. And yes, as I said, amputation is still one of the tools in our armamentarium, but that is used relatively limitedly and for select indications. Now, when we talk about limb salvage, you have to realize that we are balancing two aspects. One is the oncologic aspect. We want to take out the cancer as large as possible so that the chance of it coming back is minimal. Because we leave back, there is no sense or there is no concept of taking out 99% of the cancer, leaving 1% behind, because that 1% will come back either locally or somewhere else. So you have to get the whole thing out completely. And to be on the safe side, we also take out a lot of normal tissue around it. On the other side, we want the functional aspect, that if I'm taking out so much tissue, I need to leave behind enough tissue for the patient to be able to use the limb. Just doing a limb salvage for my surgical ego that I have saved the limb, but the patient is unable to use it, makes absolutely no sense. And so you will realize that these are two things that are inherently pulling in opposite directions. One, I want to take out as much as I can. Second, I want to leave back as much as I can. And it is striking this balance that is critical. That having that balance that yes, you have the least chance of the tumor coming back, but you have also left behind adequate tissue for the patient to be able to use that limb. So when we talk of limb salvage, there are two aspects. One is resecting the tumor. Second is reconstructing that defect. Now, there are certain areas where you don't always need to reconstruct. And I've used the hand as an example. Yes, it is an option and it is an amputation, but that doesn't mean the hand becomes unfunctional, because it's difficult to try and do limb salvage in these areas because the area is such that you want to remove as much of the tumor. So yes, cosmetically, it may look like a poor hand, but the hand still remains functional in spite of there being an amputation. Another region is the scapula. This is an osteosarcoma of the scapula. Now, the scapula is one of the girdle bones where the humerus interacts, and your concept is that if the scapula is removed, you will not get shoulder function. But that is not always true. You can see the scar of surgery. And you can see even after the scapula is removed, if you notice in the X-ray, there is no scapula. the patient is still able to use that limb. So these are areas where sometimes you don't need to do reconstruction, but amputation is not always required. Now, unfortunately, a large number of bone tumors occur close to the joint. And when we have to remove that tumor, we have to actually remove it from the joint. That means you are losing not only bone, you are also losing an articular surface over there. And as I explained earlier, it's important to completely get the entire cancer out. And the best option when you get that cancer out to recreate the skeletal defect and yet give mobility in that limb is putting in a prosthesis. And because these are large prostheses, and as orthopedic surgeons, we cannot use big words, we just add the word mega to it, and we call it a mega prosthesis. All right. Now you'll ask me, what is the big deal? I mean, joint replacements are done day in and day out. We do it everywhere. The difference is when we are doing an arthritic joint replacement, we are only resurfacing the cartilage. The bone is intact. It's like just a lubricating surface. It's like a ball bearing. You're only resurfacing the cartilage. All right. Whereas in oncology, you are resecting large segments of bone. You're resecting large segments of soft tissue. You're resecting large segments of muscle that actually move the joint, and then trying to reconstruct that defect and yet restore function. And that is the challenge. So this video, and in fact, this video is made by one of our patients in whom I did limb salvage. She grew up to be an animator, and she made this from her own experience. So this is how we do. We actually resect that tumor. And this is a modular prosthesis. That means I can adjust the length. I can change the size based on what I've found intraoperatively. Yes, we do plan preoperatively, but sometimes we need to modulate our plans intraoperatively. And the modularity of these prostheses gives us the option of doing that. So you'll realize that a good prosthesis is the cornerstone of any limb salvage program. Now, unfortunately, till about 2 decades ago, this was very easily available in the Western world. Us, we were constrained because we didn't have local prostheses, and these prostheses were horrendously expensive. So about a large percentage of our patients, we couldn't do limb salvage. But fortunately, because of where we work in, we were able to do that. We at the Tata Memorial Hospital developed an indigenous mega prosthesis, which has now been there since I've been there for about 25 years. It costs less than $1,000, which is 1/10 the cost of an international prosthesis. And we've used it and been very happy. We've also been honored with various awards for its integration. We've had, and it's not that the prosthesis just came out of nowhere. A lot of work went into it. There were cadaveric labs, there were engineering studies that we did collaborating with other institutes, and we've been managed to do it. We've published our results internationally, and this is now a globally accepted prosthesis. And it's not only parts of bone, but it's entire bones that can be replaced. You can see this is a cancer involving the entire femur. We've resected the entire femur. We put it back with a large total femur prosthesis, and you can see the function. Yes, there is going to be a little bit of a lurch, a limp because of the muscles that we've removed, but this is infinitely better than what an amputation would have done. Just like the total femur, it's the humerus also. The entire humerus can be replaced by a prosthesis. Generally, what humeral replacements do is create a stable elbow and hand joint. Shoulder function is not very good because you're removing a large part of muscle, but it's given you something that you can use your elbow and shoulder joint. And close to 10,000 of these have been implanted, not only in our country, but in various other areas where there are financial constraints. East Africa, Africa, Asia, a lot of the countries have used these prostheses, and we are happy to sort of share this with them. Coming to that, is a prosthesis always necessary? When I remove the muscle, when I remove the nerve, if the joint is not going to move, does it make sense putting in even a relatively inexpensive prosthesis? This is a proximal humerus. Axillary nerve is removed, the muscles are removed. The prosthesis is only working as a spacer. So do we need to use $1,000 there? And no. So what we have done is just used a simple femoral nail that orthopedic surgeons used to use many years ago, just to sort of fix fractures. And this costs less than $25. And we've done this. And we've published our data and results close to now about 200 odd patients. And the function is excellent. The longevity of this cheap alternative is also excellent, yet the patient has functional use of that limb. There are other innovative reconstructions that in financially constrained areas we need to look at. For example, one is a cement spacer. The ordinary bone cement that we use in any prosthesis, we've used that as a spacer in oncology, primarily in patients who don't have too good a prognosis. So rather than, we don't know, bone cancer is such that just about 50 or 60% of the patients are going to survive. Now, do we need to use an expensive prosthesis when we know that the lifespan could be possibly limited? So in those cases, we have used what we call a cement spacer, where we just remove the tumor, actually just bridge that gap and pack in bone cement over there. So if the patient is a survivor, this can be changed later on for a long-term prosthesis. This is an ordinary cement spacer. When we started doing this 20 years ago, we thought it was a temporary option. We've had some of these patients last 8, 10, 12 years with that. And this becomes critical in certain scenarios. I just put this example because currently this is in the news. I started the limb salvage program in Palestine with the Palestinian surgeons, and there we face challenges getting prosthesis. And that is where we could extensively use a cement spacer to save the limb and actually have these patients have a functional limb without having access to expensive equipment. In children, we face various problems. The bone is growing, the metallic prosthesis is not going to grow. So when the child becomes an adult, you are going to have issues with limb length discrepancy. And this is how it looks like. The tumor and the knee joint, I remove the tumor, I put in a prosthesis, excellent at the end of surgery, everything is equal, everything looks like this. When the patient is 16 and 18, the normal leg has grown, the prosthesis has not. So the patient has a limb length discrepancy. So we have a solution for this. It's called an expandable prosthesis. This was the earlier generation where we actually had a screw which we had to do surgery every time, turn the screw and expand the prosthesis. Now, every time you go in, there is a risk of infection, there's a risk of other complications. So now we have the next generation, which is called the non-invasive expandable prosthesis. You put in a prosthesis at the time of surgery. On follow-up, all you need to do is actually stick the patient's leg into a magnetic coil, which is like a mini MRI. And this is done on an outpatient basis. As the coil rotates, the magnet inside the prosthesis starts to expand. And the prosthesis actually grows. So you can control the amount of growth in the prosthesis. You don't need repeat procedures. And you can do this at your behest when you want it in the outpatient. Unfortunately, horrendously expensive. And even in a center like ours, we use it with limited constraints. And this is an example. You can see the non-invasive prosthesis. And you can see the X-ray on the right showing a little bit of expansion that has occurred. This girl grew up and it obviously expanded much more. But that's the sort of technology that is available to us today, even when we want to use it for children where conventional prosthesis may not work. I talked about heavy metal and hard metal. That doesn't mean we don't use normal biological resources that are available to the human body. God has been very kind and has actually bestowed us with a lot of spare bones that we can use here and there. One of them is the fibula. Okay, when I resect a tumor, I can obviously replace it with a vascularized fibula graft, which incorporates very well. And this is a sort of function that you get after replacing with a fibula graft. The problem, or I'll say one of the issues with the fibula graft is that I need a trained plastic surgeon, someone who can come and do the microvascular anastomosis here in this hospital. Yes, available to us, may not be available everywhere. So what we have done is actually devise a process where even that can be removed. In the areas which have two bones, for example, the forearm and the leg, once we resect the tumor, we just need to do an osteotomy of the fibula and move it medially, keeping the soft tissue intact. You do not dissect the bone out separately on the table. You just push the bone medially. And because all the soft tissue is intact, it remains as a vascular structure and actually gives you a vascular bone without the microvascular anastomosis. And you can see this is a postoperative X-ray, how large the fibula has become. Over a period of time, it is actually hypertrophied to look almost like the native tibia. And that's what a vascular graft does without the microvascular anastomosis. You can use it as an intercalary spacer where the joint is not involved, or you can use it for an arthrodesis like we have done here. Also, like most Asian African countries, we have a problem with a cadaveric donor program. We don't have access to allografts. I mean, or we have limited access to allografts, let me put that. Otherwise, allografts in European countries, and I have Roberto from Italy who's working with me, they have an excellent allograft program. They can get allografts at the drop of a hat, size match, whether you're 6'2" or 4'4", they still have an allograft in the bank to match that size. We face a problem. We don't have such sort of infrastructure. We don't have that. So what have we used instead of that? There is a technology where you can actually remove the tumor bone, re-sterilize it, and put it back in the same sitting. So yes, it's a dead bone, it's an allograft, but it's size matched because it's your own bone. For example, take this tibia. We've done a resection. Okay, we wrap the bone in sterile surroundings. We send it down to our basement where we have a radiotherapy facility. Don't worry, that's the audio of the radiotherapy machine. You're not doing anything. All right. All right, so it gets radiated. And it comes back to us 45 minutes later, and we put it back. So it's the same bone, but now tumor-free, radiated, put back. So it works like a size-matched allograft. And you can see this child's function. This is a video taken 10, 12 years ago. He's now grown up to become a medical doctor doing very well. Okay. And this is not the odd case. We've published our data. And because, as I said, the numbers, we see this is one of the largest series in the world where we've shown that the 5-year graft survival is 85%. That means 85% of these grafts have lasted beyond 5 years. And once they last beyond 5 years, then generally they sort of last like normal bone. Your failure rates are maximum the first 2 years and a little bit after that. But we talk about 5-year survival because once they cross that benchmark, then the decay and the amount falling is very less. Now, just because I talk about cost-effective care and being sort of, cost conscious, doesn't mean we spurn technology here. We are as advanced as anywhere else. We use it a little more sensibly. All right. We have special printed plates, 3D printed plates. That is the in technology. That sometimes we want special plates. The conventional plates will not work. And we use that. Why do we use that? Because in a child, like you can see, I want to save the epiphysis for growth. I need a special plate that will actually grip the bone. Yet after my resection, I'll be able to save the physis so that it can grow. And we have access to this 3D printed technology where we make plates like this and actually put it back. We use navigation, just like you use it in your car or anywhere else. We use it intraoperatively. When we have technically difficult resections, where I want to keep back part of the bone, yet I want to make certain that I've got the full tumor out, we use intraoperative navigation to use that. This is how we resect the bone. This is another technology where we re-sterilize the bone, as I showed you. I showed you radiation. We also have liquid nitrogen, where we dip the bone in liquid nitrogen. It kills all the tumors and we can put it back. So this is a hemic part of the bone removed, sterilized, again, intraoperatively with liquid nitrogen, put back. And once you've seen on follow-up, you can barely see where the osteotomy is and the patient is united. Pelvic tumors are a huge problem, not only for surgical resection, but even for reconstruction. And they are, actually, I'm pretty young. Every pelvic surgery ages a surgeon by 6 months. So I'm actually 25. I look like this because of the amount of pelvic surgeries that we've done. All right. And reconstructing the pelvis is a challenge when the acetabulum is involved, because all of you being physicians will realize that the entire lower limb is actually supported on the acetabulum. And if I take out the acetabulum, the problem with radiating bone and putting it back is the articular cartilage fails. So where an articular surface is involved, you can't do that. If you remember, if all the examples that I showed you was where it was intercalary, where the joint was not involved. If the articular surface is involved, the cartilage will die because of radiation. You will not be able to get the sort of function that I showed you. And so pelvic tumors is a challenge where we have to balance both stability and mobility. Now, these are the sort of metallic monsters that you will see that are generally used to construct pelvic tumors. The problem in a country like ours, possibly even in Africa, is that sitting cross-legged and squatting is an inherent part of our culture. Once I put in a metallic prosthesis like that, there is no way that a patient can use a squat for a toilet. They need a Western style toilet. They cannot sit on the floor. They cannot sit cross-legged. So brilliant. As a surgeon, I've done a great job, but functionally, has it really helped that patient? Has that patient been able to go back to normal life is what we need to question. And so we looked at different alternatives and we did what is known as a pseudoarthrosis or a hip transposition. What it means is we actually don't reconstruct. We just put the femur back to whatever is the residual bone that is left behind. And we anchor it over there. Sounds unbelievable, but as I said, God is great, the body is great. In spite of us, these patients have function. This is a young child with a pelvic tumor. I have removed that bone. What I've done is reconstructed it back, and you can see on the right side, just lashed it back there and held it in place. That is the child's function. This is about a year post-operatively. This is 19 years post-operatively. I don't know how many of us can do this. And it's not only children, it works in adults as well. You can see the entire hemipelvis has been removed. There is no pelvis over there. All right, so I've shown you many options for reconstruction, both technology, metal-based, biological reconstruction, and it can get confusing. So what is the right choice for this patient? There is no one correct choice. The correct choice in my situation may not be the correct choice in your situation. The correct choice for a manual laborer may not be the correct choice for someone who's an executive sitting on a desk 12 hours a day. So there are many factors that we need to consider. It's the amount of bone that is removed, the amount of tissue that is left behind, the age and health of the patient, most importantly, the patient's lifestyle and expectations. You cannot have the same menu option for all patients. And as important as all this is the infrastructure that is available to you and the honesty of the surgeon. What is the surgeon comfortable with? These are, according to me, the two most critical factors when we contemplate reconstruction or limb salvage. We try and achieve what we are not supposed to do, we have problems. Now, what I've showed you is an advertising film. It's only my good results. I have more than this share of bad results, right? So we need to be honest about it. We need to counsel our patients that there are complications. We'll go through it together. It's not always going to be one rosy path. Yes, if it is, all of us are very happy. But unfortunately, this is such a field that doesn't happen always, right? So you have to customize the product for the customer. It's an individual answer for every patient, right? So as a surgeon, I have now achieved great things. We have overcome all these challenges. But does that mean our role is over? No, there are many other challenges that we face, and all of you as community physicians actually there are also part of it. There is a lot more that we need to do. We need to increase the awareness. We need to educate both the medical community and the common population that this is our options that are available to us. With that, we at the Tata Memorial Hospital have actually put in a summer school for budding oncologists. That means we take MBBS students, we take undergraduate students, they come in by a competitive exam. We keep them here for 6 weeks. We expose them to what oncology can do. Hopefully, this way we convince a larger crowd to come into oncology because that is the need of the hour. We know that oncologists are in short supply anywhere across. So we do that. We've been running this for close to 6 to 8 years. And actually, some of these people have come back and joined us as residents and matured into faculty as well. So that is something all of us need to take responsibility about. We need to standardize treatment across the country. Doing the best in this one institute alone is not enough. We need to have the same standards that are applicable across the country, across various countries. And we have, I don't know how many of you are aware, we have something called the National Cancer Grid over here, which incorporates 290 hospitals across the country, which have access to libraries, which have access to all journals because of they are connected. We have standard treatment protocols. Now, whether they are followed or not depends on the individual institute, but at least an effort has been put into place to see that all this comes together. We need to evolve guidelines that work in our situation. What works in the Western world, expense, etc., all needs to be balanced. Does not mean I'm not saying that is incorrect, that is wrong, but always you cannot directly import what is happening there to our sort of scenario. So we need to do that. And we at the Tata Hospital have actually taken steps. You will have access to these. These are available. The evidence-based guidelines are published by our hospital every year in various specialties. We have the Indian Musculoskeletal Oncology Society. We've published our own guidelines. So these are guidelines. These help people to take informed decisions as to what can be done in a situation that may be less than ideal. And all of us need to do that. But most importantly, we need to remember that in oncology, treatment is a team game. All right, it is not one person alone that is going to be able to achieve this result. All of us need to interact, talk at every possible issue if we want to achieve the best possible results for our patients. But as I said, you need to continue to dream. Things are good, things can improve, and we won't discover new oceans unless we have the courage to lose sight of the shore. Thank you very much.
Thank you very much, Professor Se, for this great presentation. I'm not so sure how many showed hands that they are surgeons. Lovely. I'm an aspiring trauma surgeon, so listening to this, I was really, really excited. Aspiring trauma surgeon because we have one of the highest ranked trauma countries in Africa. So yeah, indeed, our glorified carpenters, this was really exciting for me to watch and listen to. Before I give the floor to the attendees, I just have a question. This is on irradiation and the reimplantation of the bones. Have you by any chance had a case of recurrence?
Yes. So it's not that, but the recurrence has come in the soft tissue, not the radiated bone. And it's not just us, there's enough global literature to show there will be a 5 to 7% recurrence in any oncology. Whether I use a metallic prosthesis or whatever I use, there is an inherent risk. And we've had about the same percentage, but the recurrence has always been in surrounding soft tissue, not in the irradiated bone.
Thank you very much. I would like to give now the floor.
Thank you so much, Professor, for the presentation. Oh, I'm Dr. Sylvester Ntachi from Malawi. I was more interested on the non-invasive expandable prosthetic. My question comes, the extent, is there a limit to the extent that we can expand, considering that tissues and everything, the muscles, the vessels, is there a limitation on that?
So there is no limitation based on the tissue. The speed is limited. The extent is not. The extent is limited by the amount of bone that you have resected. Because if you have resected 7 centimeters of bone, you will only be able to expand another additional 2 centimeters because the telescoping material is actually in that main graft. If you resected 15 centimeters, you will be able to extend much more because it can telescope more. So very often, these have to be revised multiple times that they have reached the limit of their extension, yet there is limb length discrepancy, and we need to revise it more. And involved costs are quite prohibitive, and that's the reason why they are in relatively limited use. But there is no limit based on the soft tissue. We do not expand at very fast rates. At any given time, we never expand more than 4 to 8 millimeters. Then the patient is given a 6-week break to actually get back function and then come back in another 4 to 6, because no soft tissue, or more important than soft tissue, the neurovascular structures will handle more than 4 to 6 millimeters of lengthening at any one stage.
Thank you very much, Prof. Dr. Aditola. I'm a pediatrician. However, if I had met you earlier, maybe I would have been a orthopedic surgeon. Because what we know them to be in medical school is pulling and hammering and everything. You have 8 hours.
That part has not changed too much, but the rest of it is also exciting. We still do pull and hammer, don't worry.
I've always believed that orthopedic surgeons should be muscular and have these big things. Thank you very much for that. And I think the lecture was practical, and looking at those animation and everything, even your lecture should be in the middle of the night. We won't even sleep. Thank you. However, I want to ask, based on what you said just now, it's so sweet and the story is so good that I don't think any patient will have to go through amputation. So in other words, my question is, what are the indications for amputation? So in a patient?
Let me put it very simply. You are an oncology surgeon first, you are an orthopedic surgeon second. If at any time you are compromising your resection because you want to make a good reconstruction, is when you do an amputation. Oncology comes first. There is no negotiation in that. Unless I can get out enough tissue to make certain that I have removed the cancer adequately, you do not contemplate a reconstruction. Second part is, have I left back enough tissue? As I said, having surgical ego, yes, I've done limb salvage with a functionless limb, makes no sense. Today, even post amputations, you can see the sort of prostheses that are available. People run in the Olympics with bilateral amputees. So you have to strike a sensible balance. That am I actually, finally, it is doing justice to the patient. Would an amputation be better for this patient against the limb salvage? That is the question that you need to ask, and then you decide. But having said that, in both your country and ours, we still get patients coming to us late. Fungating tumors, multiply recurrent tumors, where I cannot do an oncologically safe reconstruction. And then irrespective of what the patient, no patient wants an amputation, irrespective of what the patient wants, you have to be honest with yourself and the patient and say, no, this is a case for an amputation. So in spite of working in what is a world-class center, one of the top units of the world here, we still do 20% amputations in the bone tumors that we get. My limb salvage is 80%, 20% are still amputations.
Thank you. You've answered my second question. Most patient comes in late stage.
Yes.
Late stage. And sorry, you mentioned there's something about the price for those implants and other things. What's the average cost for surgery in case? I know you have to individualize the patients, just like you said, like the toothbrush and everything.
So I am a little unaware. I mean, the cost outside this institute can vary from anything. In this hospital, there is no surgical charge. The patient pays nothing for surgery. And also because we've been fortunate enough to get corporate grant donations. And that is something that all of us need to learn. We are not trained for that.
So
as to how to
international
approach
patients too.
International patients, unfortunately, will have to pay because this is a Government of India hospital. So that part is not something that is in my hands. But this is a Government of India hospital run by the taxpayers of the Indian taxpayers. And so international patients do pay. But having said that, I'm just saying, if an international patient comes here compared to one of the corporate hospitals in Mumbai, you would pay about 40% of the rate of what would cost you there. So it still becomes relatively affordable even for them.
Thank you very much, sir. One last question. You didn't answer, I just want to know, because we have some cases that you want to refer back, probably we would get in touch with you. But I've had issues about referring patients to India for surgery.
Yes.
There are cases in which you send them to India for surgery, and probably, just like you said, the surgeon needs to be honest. I'm talking about even leukemia or things. The patient will develop complication subsequently. When they are to come back again, they have to pay all over again. Now, do you have insurance policy, agreement, things with those patients? Like, you've been honest. It doesn't mean everybody is that honest. So what do we, where do we go from there?
Again, to be honest, I'm a little unaware of what can occur outside this hospital because all my life I've worked in a hospital like this. We're fortunate enough to do that. But I am sure there must be international insurance policies that actually can take care of this. But as you said, and I'm talking of this hospital, we have an international cell. We have a cell here of public relations that if you ever want to refer a patient, you are not getting in touch. You can get in touch with an individual doctor once you've established a relationship. That's a different issue. But there is an official cell here that you write to them. They, in fact, facilitate your visa. They facilitate other issues so that you have the documentation to come here. They even create a teleconsult before you come here to make certain that it is worthwhile you coming here rather than you coming all the way here and me telling you that you need an amputation, which could have been done as well in your place itself. So there is a facility in this hospital. And once you're done with this, maybe somebody from here can help you get in touch with them and can share all the information with all of you. So that would make life a little easier for the referring physician and the patients as far as this institute is concerned. Sure, any amount.
Thank you, Prof, for the presentation. I actually forgot that I'm an orthopedic surgeon.
Terrific.
I was amazed and surprised with the innovations that you have here. It's a shame that. Oh, okay.
You're the gentleman from the Philippines, right?
Yeah, I'm Michael Saturnino, and I'm an orthopedic surgeon in the Philippines. It's a shame that I didn't consider tumor surgery for my subspecialty, but I do joint replacement. I'm an adult reconstruction specialist. Now, in the Philippines, admittedly, there's a shortage of tumor surgeons, which makes amputation the norm and not the exception. So, yeah.
Having said that, actually, you can listen to me again in Manila in 15 days from now if you're attending your national meeting.
Oh, see you there, Prof.
Right.
And then rest assured that I'll be spreading your talk and you personally to my colleagues, and they might consider doing tumor surgery. Now, Prof, do you have bone integration prosthesis here in India? And if you have you compared the results of these cases to those you have reconstructed?
So there are two types of bone integration prosthesis. One is the uncemented prosthesis, which actually the stem incorporates in the medullary canal. All right. We don't use that here because our patients are receiving chemotherapy, radiation. The ability for bone integration to occur when you're receiving concurrent chemotherapy and radiation is challenging. And so we don't use that. We need a better hold. We use cemented prosthesis. Having said that, you have a hydroxyapatite collar, which is there at the bone prosthesis junction. So the international prosthesis actually use the bone prosthesis, use that hydroxyapatite collar and to incorporate bone. And those have had good results. With the indigenous prosthesis that I showed you, we did start incorporating a hydroxyapatite collar. Unfortunately, at that time, the technology didn't exist here and we had to send the prosthesis overseas to get that collar incorporated. It really bumped up the cost and therefore we dropped that idea. So we don't currently use it, but that is an option that is available and can be used. You can have longevity of the prosthesis once you have the hydroxyapatite collar with bone integration at the bone prosthesis junction.
Thank you again, Prof.
You're welcome.
Hi, I'm Dr. Maan Pakulan. I'm a general surgeon from the Philippines too. I'd just like to ask if there's a possibility of doing delayed reconstruction for limb. I'm not sure if that could still be considered a limb salvage, but what if you could, for example, a radial fracture and you need to remove the bone and maintain the limb? Is it possible to do a delayed implantation?
Yes. You delayed implantation of what? The radiated bone? No, how are you talking of delayed?
I usually encounter patients with multiple fracture and what seemed like a non-repairable limb. So what we do in the province, because it's sometimes difficult to transport patients in islands because we have 7,105 islands, and going to a city with a capacity to cure the patient is almost close to impossible. So within 24 hours. So I was wondering if you could leave the limb as is and do replacement or...
Absolutely. As long as you have stabilized that limb and the vascular structure, more than the neural, the vascular integrity is maintained, reconstruction can be done at any time. It doesn't have to be done immediately. In fact, maybe some of the recommendations would be that we stabilize the patient because these surgeries are long. You can have extensive blood loss in them also. So I think in your scenario, what you're saying in a polytraumatized patient, it would make more sense to stabilize the patient, ensure that alignment and vascular integrity is maintained, and do the reconstruction at a later stage when you can shift the patient to maybe a more advanced center that has this capability. That's not an issue at all.
Okay, I'm sorry for the follow-up questions, Professor, but what about if there's a tumor and can you resect it and leave it as is and do reconstruction when you can?
So that's what I showed you. We remove the tumor. We actually just put in a cement spacer. Whether you need to fix that or not is a different issue. You need to put in a cement spacer. The issue why we put in a spacer is because the body is so phenomenal that if you don't put in anything, fibrosis will close that gap. And then you will never be able to recreate the gap to put anything back again. So you don't need to do any of these fancy reconstructions. All you need to do is just ordinary bone cement that you use. Once you have the defect, shape your bone cement exactly like that bone which you removed so that dead space is created and then reconstruct at a second stage. No issues at all. We do that here as well.
Thank you so much.
You're welcome.
Prof, sorry, just popped into my mind. With the extensive surgeries that you're doing, do you have also problems with infection?
Oh, yes.
And how do you address those?
So just in conventional joint surgery, you would be killed if you had an infection rate of, say, more than 1% or 2%. That's what the accepted norms say for joint replacement. In oncology, the acceptable rate is close to 10% because these patients are immunocompromised. One, you are doing extensive surgeries that last more than 3-4 hours. Very often you are replacing one whole body volume, even in blood loss. So besides taking the sensible norms that any surgeon should do, we need to remember that our antibiotic protocols need to be sensible. We do not use extensive antibiotics, say for 5 days or 7 days. That doesn't make sense. But when you have lost more than one body volume, when surgery is extended beyond 2 and 3 hours, you need to see that your perioperative dose is augmented. You have given that at that time. And then you have to take sensible precautions. That's all. But infection rates of close to 10% are the norm. And it is a big problem.
Okay. Thank you very much, Prof, for the presentation. I am Kitabu Jame from the Gambia. Mine is a non-surgical question. I'm just a bit curious here. You said most bones on the tumor occur around the joints. Any risk factors for this?
Sorry, any?
Any risk factors? Anything identified to be responsible for this?
So there is a genomic consortium called the International Sarcoma Consortium that is now looking at whether there are possibly inheritable mutations that occur. But as of now, if you want a ballpark figure, no. Unless you have a retinoblastoma or some issue like that, those small cases can have subsequent osteosarcoma, a Lee-Fromeni syndrome. But the majority of bone tumors, you will not have an inheritable factor. You will not have an environmental or a causative factor.
Yes, it follow. Because you mentioned most of them occur around the joints.
Yes.
Why is that?
That's because the metaphyseal area, it's in the metaphyseal area have increased vascularity. And that's also what we say in children. There are various hypotheses. Possibly it's because of an increased blood flow in that area during their time of skeletal growth. And that's why they occur in the metaphyseal areas.
Good morning, sir. I'm Dr. Carlo Bordon. I'm also from the Philippines. I'm a general surgeon.
All right.
I don't do bone surgery, of course, but I oftentimes receive patients with bone tumors, which I refer to orthopedic surgeon. My observation is that, as always, it's always a locally advanced stage. Actually, I have a colleague still alive now, but already metastatic, and knee osteosarcoma, underwent also knee replacement. The first presentation was just knee pain, which he contributed to his weight gain. Anyway, like other cancer, is there a screening protocol for bone tumors like colon cancer, colonoscopy at 50, breast cancer, mammography at 40? Is there any?
Absolutely not. One, I'll just tell you, screening also, I mean, let's look at breast cancer. I'm using that as an example. There are huge questions raised as to whether we need to do screening in breast cancer in women less than 50, more than 50, etc. Because any screening protocol also has to be cost effective. Now, as I showed you, if there were 250 women over a 2-year period in the entire UK who got bone cancer, would you screen the entire UK population to try and pick those up? It doesn't make sense. And there is no way. Actually, the good part is that now, if it's nice that I'm talking to a medical audience, so it's not misconstrued. Pain is one of the first critical signs of a bone tumor or a soft tissue tumor. So you have to be sensible. Now, if you talk to a general audience and every small pain, which all of us get every third day, they would race to a doctor. That doesn't happen. But you need to be aware, and the awareness in the community has to be created. And that's what I spoke about education. I mean, I'm just saying you are more likely as general physicians to see a soft tissue tumor than a bone tumor. A good thing to remember is anything more than 5 centimeters needs a referral to an oncology center. So if you have a mass, a soft tissue mass more than 5 centimeters, refer that to a specialist, let them have a look at it. The concept of a chronic hematoma is only mythology. It never exists. It does not exist in this world. You know, a chronic, I have had intelligent people come to me, and these are software engineers who have a lump on one biceps. And I say, you didn't come earlier? No, we were going to the gym and we thought that this is muscle. Did you ever think why muscle was only developing on one side, not on the other? No. So there is no explanation. There is no, as Einstein said, 2 things are infinite, the universe and the human stupidity. And I'm not really about the universe also, I'm not convinced. So there is nothing that you can do except educate, re-educate, and try and reinforce the message. But screening is not for bone or soft tissue cancer. Doesn't make sense at all.
Professor Puri, sir, it was an honor having you here.
Thank you very much. My pleasure.
Not only was your presentation very interesting, this was such an interactive, and clinically inspiring and stimulating. Before I just release you and give over to Dr. Kingsley, I would like to announce that after this, we'll take a 5 minutes break, coffee break, ablution break.
Okay.
Yeah,
I hope you'll get to see the city a little bit. This is actually, I mean, it may not seem so, but between November to February is the best time to visit Mumbai because the weather is relatively better. Unfortunately, we're having a little bit of a heat wave and it's pretty hot nowadays. But if you're from Africa, that shouldn't bother you too much. So no, that shouldn't really be too much of a problem. So, but it's a nice place. Get a chance to walk around. It's a safe city, no issues. So thank you so much. Bye, everyone. Have a nice time. Get a chance.
So welcome back to our sessions. Thank you, Dr. Selma and Dr. Kingsley, for starting the event. And now to move to our third speaker. Our third speaker is a magical person with healing hands. He is known for his gentle touch and his ability to get into the roots of the problems. He is an associate professor of Grant Medical College and a consultant at Bombay Hospital, Bridgekandi Hospital, PD Hinduja Hospital, and the Tata Memorial Cancer Hospital. He also serves as an honorary hematologist to the governor of Maharashtra. I hope I pronounced it well. So his topic of discussion today is common skin cancer, warning signs, and misdiagnosis. Welcome, Prof. Kumar.
Thank you for your kind introduction. Very good morning to all of you. And I'm sure already 2 sessions has been done. So not so tired. It's not before lunch, but I am a little in a hurry because the session is running half an hour late and many patients are waiting at my hospital. So my introduction has already been made. And I came to know that few of you are internists, some of you are dermatologists and from other specialty from different countries. How you are finding our country? And especially the Mumbai. I compare Mumbai with the New York, It's a very vibrant city. And I'm staying in a part of Mumbai called Bandra. So must visit Bandra for many reasons, including Shah Rukh Khan and Salman Khan, the Bollywood celebrity. And it's in a coastal region, and you may get a glimpse of Mumbai's life and nightlife both together. So coming to my today's topic, common skin cancers, warning signs, and misdiagnosis. Yesterday I became professor, so that's why I'm putting my designation as a professor. My questions to all of you, why is it important to diagnose a skin cancer? Anyone? Not so aggressive. Cosmetic reason is one reason. Yes. Some of the skin cancer may be dangerous or metastasize. So it is preventable. So once you diagnose in an early stage, it can be treatable, and the patient aesthetics as well as a chance of getting metastasis can be prevented, and it is treatable. Just to bring your knowledge back to your basic science, this is the skin with the 3 layers, the dermis, epidermis, dermis, and subcutis. The epidermis has 5 layers. Dermis has sweat glands, blood vessels, and hypodermis has fat cells. So today we are basically going to discuss about these cancers. And as my topic is common skin cancer, so what I am seeing in my country, I am going to tell you about that. So skin cancers are broadly classified into melanoma or non-melanoma. Non-melanoma, you have a basal cell carcinoma and a squamous cell carcinoma. This is how you can see. This is the melanocytes. This is squamous cell carcinoma, basal cell carcinoma. When it involves the melanocytes, melanoma. Fortunately, in our country, we hardly see melanoma once in a blue moon. Once you diagnose the melanoma, you have to be highly certain. So today I am going to discuss only about basal cell carcinoma, squamous cell carcinoma, and what are the pre-malignant dermatosis which leads to basal cell carcinoma or squamous cell carcinoma. The golden rule of, as I said earlier, the golden rule of treating any cancer is hit it early, hit it hard. And you'll surprised to know that there are many textbook available on skin tumors, a practical guide, solutions, cancer of skins, ABC of skin, multiple. Once you search in Google, you will get at least 1,000 textbook written on skin tumors. 1,000, I mean to say 1,000 textbook written on skin tumors. These are the few books which I follow. And so this I am going to discuss today. Why it is important, we have already discussed. So coming directly to pre-malignant dermatosis. So when it arises from the keratinocytes means the epidermis. The factors we are going to discuss, it leads to basal cell carcinoma or squamous cell carcinoma. So the epidermis is mainly formed of how many cells? Anyone? Mainly keratinocytes and melanocytes, the two cells, keratinocytes, melanocytes. Melanocytes imparts color to our skin, and keratinocytes has a different function, including a barrier function. Melanocytes, some of the factors when operate with the melanocytes, it leads to melanoma, which I am not going to discuss today because we rarely see in our clinical practice. And it's not possible to discuss melanoma in a half an hour session. So what are the precancerous keratinocytic lesions? Anyone? Precancerous keratinocytic lesions, the common benign tumors of the skin, which arises from the keratin. Any idea? So these are actinic keratosis, which basically a keratosis arising on sun-exposed area. Arsenical keratosis, when you ingest arsenic, which I am coming later on. Thermal keratosis, when a person is getting exposed to different kind of temperature. Hydrocarbon exposure. Chronic radiation leads to keratosis. When we give radiotherapy in different cancers, we get a reactional keratosis as well as a radiation keratosis. Uva keratosis, when we treat skin condition like vitiligo or psoriasis, with a cumulative exposure, they may develop a uva keratosis. Bowman's disease or carcinoma in situ or squamous cell carcinoma in situ. Different type of virals play a role in keratinocytic lesions. The most common virus implicated in skin tumors are human papillomavirus, and that may lead to Benoit papillosis, epidermodysplasia verruciformis, that is a genetic condition, and Buschke-Lowenstein tumor. It is nothing but a giant condyloma acuminata. These are other precancerous lesions which I am going to discuss right now. And in oral cavity, leukoplakia or erythroplakia. So actinic keratosis, also called solar keratosis, is mainly occurs in middle-aged elderly people between 60 to 70 years of age. Males are more affected than females, and Caucasian skins are more prone to develop this actinic keratosis than the other skin type. White population, prevalence is 40%. The most of the white population, if you see, you will get a seborrheic keratosis. 40% is a under percentage. You may get it in 100% cases after 60 years of age. Some or other form of actinic keratosis. And it may lead to squamous cell carcinoma in 60% cases, basal cell carcinoma in 30%, and carcinoma in situ in 12%, and invasive melanoma in 6%. How it looks like, you just see it, is very common. It looks like a pasted skin, something pasted on the skin. So you feel that you can remove it, but it is not removable. So it is on the upper part of the epidermis in the keratin or in stratum corneum. The close-up view of the same. See how it looks like. Skin color to dark pigmentation and with some scales. And here in the histopathology, you can see this basal layer. This is a normal basal layer which is parallelly arranged to the basement membrane, gets disturbed in case of actinic keratosis. This is how it looks like on a scalp. Another photographs, pain with inflammation. And nowadays, after 2005, we started using dermatoscope to better visualize the lesions, which magnify your lesions to into 4 to into 100. So these are the dermatoscope instruments. We use it in case of many cancer, including pigmented lesions. And they look like the actinic keratosis look like a strawberry appearance. So other clinical variants, the same. Once the actinic keratosis become inflamed by any means, it is called inflamed actinic keratosis. Spreading pigmented actinic keratosis, proliferative actinic keratosis. These are the different subtype of actinic keratosis. What are the risk factors for actinic keratosis? Anyone? What are the risk factors? The one most common risk factor for any cancer on the skin? Sun. The sun and the UVC light. This light is, and where is the ozone hole? Ozone is depleted in which part of the earth? It's in Australia and New Zealand. So the skin cancers are more in that part of the globe because of the sun. UVC lights are reaching into the atmosphere. It is blocked by atmosphere UVC. UVB causes skin to darkening, and this reaches most, and it may cause cataracts in long-term exposure. These are the another risk factors: being older, being male, having fair skin, living close to the equator, being exposed to the sunlight, and have a family history of actinic keratosis. They are more prone to develop actinic keratosis, and it's more common in compromised immune system like HIV, or a person on immunosuppressive drug for a prolonged period of time, especially the cyclosporin and methotrexate, they may develop actinic keratosis. So what is very important in actinic keratosis? Actinic keratosis as such is a pre-malignant condition, but nothing to worry, non-serious, but you have to look it carefully. And if there is any change in existing actinic keratosis, the person should report to the nearby medical center for further diagnosis and management. So observation is very important in case of all pre-malignant condition, which you know. So you tell your patient in a very guarded manner, don't scare them. Many a times what happens, they get scared after listening the term cancer, you know, or precancerous. Even you say precancerous, you tell that it's a normal thing, but you should report if there is any change in this. And best way to see it by documenting. So take a photograph of that lesion, keep it with the patient, and patient will report back if there is any changes in the skin. Now coming to arsenical keratosis, this is because of the chronic ingestion of arsenic. Certain part of the world, including our West Bengal or Bangladesh and some part of Taiwan, the well water or tube well water is contaminated with the arsenic. So they develop this arsenical keratosis, which is similar to actinic keratosis, but they are more prone to develop squamous cell carcinoma rather than basal cell carcinoma. So regular follow-up for every 6 months is required. This is how it looked like: keratotic lesions on palms and sole, the acral part of the body involved in arsenic keratosis. And along with that, they have a dyspigmentation. Dyspigmentation, I mean to say, it's a mosaic pattern. If you see at the hand, the earlier lesions before keratosis, they may have a dark spot and white spot on their palms and as well as on the trunk, also. That is a hallmark of arsenic poisoning, and the latency is from 6 months to 10 years of ingestion of contaminated well water with arsenics. With this, I am coming to a next pre-malignant condition. what it is? Anyone from the audience? Very common, a cancer on the scar, marjoline ulcer. The chronic scar, something, some irritation on the scar for or friction or some sort of any chronic disease on a scar, they may lead to squamous cell carcinoma and they have a high potential for metastasis. So they should be dealt immediately once you deal with it. This is another photograph where you can see the marjoline ulcer, highly aggressive tumor with rapid rate of regional metastasis. Another picture in another patient. These are very warning signs so that you can refer this patient to a nearby oncology center for biopsy and further management. This is a scar on the finger where a person is developing marjoline ulcer or squamous cell carcinoma. And here it is not obvious. So you should be high index of suspicion is required to prove that the person is developing a squamous cell carcinoma. Another pre-malignant condition is Bowman's disease, which is also called squamous cell carcinoma in situ or intraepithelial carcinoma. Affected age is elderly, of course. Females are more affected in Bowman's disease than the male, white population. Progression to invasive carcinoma is 3 to 5%. This is how it looks like. Any scaly plaque which is tender or recently become itchy or become painful and started oozing, you can suspect a Bowman's disease, and the diagnosis is confirmed by taking a skin biopsy. These are the predisposing factors like other skin cancers. This is how it is look like on the leg. Management, I am not going to discuss. This is not a part of my topic. This condition, epidermodysplasia verruciformis, this is a inherited condition. Sometimes it may occur as acquired when a person is on chronic immunosuppressive treatment. This is an autosomal recessive condition. And these are the genes so responsible for this condition called epidermodysplasia verruciformis. Why it is important, why I am going to show this? Because many a time our internist friend or internal medicine people diagnose it as a pityriasis versicolor. I'll show you some pictures. See this picture, it looks like seborrheic pityriasis versicolor. Sometimes I also miss, but nowadays I'm not missing it. It's an earlier part. When you see this patient casually, then you diagnose it and landed up with a pityriasis versicolor. But once the patient is not responding to the pityriasis versicolor, you relook into the picture. See, these are look like a pityriasis versicolor. Very common skin condition, fungal infection with a mild fungal pityrosporum ovale. Very common in skin of colors. But when you look it carefully, see some of the lesions are elevated, So when the lesions are elevated out of proportion to the pityriasis versicolor, start thinking of epidermodysplasia verruciformis and do the biopsy and it will confirm your diagnosis. The 3-man. This is a severe form of epidermodysplasia verruciformis, the severe form. The patient may develop warty lesions on palms and soles. See the soles and palm. Another picture. See how severe it is. Everything is in the stratum corneum and epidermis. The peculiar cytoplasm, grayish bluish cytoplasm, or you can say coilocytes, which is a typical of epidermodysplasia verruciformis. I always tell my students, so whatever the name is, you just decode the name. Epidermo means skin. lysis of the skin. Epidermal dysplasia. Dysplasia is something going on in an aberrant way. And verruciformis. Verruciformis means varicose lesions. So varicose lesions like this. See, this is the histopathology. And see, this is a projection. That is a verruca. Verruca vulgaris. It's a large form of verruca vulgaris. Verruca means projections. Now coming to pre-malignant male genital dermatosis. These are the pre-malignant male genital dermatosis like erythroplasia of Curat, Bowman's disease of penis, or binoid populosis. This is erythroplasia of Curat. You can see the redness, unusual redness appearing for a longer period of time. And HPV 8 and 6 are responsible for erythroplasia of Curat and Bowman's disease of penis. This is a Bowman's disease of penis. You can see the scaly plaque, which I showed you earlier. And this is binoid populosis. Many a time in my private practice, people come for this and they are very worried. And they ask me, sir, what to do for it? It may be cancerous. Can you do a biopsy for me to confirm it? However, it is benign because it's caused by 16 and 18. And it has a lesser risk of developing any cancer. And it's most common in young and sexually active male or female. So these are the benign lesions, but they are pre-malignant because rarely they turn out to be a squamous cell. Rarely. These are the risk factors. White lesions over the glands and shaft of the penis. This shaft of the penis and glands, these white lesions. Anyone, what could be the diagnosis? Very common skin condition because of chronic inflammation, long inflammation, especially in diabetic male, candidal balanoposthitis, chronic candidal balanoposthitis leads to this condition. This is called male genital lichen sclerosus at atropicans. The end result is BXO, that is balanitis xerotica obliterans. Balanitis means inflammation of the shaft of the penis or glands of the penis. Xerotica means dryness, and obliterans is squeezing out your penile shaft. It's common in uncircumscribed men. Symptoms, it may be asymptomatic or patient may present with the symptom while being sexually active. This is the one condition very rare that is called PKMB, pseudoepitheliomatous keratotic and micaceous balanitis, because the scales are like a mica or asbestos. Now with this, I am coming to the pre-malignant female genital tract dermatosis. Already we have discussed about the LSA of male. The same thing is happening with the female. And here I would like to say that a patient may develop a lichen sclerosus atropicans of vulva, and similarly it spreads and involves the anus, and that is called a figure of 8 appearance. Okay. And with prolonged standing, the patient may develop a squamous cell carcinoma, which I will show you while discussing a squamous cell carcinoma. Pre-malignant condition of oral cavity, most common is leukoplakia. The definition of leukoplakia is already there in textbook, so I'm not going into the detail of that. This is the most important slide. If you want to take a picture, you can take a picture of the slide, because how you can differentiate between a leukoplakia or oral candidiasis. In leukoplakia, you cannot brush off the lesion or remove it easily. So once you scrap the lesions, you cannot remove it. But in case of candida, oral candidiasis, you may succeed in removing the plaque. These are the homogeneous type of leukoplakia, uniform whitening of side of the tongue. This is non-homogeneous, where you can see along with leukoplakia, there is an ulcer. Long-standing leukoplakia lead to ulceration of the lesion. That is called non-homogeneous leukoplakia. Another condition called speckled leukoplakia, where you can get dotted fibrosis. And this is a verrucous leukoplakia. See, the surface is uneven. This is a dangerous sign. So whenever you see these kind of things, you must take an appropriate action and treat it. High malignant potential of varicose type of leukoplakia. So whenever there is an uneven skin surface, must be very cautious and refer them to the nearby oncology center. These are the features of leukoplakia who are at increased risk of malignant transformation, female, more than 50 years, even non-smoker, long duration, non-homogeneous type. Biopsy is very mandatory. Erythroplakia, when there is a redness of the oral mucosa. Now coming to the most common type of skin cancer, the proper skin cancer, that is called basal cell cancer, or we commonly call it as a BCC. These are the different type of BCC. I will come one by one. So nodular BCC, superficial BCC, pigmented BCC, morphoic form BCC, or basosquamous BCC. This is see how the BCC evolved from a nodule to ulcer. These are the warning signs. When there is a new skin lesion, itching of a lesions and EG bleeding with saving or abrasion, you must think of giving immediate attention. Non-healing lesions, and there is a change in color. Now coming to the first pattern, and when you do a skin biopsy, you have a basalioid cells, epidermal cells in the dermis in this pattern. This is called basalioid tuber arising from the epidermis. These kind of features are characteristic of basal cell carcinoma, and they arise from basal cell, not from the other part of the epidermis like a spinous cell or granular layer. This is how the basal cell carcinoma look like. This is the most common type of basal cell carcinoma, called nodular type of basal cell carcinoma. When it ulcerate, it is called ulcerative basal cell carcinoma. Another picture. Difficult to diagnose when it occurs at the margin of eyelid. This is how it evolves from nodule to either ulcer or a nodular ulcerative lesions. This is another variety of basal cell carcinoma called pigmented basal cell carcinoma, because pigmented basal cell carcinoma is with Western literature is not so common, but we see it very commonly because of our skin of colors. So we get it, the pigmented basal cell carcinoma, more often than the Western part of the world. So pigmented basis is not uncommon in our part of the world. And that is how it is look like, beaded appearance, you can see with a central crater. And when you do the biopsy, you can see the pigments. These pigments appear predominantly into the dermis. The patient may complain of itching, burning, or more sensitivity to the light to the lesions. Another pattern, this is called superficial spreading type of basal cell carcinoma, where you can see the beaded appearance at the margin, which is a diagnostic or hallmark of basal cell carcinoma, along with central scaly plaque. What is the common differential diagnosis of this superficial spreading basal cell carcinoma? Anyone? Yes. Tinea corporis. So most of the time, many a times we miss this diagnosis. That's why I pointed it out, because many a times we think it's a fungal infection or ringworm. However, it is not ringworm. Patient may not complain of itching at all. So must think of, and you will not get this margin is not red, not erythematous or active. In tinea corporis, you will get pustular lesions along the margin, and there is a redness spreading beyond the lesions. And there is a central clearing. It's a very flat lesions. Here you can see there is no central clearing. It's a scaling. So uniform with a well-defined beaded margin. Difficult to diagnose this condition. This is also superficial spreading. Once you get experience in diagnosing basal cell carcinoma, then you can diagnose that this is a superficial basal cell carcinoma. This is the most common carcinoma in young adults. And it is the basal cell carcinoma. Most of the basal cell carcinoma, you can see it on the upper part of the body, especially the head and neck area. But this is the one basal cell carcinoma which you commonly see it on trunk. This is the rarest of rare form of basal cell carcinoma, which we call it as a morphoic basal cell carcinoma. It looks like a yellowish scar. So do you know about the morphia? Morphia is a one condition where there is a binding down of the skin, all the appendages get flattened, the skin will become atrophic. So this is the atrophic skin structure. You can see more close-up photographs and look like a yellowish scar. So this kind of basal cell carcinoma is not so common. Now I have an audience question, just to have a break. Which one is the most common basal cell carcinoma? I have already discussed. Yes. Nodular? Anyone? Further add to it? I'll give you a clue. It's a nodulo-ulcerative, right? It's a nodulo-ulcerative is the most common type of basal cell carcinoma. Yeah, you're right. Yes. Achha, you were saying on that side. Yeah. Oh, the slide is appearing as a presenter view. Yes.
Very smart.
Very smart. So I'll ask question before 2 slides, So how one can prevent from BCC? These are the sunscreen, avoid sun exposure, avoid tanning beds, and cover up your area. Now coming to the second most common cancer, and that is a squamous cell carcinoma. Squamous cell carcinoma is little bit more aggressive than basal cell carcinoma, because basal cell carcinoma metastasize or not metastasize? Anyone? This question, no, answer is not there. Basal cell carcinoma metastasize or not metastasize? It is spread to nearby or not spreading? It doesn't spread. It doesn't spread. But squamous cell carcinoma, in certain percentage of cases, it spreads to nearby lymph node, even to internal organ. So it metastasizes. And it arises from cells, the epidermis, squamous cells. This is the definition. This is the seborrheic keratosis, I already told you. And that's how it's become aggressive. Another one, wart-like growth. Second most common cancer, as I said, UV exposure is the most important risk factor as previous cancers. Slow growing tumor with tendency to metastasize. And over and above that, these diseases may occur on chronic skin diseases. I'll show you some of my patients' pictures. This is how it looks like on histopathology. Keratin pearls. The epidermis proliferating into the dermis and forming keratin pearls. This is a hallmark of squamous cell carcinoma. So 3 cases, 1, 2, 3, discoid lupus erythematosus. How many of you know about the discoid lupus erythematosus? It is a lupus confined to skin. This is how it looks like, the white one. And a person with discoid lupus erythematosus may develop a squamous cell carcinoma when he or she gets chronically exposed to sunlight. So his or her DLE also get aggravated, and similarly the squamous cell carcinoma. Another case, 40 years old lady, and this is another case on the lip. A condition called porokeratosis, which is a skin condition where also you will get squamous cell carcinoma. This is also a chronic skin disease. Lupus vulgaris. Lupus vulgaris, anyone know what exactly it is I am talking about? Yes, tell me. No, it's not the commonest form of lupus. Commonest form of skin tuberculosis. We call it as a lupus vulgaris. So when there is a plaque of lupus vulgaris existing for 2 or more years, the patient may develop this fungating mask, and that may turn out to be a well-differentiated verrucous squamous cell carcinoma. Lichen planus. How many of you know the lichen planus? It is autoimmune. It's a very benign condition, very stubborn to treat, and there is a remission and relapse. And how it is look like? It looks like this: pearly papules, flat top papules, and invariably itchy. Rarely it may turn out to be a squamous cell carcinoma, especially a form of lichen planus. We call it as a lichen planus hypertrophicus. See the squamous cell carcinoma arising out of lichen planus hypertrophicus. Another case. And this is what I have discussed, the LSA, lichen sclerosus atrophicaans, on the genital region. But as in skin also, you may get it, these lesions, which many a times people misled and diagnose it as a pityriasis versicolor or vitiligo, leukodema. But it's not vitiligo, it's a lichen sclerosus atrophicaus, because everything was around the hair follicle and the skin is flattened. Genital LSA turn out to be a squamous cell carcinoma. Burn scar, which I have already shown you as a marjolin ulcer. So high index of suspicion is required. Okay, now coming to the audience question, we are about to end of our presentation. Now the audience question. What do you think? What exactly it is? You have 4 choices. Actinic keratosis, arsenical keratosis, Marfan's disease, and marjolin ulcer. It's not Marfan's disease. I have shown you in my first slide. It's on the scalp, so it's actinic keratosis. It's actinic keratosis. What is this? On scar, marjolin ulcer. That marjolin ulcer. Any cancer related with this creature. Already there. Already there. Already there. It's a rodent ulcer. It's a basal cell carcinoma. Your edges are nipped off like a rodent. So the take-home message in skin cancer is there should be a high index of suspicion. The suspicious lesion should be followed up closely, and if required, biopsy should be taken or should be examined with the dermoscopy. And these criteria should be followed in each and every case of skin cancer, or you suspect a lesion to be a precancerous. And these are the A, B, C, D, and E. A is for asymmetry, look for the asymmetry. B is for the border, is the border is irregular. C is for the color. If there is a color change in the lesions. D is for the diameter, if the lesions is increasing in size. E is for the evolving. If another lesion is evolving nearby area, then you may suspect that the patient may develop cancers. Thank you very much. This is my references. Thank you. Thank you for your patience listening. Thank you.
Thank you, sir, for the presentation. Dermatology is always challenging. I had several questions, but of course I'll ask only one. I'm a physician, so most of the times we get cases of tinea corporis. Perhaps we may have misdiagnosed.
That is unrelated, but I'll answer. No problem.
Yes. So I know that tinea corporis, when it presents, usually to present with several lesions on the corpus. Is that the same with basal cell carcinoma? In case I'm trying to distinguish.
Tinea corporis never changes into malignancy. I have never seen any tinea corporis patient changing into or develop malignancy.
So
it's very unusual.
It's just at the time of diagnosis trying to make out which one is, whether it's basal cell carcinoma or tinea corporis.
No, basal cell carcinoma is also common cell carcinoma is out of question in case of tinea corporis.
Okay, no, my question is I'm trying to distinguish because I can make a wrong diagnosis. I can think it's tinea corporis when it's basal cell carcinoma. So now I'm saying
basal cell carcinoma, you have a beaded appearance margin and the skin is nodular with a vascularity. I have shown you the picture. There are vessels traversing around the nodules.
Yes.
So it starts with the nodules, gradually it evolves and become ulcerated in the center. That is called nodulo-ulcerative.
Okay. Now, other than that, in terms of the number of lesions, does basal cell carcinoma also present with several lesions like we see in tinea corporis? That's my question.
It may, patient may have many type of basal cell carcinoma. In fact, sometimes they have a mixed variety of basal cell carcinoma in say single patient, especially in white skin people. It's not common in our skin of colors.
Thank you.
It's very uncommon. We get only 1 or 2, maximum 2 lesions. But when I was in US doing my fellowship, I was seeing the basal cell carcinoma is like a fungal infection, which we are getting in our country. Each and every patient was having some or other form of basal cell carcinoma. And Mohs surgery was very popular in US. However, it is less popular in India. You have to find it out the Mohs surgeon. But in nooks and corner of US, you will get a Mohs surgeon who is performing Mohs surgery for basal cell carcinoma. So basal cell carcinoma is a very common carcinoma, especially in the Caucasian skin. And a patient may have a different type of basal carcinoma, cell carcinoma at a given point of time.
Thank you.
Hopefully I answer your question. Yeah.
So we take one more.
Yeah.
Good morning, doctor.
Yeah, morning.
Dr. Smriti Dina from Mauritius.
Yeah, I came to know that you have trained in dermatology.
My question is more practical. It's not about the theory. You've worked in India for how many years?
I'm working for 96 onward. Is that 27 years?
Okay. So you've seen a lot of differences in dermatological cases and lesions. I mean, as compared to white skin, Caucasian skin.
Yes.
So our issue is actually back in Mauritius is that we have a population what is multiracial. Okay, so we have Indian descent, African descent.
Most of them are Bihari.
Yeah, most of them. Yeah. So the issue actually is that what we've learned at university, what we've seen in dermatological books, is not what we see in practice. So it is not what we see in practice.
Okay.
There are, of course, things that are the hallmark of the diseases, but sometimes it's very difficult to recognize certain lesions on skin of color. So what is your advice for a practicing dermatologist?
You keep on seeing the patients, and now we are in the era of digital information, you know. So a lot of things are in fact, in most of my presentation, I have taken picture from the internet, the Google image search. So once you put a Google image search, there are a lot of AI tools also which diagnose you or take you to a 70%. You may have an idea what you are dealing with. So the only thing, the way to learn in our specialty is to
practice.
looking into the lesions.
Yeah.
So it's a visual specialty. So go through the atlases, which are online atlases available. In fact, in books also, there are a lot of books written on skin conditions. So go through the books, see more patients, then you realize that it's very easy science, The nomenclatures are a little bit difficult. Otherwise, the science is very easy. The dermatology is a very easy subject to grasp. It's
Not
very
really.
easy. Only the nomenclatures are,
Yeah.
Once you've been to the specialty for 6 months and keep seeing 100 cases per day, 100 cases per day.
It's the trained
I was
eye.
fortunate that I was seeing 400 cases in a day in my residency. I did my residency from All India Institute of Medical Sciences, New Delhi, which has an OPD of 600 per day. 600 people come to see us, and that too of the rare diseases, because the highest center in India, if you know, the AIMS Delhi. So AIMS Delhi has a huge number of cases. So you can learn easily within 2-3 months time. So get exposed to the patients and see it into the book, correlate with the findings, and then it will be easy to diagnose.
Okay. So did you have the experience of diagnosing multiracial populations?
Here, rarely we get Caucasian population, but Mumbai, yes, there are a lot of consulates over here. So we are getting few cases. I can say in a month, I see 10 or 15 cases.
And in terms of treatment, is there anything that changes in the protocol when the skin type is different?
Yes, that changes because of the skin of colors. They are more sensitive. So we could prescribe some treatment which is not going to harm them.
Pigmentation.
Pigmentation, or if you are using any topical corticosteroid, then the potency will be less because they have a thinner skin because of the chronic exposure to the sunlight.
Thank you.
Thank you. Thank you very much.
So thank you, Merck Foundation, for the opportunity, and thank you for nice introduction. So in your program, you must have seen the topic as, you must have read the topic as functional gastrointestinal disorders, a case study, but here you see something different. It is written as disorders of gut and brain interaction. So I'm not giving a wrong presentation. This is a correct presentation, but there is a change in nomenclature, which I will like to highlight. So how the name functional gastrointestinal disorder came into the practice, because there was a lot of patients which used to come to the gastroenterology OPD, and they used to have a lot of symptoms, pain here, there, these nausea, vomiting, constipation, so on and so forth complaints. Once they are completely evaluated, if you do perform physical examination, it is normal. You perform some blood reports, they are normal. You perform ultrasound, normal. You perform CT, normal. You perform endoscopy, normal. But patient continue to have long list of symptoms and problems. Then you say, okay, now I'm left with prescribing him something. So you will prescribe something, 2-3 medicines. Patient will take it 15 days. He will come back with same or maybe some aggravated symptoms. And now you are left with nothing. So you don't know what to do exactly. So that's why these patients were labeled as functional GI disorder. So they have some problem with function. There is no problem in structure. We have performed so many investigations. Everything is done. Structure is normal. Some functional related problem. So initial name was functional GI disorders. As our understanding of these disorders and pathophysiology behind these symptoms improved, we came to know that there is a problem in brain. There is definitely some problem in gut, maybe gut related nervous system, and also some pain perception in higher center, that is the brain. There is some problem related to microbiota, which forms the integral part of the gastrointestinal system. There is some problem with the mucosal barrier. There is some problem with the immune system. There may be some change in sensitivity of the normal or the change in perception of normal physiological activities which are going on in the intestine, like peristaltic activity. We all are sitting here. Still, some peristaltic activities are going on in small intestine, they are large intestine, but we do not feel that activity as a pain or as a disabling complaint. But few of these patients might feel that as a disabling complaint or discomfort. So that is something we call it as visceral hypersensitivity. Some patients may have some problem related to some food, and that can produce symptoms. And almost all of these patients have some psychological abnormality, some stress, some depression, some anxiety, some or the other things. So Rome Foundation actually divided, they came up with this type of say domains, and okay, so they came up with these different domains which has a gut. So as I enumerated, there can be problem with motility, there can be problem with sensation, microbiome, secretion, immunity. There can be problems at brain level, which can be psychological, which can be cognitive, which can be some stress or inability to cope up with some stressful situations, hypersensitivity. There can be environmental problems, which might be precipitating or aggravating these type of symptoms. And all these things in combination, which may be one more than other, all these things lead to some kind of symptoms, and these symptoms are definitely affecting the quality of life and day-to-day function of these individuals. So Rome Foundation divided the disorders of gut-brain interaction, previously called as functional GI disorders, into so many subtypes. It is impossible to cover all the subtypes even in a month of time, because there is a lot of literature. So we will be covering only 3 of them, and that too in a case-based manner. So here is our first patient. He is a 40-year-old male patient. He is a chief executive officer of a company. And he is symptomatic since almost an year, and his symptoms have aggravated since last 3-4 months. So he started telling his complaints, like he eats something, then he gets some lot of fullness, tightness, heaviness. He feels like he eats some 100 or 200 grams of something, but he feels like 15-20 kilogram of the food stuff is ingested into his stomach, and he's unable to finish his meal. He feels like bloated kind of thing. And also all these things started during the COVID times, when his company shares or stock market started going down, company started suffering loss. Then somehow he lost his father to COVID. So all these, so he developed a lot of stress, and subsequently since last 4-5 months, he has a lot of these problems. Sometimes he eats some spicy kind of thing, which aggravates his symptoms. So he sometimes he also said that, okay, he gets pain here, then there is some burning kind of sensation or here somewhere. Sometimes he gets some acid in some sort thing in mouth or something. So all these haphazard complaints he started telling. So first 5-6 minutes, he just kept on talking, and I patiently listened to it. So first thing is that you should listen to this patient. So they are telling their problem, so you should listen. Second thing, then I divided these patients, his complaints, in 4 domains, which I told you first. There are some symptoms which are related to gut. Example, he feels like after eating something, he feels distress, he feels fullness, weight. So he's trying to express it as distress. So this is postprandial distress. Second, he also had some bloating, some belching, some retrosternal burning, which may be related to coexistent gastroesophageal reflux or maybe heartburn. There was a precipitator or aggravator, that is some spicy or fatty meal if he takes. There were some environmental factors like ongoing COVID pandemic, which added stress to everyone's life. There were some psychological stresses, like his company is not performing. He lost his father, so he had lack of social support. His sleep is reduced. He feels exhausted. kind of thing. So along with that, I have added one more domain which actually Rome has not mentioned in this one, but they have definitely mentioned this in text, that you must rule out alarm symptoms. So organic disorders to be ruled out. So if you see all these postprandial fullness and all, these can be there even in many disorders of stomach, the gallbladder, pancreas, even simple splenomegaly can cause the fullness after meals. So there are a lot of other organic disorders which are definitely have some pathological problem can have these symptoms. So this field is alarm symptoms. That's why it is written in red. So you must always ask these alarm symptoms. One of them is vomiting. Second is weight loss, loss of appetite, gastrointestinal bleeding. It is alarm symptom. There is bleeding. That means there is 100% some pathological abnormality, and you should focus your attention and try and diagnose it. Anemia is there. That means there may be blood loss, there may be B12 deficiency, there may be some other disorder. Palpable abdominal lump, that means there is 100% there is abnormality, you must investigate it. Severe abdominal pain, these patients may have some discomfort, but severe abdominal pain denotes maybe some acute abdominal condition which needs to be ruled out. Fever and jaundice are definitely some pathological conditions. So now in this slide, we will try and analyze his symptoms and try and correlate his symptoms with pathology, what is going on. So his first symptom is postprandial fullness. So what is exactly happening in this patient? So when we eat food, food goes in stomach. Stomach relaxes. It receives food. As the stomach relaxes and it receives food, the gastric volume increases proportionately and there is no increase in intragastric pressure. But in these patients, this relaxation part is affected and there is distension of stomach and there is no relaxation, adequate relaxation. This causes flooding of the distal stomach, that is antrum, with food, and this antral distension causes a symptom of postprandial fullness, or whatever the weight, heaviness, whatever. Patient can describe it in any words. Second possibility is probably that his gastric emptying is delayed. So food is staying there for a long time, and that's why he's getting persistent fullness after meals and he's unable to eat it. Second thing which I mentioned, in 30 to 40% of the patients with these symptoms, the emptying is normal. It has been demonstrated by some tests. So how these patients get problem? It could be visceral hypersensitivity, that is increased sensitivity to normal physiological activities. And usually these patients will have other associated problems like functional heartburn. Many of these symptoms are associated with food. As in our patient, he said that when he consumes some high fatty and spicy kind of meal, he feels like his symptoms aggravate. So this can be aggravator or precipitator. This can be because of some activation of some receptors with capsaicin, which is commonly found in spices and chilies. Some acidic foods, there are some acid sensing channels in duodenum which can cause this, and this one is cholecystokinin, which is secreted when there is lipid rich food is consumed. So these are some of the precipitators. Second, again, the chronic inflammation at the level of duodenum is also found to be associated with these particular symptoms, and this can may also contribute to hypersensitivity. H. pylori, this is a bacteria which stays in stomach, and H. pylori is also known to cause dyspeptic symptoms, but this is different from the functional dyspepsia which we see. This is H. pylori associated dyspepsia. If you treat H. pylori with appropriate therapy, the symptoms resolve. Sometimes after some gastroenteritis episodes, you will find patients coming up with these problems. So this is just some altered motility because of the post-infectious state, and this will resolve over a period of time. If it persists, then of course you have to intervene. So change in microbiota is associated with altered gas production, and that can result in bloating and postprandial distress. So this is how we evaluate the patient. First, you rule out alarm symptoms because so many other diseases. This is a list of the red color shows list of diseases which can have more or less similar complaints. And you should never miss these disorders because that can be problematic, that can be life-threatening for the patient. Now, whether you perform endoscopy first in these patients or not, no, not always. But there are definitely some symptoms when there are definite symptoms of gastroesophageal reflux. If the patient age is more than 45, patient has a family history of gastric cancer, then definitely, yes, you should perform endoscopy first because these are the patients who are likely to have some or the other gastrointestinal problems like enumerated in this particular section. So basic investigation in this particular case will be hemogram to exclude that there is no anemia and any other problem, ultrasound to rule out pancreatobiliary diseases mentioned here, and endoscopy is only in selected patients, or if you are using a test and treat approach, like you are testing the patient for H. pylori, then you perform endoscopy, obtain rapid urease test. If that is positive, then you treat for H. pylori. That is test and treat approach. That's what they said for dyspepsia. So this is a algorithm. So for functional dyspepsia, you have to divide this into two. One is postprandial distress, as in this patient. Other form is epigastric pain syndrome. Here the patient will keep on having pain, whether he eats, whether he doesn't eat, any problem, but patient will keep on complaining pain, 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 and pain. So if epigastric pain syndrome is a predominant clinical finding in our based on history, then you try proton pump inhibitors like pantoprazole, rabeprazole, whichever is available. If relief is, if it relieves the symptoms, it's okay. If no, then next step is to add an antidepressant like tricyclic antidepressant, maybe amitriptyline. If there is relief, then it's okay. Then if no, then patient will need further testing, whether there is a problem with gastric emptying, whether there is increased fundic tone. This can be treated with acosciamide, or maybe some additional antidepressants, or some duodenal mucosal problem, duodenal eosinophilia is there, then that can be treated with drugs like montelukast. For postprandial distress, where the gastric motility is the primary problem, our first choice will be a prokinetic. Prokinetic drug will improve the gastric motility. It will streamline the gastric contractions and improve gastric emptying, and that will help in reducing the symptoms of this patient. So now this is a pathology. It is the same as mentioned previously. These are the symptoms same, but now we will focus on management, how we approach this patient. So patient had problem with accommodation, antral distension, and change in rhythm. We tackled this using a prokinetic medication like domperidone, metoclopramide. So these can help. Acosciamide is a new player which helps in relaxation, which selectively helps in relaxation of fundus of the stomach, so that fundic spasm is reduced and fundus can accommodate more and more food. So visceral hypersensitivity, it is mainly treated with amitriptyline or other tricyclic antidepressant. They will help in reducing these symptoms. There are some food related symptoms. So this can be treated by maintaining a food diary. If you ask patient, if you should, whenever you eat something and you get symptom, you should record it. You should record that particular name of the foodstuff, that I had this food and then I had this problem after these symptoms appear. And you try and exclude them from the diet. Then that can help you in reducing the symptoms. H. pylori, as I mentioned, if that is positive, then anti-Helicobacter pylori treatment will help in reducing. Post-infectious dyspepsia, if dyspeptic symptoms are there, then reassure the patient. It will resolve, may take 1 or 2 weeks. You can prescribe some prokinetics, but usually resolve. It is self-limiting. Food related, if the bloating and postprandial distress, if these are the prominent symptoms, then these are usually associated with dysbiosis, some abnormal bacterial growth, and that you can use rifaximin for that, and some dietary changes that will help you. So what I'm trying to tell you is these functional GI disorders, they are not just abnormalities, but there are some definite pathophysiological mechanisms involved with this, and we can target one or more of the mechanism which is predominantly found in your patient, that you can come to know from the history, and selectively we can prescribe some medicines, and that will help your patient getting better. And of course, reassurance and doctor-patient relationship is definitely important. While doing so, you should never miss out alarm symptoms, because these many of these alarms disorders, they have cancers like gastric cancer, gallbladder cancer. So these are very life-threatening diseases, and if you miss out and delay for 1 month, 2 months, then they're going to cause a lot of problem to the patient. Along with the gastrointestinal problem, other psychological problems, stressors, they also need to be addressed, and you can surely take the help of your psychiatric colleagues and counselors for management of this. So our approach is multi-pronged approach, and it is, as I mentioned, that we have 3 or 4 domains. So we divide the symptoms and then approach each and every symptom. So this makes your job little bit easier. Okay, so now we quickly come to our second patient. So we have finished one patient. One patient is out of our OPD. So here is the next patient. So, she is a 34-year-old female. She's computer programmer. She has 2 children, and she's unwell since last 2 years. So 2 years she's having problem. And here you see there are so many complaints that they are not fitting in the slide also. So I tried to somehow cramp and put it in the slide. So she has main 2 complaints is abdominal pain and altered bowel habits. So she describes her pain as a diffuse pain. It increases, it decreases. 2-3 days she's okay, but other 4-5 days she is having a lot of problem and disability. Her pain is related to defecation. As soon as she passes stools, she gets some relief, but again the problem starts. Pain is increased by food intake, especially some spicy food. In India, we take a lot of everything, whatever. Even if you will have a lunch now, you will eat a lot of spicy food, don't worry. So for the pain, she's taking some painkiller medicines, which half an hour, 45 minutes she has relief, but then again she develops some other problem, and she wants to have these all the permanent solution to the problem. Along with the pain, she has altered bowel habits. She passes 5 to 6 small to moderate. This is exactly how a patient will describe it. Okay, so 5 to 6 small to moderate or liquid quantity of stools. First 2 stools are more liquid, then subsequently they are semi-solid. So, oh my God, this all doesn't make sense. So what you should do is, you should straight away hand over this chart, Bristol stool scale chart. I will come to this later. So she started describing her stool. So I straight away handed over this stool chart to her. Then I continued asking some questions. So she told that she also had some mucus, she had urgency, and as soon as she takes meal, immediately she has to go and rush the toilet, and immediately she has to go and pass some stools. At night, she doesn't have to get up and pass the stool, and there are these red symptoms, which are the alarm symptoms, like tenesmus, blood in stool, oil, mucus, mucopus, incomplete evacuation, or some mass which is felt in the rectum or coming out from the rectum, or finger evacuation. So now we come to this Bristol stool form scale. This is a very valuable tool, and it represents the intestinal transit. So when we eat something, it is converted into a liquid with some particles which are 3 mm size, that from the stomach it goes into duodenum. Over the entire flow in the gastrointestinal tract, it becomes, initially it is liquid, and as it comes into the colon, most of the water, almost 90% of the, more than 90% of the water is absorbed, and stool becomes solid, somewhat like this. But if stool stays in colon for a longer time, colon keeps on absorbing water. So the stool slightly becomes hard, then it further becomes hard. And as it becomes hard, it becomes brittle. So in very constipated patients, you will find that they are passing some hard lumps like this. On the other hand, if the intestinal transit is fast, stool is not staying in colon for a longer time, then patient will pass some these soft blebs. If the intestinal transit is still fast, then patient will pass this kind of mushy stool, and it's very fast, or there is increased secretion of water from the colon, then patient will pass watery liquid stool. So whenever such a patient with colon related symptoms or bowel related altered bowel habit patient comes, you take a printout of it and straight away hand over it. He will tell you that, so see, in this our patient, her initial 2-3 stools are like BSS 6 or 7. So this is 6 and this is 7. So they are quite loose type of stools. Then subsequent 1 or 2 stools are like this. So they are slightly more on solid, but not completely normal. Okay. So this is the Bristol stool. It represents the intestinal transit. As if you see the Indian guidelines, even type 3 and type 5 are considered abnormal. If you see the Rome, then 3, 4, 5 are considered as normal. So on inquiry, so her complaints are still continuing. See, 2 slides she has taken for complaints. So she is afraid of leaving home because of stool frequency, because if she eats anything, she immediately have to go. And if there is no toilet, then how can she, what she will do? So she is anxious. So this adds to anxiety. Her husband is Navy officer, so he is not present at home. So entire household responsibility, and that is on her own shoulder, and she has to bear everything. She has 2 children, and one of the children has some learning disability or some poor school performance, and there is unfortunately no one to support. So lack of social support. So you should also ask about these things. So she had exacerbation of symptoms during her deadlines and assignments. She is computer programmer, so working for some company. So she has some deadlines. So you have to finish this program in say 1 month or 2 months. And as soon as the deadline approaches, and when she needs to be focused on her work at her best, her symptoms starts increasing, and she feels disabled, depressed, and that adds to her anxiety. So she had consulted so many doctors, they have given some tests, but all come normal, as I mentioned in previous section. So in these patients, you should ask all these alarm symptoms. First is blood in stool. Blood in stool is always a problem. It represents either neoplasia, inflammatory bowel disease, ulcerative jejunoileitis. So if there's tenesmus, mucopus, then it suggests ulcerative or infectious colitis. Fever again suggests some infection. Severe abdominal pain unrelated to defecation. This is not IBS, remember. In IBS, abdominal pain will be related to defecation or food. If it is unrelated and continuous, it is not IBS. Don't make mistake. Weight loss, loss of appetite definitely suggests some organic disease. So vitamin deficiency, it definitely suggests some abnormality. Symptoms of pain, vomiting, distension, constipation, obstipation, this definitely suggests intestinal obstruction because of some luminal narrowing, and this is problem. This can be tuberculosis, this can be cancer, this can be some IBD related stricture or something else. Family history of colorectal cancer, you should never miss it. Sometimes you should inquire about food allergy, and presence of dehydration, it definitely suggests that there is some abnormality. So her symptoms, which are lot of symptoms, I have divided in one slide, and this is a complete analysis of her symptoms. So gut related symptoms are abdominal pain, which is associated with change in stool frequency or form. Exaggerated gastrocolic reflex is there. There is some social problems are there. I have ruled out all the abnormal alarm symptoms, and there are some psychosocial stress and other things which are there. So I have divided her symptoms into one slide and very crisp. So this is what we have to target and understand in our next subsequent slides. So again, pathophysiology and correlation with symptoms. Normally we have high amplitude propagated contractions which are there, which happen usually in early morning hours. These contractions are meant to clean the colon out of stool. That's why we get urge to pass stool usually in morning hours. So this is a biological rhythm or biological clock. So in these IBS patients, especially with diarrhea predominant, these contractions are exaggerated, and that's why they get increased stool frequency and urgency and urge to pass stools. Sometimes the gastrocolic reflex is a normal phenomena. Remember, in the morning, if you take a glass of maybe say tea, coffee, or not even that, just simply water, you will get an urge. So this is gastrocolic reflex. It is normal. But if it gets exaggerated, then it will have problems like this patient. She eats anything, she immediately has to rush to the toilet. And there is some problem with autonomic nervous system, which has maybe due to some inflammation or bacterial overgrowth, and that can contribute to diarrhea, mucus, and urgency. Several food materials like capsaicin, FODMAPs, I will come to this FODMAP diet, and those can aggravate the symptoms. So there is some problem with central pain perception also. So the pain component is probably related to the central nervous system and reduced pain perception. Foods like FODMAP, gluten, and capsaicin, they increase the symptoms. Sometimes, even if all these factors are not there, then sometimes the bile acid abnormality can cause diarrhea. So now we know, grossly we know the pathological mechanism. It is not necessary that all pathological mechanisms will be there in one patient. It is your history that will guide you to the pathological mechanism. Just for summarizing point of view, I have tried to correlate normal, pathology, and symptoms. So evaluation and management. So it's simple. You have to divide IBS into two gross parts. One is constipation predominant or diarrhea predominant. Some patient may have combination of both, that is mixed. You have to ask for associated disorders. Our minimum investigation will include hemogram, C-reactive protein, stool examination, fecal calprotectin, and sometimes, although these investigations may be normal, colonoscopy and mapping biopsy will be required to rule out microscopic colitis. It is not IBS, it is some different disorder, but it will also have normal colonoscopy and many normal investigations. Only biopsy can differentiate whether it is collagenous colitis, previously known as collagenous sprue, or lymphocytic colitis. So now we will focus on this therapeutic. So increased stool frequency, urgency. What therapeutic options we have? There are increased contractions. You slow down the contraction. Give anti-motility drugs, loperamide. Food causes problem. Identify food, take out the food, exclude. FODMAP, exclude. Try and give low gluten. Bile acid has a problem. Give cholestyramine, which is bile acid binding resin, which reduces which may reduce the symptoms related to bile acid. Reduce the intestinal motility. Ramosetron is a 5-HT3 antagonist. It will help. Bacterial overgrowth, we have rifaximin, antibiotic. So that can help. If many of these patients have altered stool with prominent abdominal pain. So for prominent abdominal pain, we have antispasmodics. Pain represents muscle spasm. So you reduce the muscle spasm. How? Dicyclomine, anticholinergic, mebeverine, otolinium, peppermint oil. All these things, they reduce the spasm. These are antispasmodics. There may be increased pain perception at central nervous system level. For that, we have tricyclic antidepressants. One advantage of using tricyclic antidepressant is that side effect of tricyclic antidepressant is constipation. So you use the side effect of one medicine to our advantage in diarrhea patients. So if you have patient with IBS and constipation, and if you use tricyclic antidepressant, it will worsen the problem. But in diarrhea, you can use it. In the patient with constipation, you will have to use selective SNRI, selective serotonin norepinephrine uptake inhibitors. These are escitalopram or citalopram. So you use adverse effect of one medicine to your advantage and treating symptoms. So in one go, you are targeting brain as well as gut. Okay, so rifaximin I covered, cholestyramine I covered. So this is something about FODMAP. So now this is a very big list of foods to avoid. And if you read it carefully, whatever you like, and love to eat is in this list. That's why deliberately I have put this chart. Okay, and whatever is costly and you may not like is foods to enjoy. So now you have to balance it somehow. So how will you balance? So tell the patient to maintain a food diary. It is not like that you have to, if you if you tell the patient, give this chart and tell the patient, okay, all foods to avoid. Next time you come to my clinic and I want to know that you have not consumed a single piece of all these foods to avoid chart. Then he will come to you with fasting, nothing. So that is not possible. That is very inappropriate. So what you can give this chart, you can tell the patient that whenever you get symptoms, you refer this chart and you see out of these foods to avoid what you have consumed. Make a list of it. If you have consumed, say, some spicy thing, you make. I had some paneer tikka masala at one marriage and then I had problem. So you write down, I had this problem, this food, and then symptoms started. This will help us in tailoring down this long list to maybe some 5 or 6 foodstuffs. Only those can be excluded. Rest of the things you can take surely. So if you tell this, patient will also get reassurance. So reassure the patient. If you give it, hey, don't take anything, then patient will get, I mean, he will throw this thing in the next dustbin, which he gets along the road. That is not. So exclude. And once you exclude, symptoms subside, try and reintroduce it maybe at lower threshold. See if he tolerates or not. Okay. And so you can make this, customize this list to particular patient. So this is how, and in this, you can take the help of a trained dietitian. If you are having some dietitian who can assess it, it will be of great help. So again, conclusion, our approach is domain-based. So divide patient's complaint into those 3-4 things. Patient may tell you this many complaints, but there will be very few things which you have to pick up and address. So this burden is less. Otherwise, you may end up getting some of these disorders. So quickly move, this patient is over. We have given some medicines and now I hope she will be happy. So now this third patient has come. So he's a 36-year-old male. He's a stock market broker. So he works with all those stock exchange and purchases the stocks and sells the stock and whatever. I don't know how he gets some financial benefits. So he came, he's symptomatic since last 6 months. And his main complaint is constipation. So I asked him, okay, can you describe more about your constipation? So he feels that every day I get up, I visit toilet 3 times. Every time I strain, I pass some stool, but I still feel that my bowel is not completely evacuated. So I again go, again strain, again wait some 10-15 minutes, but nothing works. And every day I feel that bowel is not completely evacuated. I'm absolutely unhappy. So, okay. So I asked him, okay, what do you do if that? So he sometimes try to pass finger and see if it is evacuated. So attempts finger evacuation. He feels bloated, belching, and full if these symptoms are present. And he's absolutely unhappy. So while this interview was going on, patient's wife interrupted. She said that this person has a habit of carrying mobile phone into his toilet. So he gets up, he takes his mobile and goes to toilet, and in the morning he starts reviewing which stock is going to go up, which is going down, and which should I purchase, and whatever the stock market transactions and all. He starts planning from that point. So he is not focusing on his normal activity which he's supposed to do. Distraction. This also creates an state of anxiety. See, if yesterday he purchased one stock, today that value has crashed down to nil, then he is anxious. So this control over the normal activity is shattered. Anxiety at one point is going to affect entire body. Anxiety if you see anxiety, you get tremors. So hand has nothing to do with anxiety, but it is this your nervous response. It is universal. It can have tremors. It can have the problem related to anal sphincter. And wives are very observant. I have observed this in my consultations, and I don't think that I would have ever be able to elicit this history, but she pointed out a very correct history. So along with the constipation, he has throbbing headache and he has tried multiple laxatives and lot of stuff, but that is not working. So I straight away went to alarm symptoms and asked him whether he has any bleeding. Bleeding per rectum is an alarm symptom because it is associated with rectal carcinoma, inflammatory bowel disease, or maybe some infectious colitis. So if he's having something with some fleshy thing coming out per anus, sometimes this can be related to rectal prolapse. I asked him symptoms of intestinal obstruction, which were not there. I asked him about urgency, tenesmus, which are symptoms of IBD, inflammatory bowel disease, which were not there. Fever, weight loss, loss of appetite, these are general symptoms suggestive of some organic disease, not there. Family history of cancer, no family history of cancer. So I ruled out all the alarm symptoms. There were psychosocial stress, deadlines, and all those things were there because he's a stockbroker. If his stock falls, then he's stressed. And he's there right since his first hour in the morning, as soon as he gets up. So what is actually happening in this patient? Let us see. This is very interesting. At rest, this is the position. This is a rectum. This is sigmoid colon. This is puborectalis sling, which is pulling this rectum forward and creating an angle. So this angle is known as anorectal angle. This angle is partially occluding the rectum, and that's why today also at this point also we all are in this particular state, that is resting state, and this is governing our continence. We can halt the peristaltic movement and we can store the stool till we get appropriate environment to pass the stool. Now say a person has urge to pass the stool. He goes to the toilet, he is in appropriate environment, he is very good, he is not carrying his mobile or newspaper, so he has complete focus. So there is urge to pass, there is a contraction of rectum, contraction of diaphragm, contraction of abdominal muscle. So they are all three are giving this downward push to the stool. Puborectalis angle, if you see this angle has relaxed, you can see this angle and you can see this angle. So this angle has opened up. Anal sphincters are relaxed. So here you can see the anal sphincters are contracted. At rest, they are contracted, internal and external. Here, both are relaxed. And then person passes stool. This is normal. Now, what is happening in this patient? This patient has a slightly kind of the BSS type 2 or maybe 3 stools. He had delayed transit. He has good abdominal push. He's straining. So his abdominal efforts are good, but his sphincter should relax. That is not relaxing. He is trying to push, but sphincter is paradoxically contracting and not allowing this stool to come out of the anus. This is known as obstructive defecation. So there is some incoordination between abdominal efforts, rectal efforts, urge, and this sphincter complex and relaxation of this puborectalis, which is not happening. So this is the incoordination. That's why despite taking so many laxatives and so many visiting so many things, his symptoms are not relieved, because the problem is not with some percent problem is with stool consistency, which can be taken care of with laxatives, but this incoordination cannot be taken care of with laxatives. So next, I convinced him and I performed a digital rectal examination, part of clinical examination. Left lateral position, excluded painful condition, inspection of perineum. Then gloved finger was lubricated finger was introduced. Contents, tone, squeeze, and descent were analyzed. And then while withdrawing the finger, you should always inspect the finger, whether there is any blood or anything, because if blood or anything is there, that means you are more likely to have some cancer or something. So this was performed. So so in this particular patient, when I told him to strain, his abdominal efforts were good, but I could feel that his sphincter is gripping my finger. That sphincter is not relaxing. It is not allowing my finger to come out. It is gripping. That means sphincter is paradoxically contracting as shown in previous slide. So I performed his sigmoidoscopy, which was normal. But remember, in patients with in those patients who had habit of fingering in the anus, you can get these type of ulcers on sigmoidoscopy, and this is known as solitary rectal ulcer syndrome, or SRUS. So his sigmoidoscopy was normal. So next step was anorectal manometry. So what your finger senses, all these colorful figures also show the same thing. Remember, your finger is a best manometer you have, and this is useful in 77% of the cases. This is not my figure. It is proven by clinical trial that in 77%, only PR examination, if performed properly, can diagnose the obstructive defecation. Yeah. So in this patient has dyssynergic defecation, slow transit. So the biofeedback is the treatment for this particular patient. You can use some laxatives for bacterial overgrowth, rifaximin, and associated symptoms you need to address, and psychosocial things are, of course, you have to address, and no mobile, no newspaper and anything while doing the defecation. So this is the overview of constipation. You can take a snapshot of it. Constipation can be normal transit, slow transit, or defecatory disorders. In slow transit and normal transit, you will have urge, but in slow transit, you don't have urge, but in other two, you will have the urge to defecate. And for normal slow transit, you have colonic transit studies. Treatment is laxatives here, but for defecatory disorder, you need biofeedback treatment. So divide constipation in 3 types, as mentioned previously. Rectal examination is essential. In 30%, in 77%, you will be successfully able to diagnose it. In the rest of the 30-40%, you need all the 3 cases. So to summarize, the gut-brain interaction is important. Listen to the patient. If you listen carefully to the patient will tell you the pathophysiology. Patient is actually telling you pathophysiology. You just have to capture and interpret in that manner. Further reading, I will suggest Rome 4 and Indian guidelines on irritable bowel syndrome. Thank you. So for the, it was a slightly longer lecture. I know you will be having a lot of questions. I will share my email address with him. You can write down and send the questions. Okay, I will answer on that. Thanks.
Thank you very much, Prof. Sir, for your presentation.
Thank you for your kind introduction. Okay, so pediatric cancers are very rare, and the infant and neonatal cancers are further rare. Okay, but then why do we need to study them? So they have very unique clinical and genetic characteristics. And the embryonal tumors are much more common as compared to the sarcomas, which we see in the pediatric patients and in the adult patients. So neuroblastomas, nephroblastoma, retinoblastoma, medulloblastoma, hepatoblastoma. These are all embryonal tumors and are much more commonly seen. And still they are rare, and the data also is not very well captured. And we think that if we find out the causes of cancers in infant, we may have a better understanding of the mechanism of carcinogenesis. So I work in a hospital which is very next door to Tata. It's a exclusive pediatric hospital with pediatric and neonatal subspecialties and all kind of super specialties. And because we have a very good intensive care in NICU as well as PICU, we get a lot of cancers, and even Tata mostly refers all the infant cancers to us because they do not have an intensive care unit here. So what are the commonest cancers in the neonates? It's neuroblastoma is the commonest, which is followed by leukemias. Other cancers include central nervous system malignancies, retinoblastoma, Wilms tumor, and germ cell tumor. And if we compare like female to male ratio, it's more common in the males, all the types of cancers, except for the JMML and ependymoma, which is in which males are more commonly found to be involved. Okay, and over the years, like this is a data from SEED from 1976 to 1994, there's a lot of change. So there is a lot of increase in the percentage which we have seen. And also in Wadia Children's Hospital, we have seen there is a great increase in the number of cases over the last 4 decades. But unfortunately, the survival in neonatal cancers is not as good as the pediatric cancers. So pediatric cancers have a much more better survival than the adult cancers. And we have survival rate of anything between 80 to 95%. So like Wilms tumor and many neuroblastomas and even leukemias are they do much better, but not so in neonatal cancers. Maybe probably because of their the immunity is not that good. Also, the side effects sometimes are much more in them. This is the data on the survival among the infants in the United States. This is a data over 40 years. They did show improvement in the survival. So neuroblastomas actually have a very good survival, especially in the infants and neonates. So it was like around 84%, and now it has gone up to 94.5%. But not as good in the leukemias, which was 26%, but now at least it's up to their 60% because there is better availability of the stem cell transplants. So I'll talk about only the 2 cancers which are the most common in the infants, which includes the leukemias and the neuroblastomas. So most common leukemias are acute lymphoblastic leukemias, and the overall incidence, so all type of leukemias are around 41 cases per million infants. Okay. So ALL forms the most common, which is 21. Acute non-lymphoid leukemias include 11. And then there are JMML, which is 3 per million, and there are some other unspecified, which are about 5 per million. So infant leukemias, as I mentioned, is rare. And the ALL amongst all the pediatric ALLs forms only 5% of the cases, and 6 to 15% of the AMLs is infant AML. The TALL is further less. And they differ from the pediatric leukemias because they have high extramedullary disease burden. They have a huge hepatosplenomegaly. They have central nervous system involvement as well as the skin infiltration. So you can see the figure on the right side. This is called as blueberry muffin lesions. So this is also called leukemia cutis. The blueberry muffin lesions are also seen in other conditions like CMV or congenital infections. And then the lower down figure is proptosis, which is commonly seen in the AML. This can also be seen in LCH as well as neuroblastomas. So what are the differentials? So especially for my pediatric colleagues here, if a child is presenting with very high count, what the differentials you should keep in mind is a leukemoid reaction. So that can be their leukemia reaction may happen in any case of severe sepsis. So there will be very high count, but this will resolve within a few days. Some of the hemolytic anemias, we have had many patients who were referred to us with anemia and leukocytosis. But then when we examined, or we saw their CBC report and we saw their peripheral smear, these were all normoblasts. Okay, so sometimes thalassemia is mislabeled as leukemia. So you should be very careful when you're dealing with a patient who's a baby who has got high counts. So ask for a good CBC report and a peripheral smear to have a differential diagnosis. And in the if there is a hemolytic anemia, there will be only normoblast, which is the premature erythroid series, and no blast will be seen on the peripheral smear. So this I'm not going to talk because there's no pediatric oncologist, but this is just a slide to say what are the types of genetic defects which are seen, or what are the genetic abnormalities, cytogenetic abnormalities seen in the leukemia, pediatric and infant leukemia. And how do we risk stratify? So there we group them as low risk, medium risk, and high risk. And this is important to do because that determines how we treat them. So it is important to know what is the high risk. High risk is MLL gene rearrangement with a baby presenting at age less than 6 months and a WBC count more than 3 lakhs. So if there is a baby who is presenting with high risk, this is how we treat. How, like, the low risk will go on to the routine chemotherapy. Intermediate risk may require a higher chemotherapy regime, while all the high risk patients will require a stem cell transplant. So what are the challenges we face? Because these diseases are more aggressive and their event-free survivals are lesser or worse than the childhood ALL. They may develop resistant clones to conventional ALL chemotherapy, like prednisolone. So like we see day 8 response in the when we are evaluating any of the leukemias, the day 8 response is usually poor in infant leukemia. There are unique vulnerability to complications and toxicity of chemotherapy. And because they are very small, radiation is not an option there. So usually we are going away from radiation from most of the childhood therapy, but like still if required more than 3 years of age, radiation is used. But these children, we can't use radiotherapy, and they may develop more late toxicities of high dose chemotherapy and stem cell transplants. This is the risk stratification. Again, I'm not going to go into the detail. For this AML, it is similar to what it is in the pediatric AML. So they are classified as low risk, intermediate risk, and high risk again. And low risk or the standard risk and intermediate risk go on to the conventional chemotherapy arm, while the higher risk are consolidated with transplants. So main important thing which we all should know is the supportive care therapy in the for the treatment. And so infections are the main cause or the leading cause of death. So we have to ensure that the infection rate is minimal in our unit when we are treating small babies like that. So then there can be a certain babies who may have congenital leukemia. So how it is different from the infant leukemia? So congenital leukemia will present within the first 4 weeks of life, and their prognosis is further worse. There is higher chances of relapse rates. And but the treatment is almost similar to the infant protocol. And then this is one interesting thing which I'm sure the neonatal colleague would know, is transient abnormal myeloproliferation, TAM. Okay, this is unique to children with Down syndrome. Only about 5 to 10% of infants with Down syndrome have this, and the underlying cause is a GATA1 gene mutation. They present with high WBC count, thrombocytopenia, anemia, and hepatosplenomegaly. They may have some blasts either on the peripheral smear or on the bone marrow examination. But the good point about this is that it's like more than 80% may undergo spontaneous resolution. Okay, so you may have to just monitor and just support these babies, and they may come out of it. Okay. How do we decide that which baby is going to come out of it? Again, we group them as high risk and low risk. High risk will have the presence of high WBC count, which is more than 1 lakh. They may have signs of liver failure with bilirubin more than 10 times. They may have increased transaminases. They may have coagulopathy and effusions. If any of these are absent, then it comes as a low risk. And for a low risk patient, you can just observe them, just support them, and no treatment is required. For the high risk, you just need to give some low dose cytarabine, and you have to just give it for a few days, and they again resolve. So it's easy to treat a patient with transient abnormal myelopoiesis, but then you have to keep them in close follow-up, because later on they may develop myeloid leukemia of Down syndrome. Again, JMML is a very unique entity for the infants, and it's very rare. In Vadia children, we see about 4 to 5 cases in a year. And this happens because of the dysregulated activation of the RAS signal pathway. So these are the mutation, PTPN11, NF1, KRAS, NRAS, and Sybil mutations. These are the ones which lead to JMML. And these are the symptoms. So what they present with us: pallor, splenomegaly, lymphadenopathy, skin rash, fever, and cough. And there are other diagnostic criteria in which the category 1 should be present in all, which includes, like, if the CBC should have absolute monocyte count more than 1,000, and the blast percentage should be less than 20%, both in peripheral blood and bone marrow. If it is more than 20%, then it will be put as leukemia. So either if there are lymphoid blasts, then it will be called acute lymphoblastic leukemia. If there are myeloid blasts, then AML. So in JMML, the blast percentage is less than 20%. Then I talked about the genetic mutations. If one of them is present, then it's a definite criteria. And there are certain which may or may not be present. So again, based on the genetic mutation, you may have, some of them, like the Sybil mutation, which is on the right extreme light, you can wait and watch. Don't need to treat them. Apart from, like, if they've got a very big splenomegaly, then you may need to treat them. Otherwise, you can just wait and watch. But there are certain mutations, like especially somatic mutations of PTPN11, KRAS, and NRAS. You have to straight away take these babies for stem cell transplants. Otherwise, the prognosis is very, very poor. So, as I mentioned, some of them may require chemotherapy, and similarly, like as I said, Sybil mutation can be you can wait and watch, but some of them have a very huge hepatosplenomegaly. You may require to give some small course of chemotherapy with 6-MP and cytarabine. So again, the prognosis here in JMML is unfortunately not very good, and many of the patients relapse even after this transplant. And the second malignancy, which is like the most common malignancy in the infants, is neuroblastoma, and I'll talk about that. But before that, what are the common malignancies and how the pediatric solid tumors are different as compared to the adolescent or childhood malignancies? So you can see the neuroblastomas and mesoblastic nephroma, hepatoblastoma, Wilms tumor are much common in the infant group, while in adolescent group, you can see that rhabdomyosarcoma, soft tissue sarcomas, germ cell tumors are more common. In the genitourinary, you can have, so germ cell tumors usually have 2 peaks. They can be present in the infants and neonates or in the adolescents. And head and neck, you can see that there is retinoblastoma and neuroblastoma, which is much more common, while in adolescents, rhabdomyosarcoma and nasopharyngeal carcinoma are much more common. And in thoracic, neuroblastoma. So the neuroblastoma is the most common tumor in the infants and malignancies in the infants. The good part is that in infants, the prognosis is very good for neuroblastoma. They usually present between 0 to 3 years of age, And there are certain genetic conditions which may be associated, underlying genetic conditions like neurofibromatosis 1, Hirschsprung disease, pheochromocytoma, or Turner syndrome. They may be associated with neuroblastoma. How do they present? So the neuroblastoma can arise from anywhere along the neural crest. So where is the site of origin? Based on that, there will be the symptoms. So if it is adrenal gland, the child may present with a lump in abdomen. There may be sometimes chest mediastinal mass. Some babies may come with like what is called as bruising around the eyes. We call it as raccoon eyes. And if it's stage 4, they may have fever and bone pains. And how do we diagnose it? So the radiology helps us to diagnose. We require first, we can actually go in for a USG abdomen and then followed by CT or MRI of the abdomen. And it's important to do a CT or MRI of the abdomen to define the image-defined risk factor, which I will come to. And then you need a CT guided biopsy. You will also require to do a PET scan and MIBG to see the extent of the disease. Bone marrow aspiration biopsy, if the PET scan is showing bone marrow involvement, you can get away with doing a bone marrow aspiration biopsy. And NMIC amplification is important to do because that will prognosticate the tumor. So this is the image defining risk factor I was talking about. It's important to know which are, so like in the cervicothoracic region, there could be tumor encasing the brachial plexus. So that makes it a high risk tumors. So in the thorax, there could be a tumor which could be encasing the aorta and or its major branches. So again, it becomes a high risk tumor. In the abdomen, there could be a tumor which is encasing again the aorta and vena cava. So these become high risk. So they become L2 category. And because they are high risk, because it's difficult to operate them. So these are the classification, we call them as L1, which can be easily, they are not involving any vital structure and can be easily operated. L2 is a leukoregional tumor, but there are image-defined risk factors. M stands for metastatic disease, and MS is a special stage which is seen in the babies. These are the different classifications. I think I will not go ahead with these ones. So MS is a special stage, disease, which I think for my pediatric colleagues and the neonatal colleague, they should know about it. Because these are again the tumors which may not require any treatment and they may just get cured on their own. So what are the criteria for a MS? This one is MS disease includes a distant metastasis in children who are less than 18 months of age. But the metastasis is only limited to the skin, liver, and bone marrow. Okay, and bone marrow also, like the involvement is less than 10% of the total cells, nucleated cells. And the tumor may be L1 or L2 morphology. Now, how do we decide which baby with a MS or 4S disease requires treatment? So there is a score which is called as Philadelphia score. In that, you have the scoring as score 1, 0, 1, and 2. And it includes, the points includes if the baby is having any vomiting, is there any respiratory distress, is there any pedal edema or sacral scrotal edema, is there any renal involvement or liver involvement. If the total score more than 1 in newborns or more than 2 in older infants, then it will require a treatment. Other babies, you can just wait and watch. You don't need to treat. These kind of tumors tend to resolve on their own. So for other babies, so apart from MS staging, the other prognostic factors include INRG staging, age, baseline LDH and ferritin, histology, NMIC amplification, ploidy, and segmental chromosome aberration. And then you classify them as again low risk, intermediate risk, and high risk. The treatment for them, for low risk, surgery is the main treatment. Some babies you may require to give chemotherapy. Intermediate risk, you usually tend to give chemotherapy first, try to shrink the tumor, and then surgical debulking. And high risk is a multimodal treatment, which involves chemotherapy, radiation, surgery, and also autologous bone marrow transplant. And with that, I will end my talk. So as I discussed only 2 tumors because I thought there are not many pediatric oncologists, and these 2 tumors are the common tumors. So I chose to speak about them. And there are some lessons, like we should at least pick up those babies who can be observed, and where we should be observing the babies or where we should be treating. At least if I am able to put that across, I think I have done my job. So childhood cancer patients, overall infant cancers have increased over the years. It could be either because we are diagnosing them timely, or there is increased referral, or it is possible that there is an increased incidence. Gender ratios have remained consistent. Incidence of hematolymphoid cancers has increased over the last 2 decades. Prognosis of neuroblastomas for infants is very good, but as compared to in the pediatrics, this is opposite. So most of the infants and neonatal cancers do not have very good prognosis, but it's opposite in neuroblastoma. Neuroblastomas in infants tend to do very well. And further workup is needed on identifying risk factors, exploring molecular characteristics, and planning primary prevention strategies. These are my references. Thank you for your attention. This is my team.
Thank you very much for the presentation. I just want to ask this question. I mean, how are you able to get these success rates? That means you are picking them up very early, most likely. In terms of, I mean, I don't know, you have more of neuroblastoma here. In where I practice, we have more of retinoblastoma in the newborn and in infant age group. But what I'm asking is, you have a very good success rate coming out, survival rate is being high. Is it that you picked I don't know the kind of what you operate. Do the people in the local setting, do they have those risk factors that when they notice, they can send? What do you usually tell them? Because what I notice is that they come very late. The bilateral lesions, all those things occur. Even in neuroblastoma you're talking about, they will come down with very sick babies, abdominal distension, and other things. So how did you pick them early like that? I mean, do you have the system in place?
Okay. Pediatrics, so more than 18 months, if there is neuroblastoma, they don't do well. This is the infant data. So less than 18 months, they do well. Like even stage 4 and stage 4S, they do really well. As I said, you may choose not to treat them also. Even stage 4 do well if they do not have the endemic amplification. So they do well. For references, we get, like, it's a pediatric hospital. Our hospital is a pediatric hospital. So anybody who is coming in for a checkup for all our pediatricians over there, so they tend to pick up fast also. So that also is one factor. But even if it's coming at stage 4, less than 18 months, they will do well. So you need to treat them aggressively. Like you need to give them chemotherapy and they will do well. All right, thank you.
I won't take much time of you guys. I'll just rush. It is a small topic, recognizing emergency care. Whenever a patient is coming to emergency, what are the tips and what are the signs you can actually see in the patient, and you can actually think this is a emergency care or this is a mild risk case or moderate risk case. I'm not going with the pathophysiology because oncology emergencies itself, there are multiple textbooks. When this topic was given to me, I had a PubMed search. Exactly when I have put these words, I had got 445 results. And when I searched oncological emergencies, there were results more than 6,000. So there is not much which I can tell more than about that. So, but I can classify. There is for the oncological emergencies, how to just stratify, we'll have a look. First, why we have to observe these oncological emergencies when the patient is coming to emergency medicine. It is the starting point of the hospital where a patient lands up in emergency, and providing a timely and effective intervention actually saves most of the lives and reduces the morbidity and mortality as well. And if at all any life-threatening complications, if you are seeing in the patient, you can address then and there itself, so that the patient will not go bad. So when you look into statistics, WHO statistics of 2018, I have taken because after that we had COVID. There were 2.2 million deaths in Asia and 0.7 million deaths from Africa in 2018. And American Cancer Society projections are there will be 7.5 million cases, new cases added to in 2021 and 1.1 million cases in Africa added. So oncological emergencies, why actually the cases are more and more coming every year is because of the improving lifestyles and because of the aging, the patients are getting aged and we are seeing more prevalence. Whenever there is more prevalence, more number of cases and eventually more number of emergencies we'll be seeing. So what do you call an oncological emergency? It is any critical situation that arises in a cancer patient requiring immediate intervention, which is potentially life-threatening if not intervened, and effective recognition and management strategies will impact patient outcome and overall quality of care. So the need for specialized emergency care, because the prevalence is increasing, the need for specialized emergency care is required, and we multidisciplinary approach. It is not, you are not the heroes in emergency. We will stabilize. Always emergency medicine bread and butter is airway breathing circulation. We will stabilize airway breathing circulation, discuss with oncologist or neurosurgeon and radiologist, put them in a loop and discuss the strategy, what we are going to do best for the patient. So the objectives of the presentation would be understanding how to understand common oncological emergencies and how can we recognize them, and any essential management strategies which we can start in emergency such that we can reduce the mortality and admit the patient and do best for the patient and patient's families as well. So cancer treatment overview, which I had already talked. Cancer is a complex disease which has diverse manifestations. So there are multiple oncological emergencies, almost 25 to 30 oncological emergencies are there, which we'll be seeing. So what are these impact on the patients of these oncological emergencies? There will be increased mortality. And whenever a patient is identified with a cancer, he will be subjected to a treatment by his oncologist. He will be subjected to a chemotherapy or planned for a surgery or planned for a radiotherapy. Suddenly, when he lands up with an oncological emergency, all his plans will be disrupted, and it will prolong the hospitalizations, it will reduce the quality of care, and it will be an economical burden on the patient and patient family as well. And patient will be leading to so much emotional and psychological distress. So if you have a look, just see in the slide, on the right side, there are almost 23 oncological emergencies. So we cannot discuss all the one together. We can all stratify into 4 major groups. Any oncological emergency, if you are thinking of it, it can be happening because of these 4 groups. Either it could be related to local tumor effects, which we can see as a malignant airway obstruction or metastasis or spinal cord syndrome or superior vena cava syndrome. Whenever there is a metabolic derangement, you can see the metabolic, such as take for example tumor lysis syndrome. Whenever a patient is subjected to chemotherapy, all his cells will lyse, and immediately there will be immediate metabological derangement such as hypercalcemia of malignancy, hypocalcemia, hyperphosphatemia, and metabolic acidosis. And patients with hematological derangement, such as patients who is suffering from this leukemia, such as there will be a huge tumor load and huge cell load in the bloodlines, which will be leading to hyperviscosity syndrome and thromboembolic phenomenon that we all know cancer patients will be leading to thromboembolic phenomenon. And relating to therapy, which we should not forget, always chemotherapy, radiotherapy, what we are doing, sometimes tumor bloat syndrome may cause, and sometimes there will be febrile neutropenia, neutropenic sepsis or mucositis or severe bleeding because of our treatment strategies. So when we see these oncological emergencies, this is the same slide which I have put in another listed. So let's think about important condition which will be coming to our emergency. The patient who will be switched on chemotherapy after receiving chemotherapy on the 3rd day to 2 weeks period, he will be calling you, doc, I have fever, what can I do? So we'll ask them to come and we will evaluate. So neutropenic fever, it is there are two subsets in this. It is neutropenia and it is fever. We know because of chemotherapy, neutropenia is going to happen. But when do you call it as a neutropenic fever? So by definition, less than 1500, when you are seeing the differential blood count, less than 1500 differential neutrophil count, if you are getting absolute neutrophil count, sorry, it is called neutropenia. So then you again stratify into mild, moderate, severe. Mild cases, you can actually treat on a OPD basis because it is a double-edged sword. Whenever you are admitting a mild case in hospital, he will be having a risk of hospital-acquired infections. So mild cases, risk stratified by MASC score, that is Multinational Association for Specialized Cancer Care Network. You will get the scoring, how to scoring in internet. It is easily available. It is a scoring for 23 points, and any scoring more than 21 is a mild risk. Any scoring less than 21, the patient is at high risk and you need to admit the patient. So coming to neutropenia, less than 1500, as I said, it is neutropenia. Then less than 500 is severe neutropenia. 500 to 1000 is moderate, and more less than 100 is profound neutropenia. Anything above 1000 is mild. Then any regarding the fever, when you talk about the fever, please remember more than 38 degrees Celsius, if at all the patient has for more than or equal to 1 hour, it is a neutropenic fever. Or more than 38.3 degrees Celsius, at least one single episode of rise to more than 38.3 degrees Celsius, you need to admit the patient because he is suffering from a neutropenic fever. Whenever you are identifying neutropenic fever, keep the patient. Don't forget taking blood cultures in the emergency itself. You need to have blood cultures, and empirical antibiotic can be started in emergency. After that, you can see for the blood sensitivity, and you can start a antibiotic, specific antibiotic after admission. So fever and other small symptoms like chills and rigors, fatigue, weakness, and whenever a fever is there, tachycardia we can see in the patient. So this is a small slide which I have got from emergency textbook. Low risk patients, you can discharge the patient whenever. Please see if a physician is available, which or the patient is able to reach the nearest physician for the next 3 days. If you are discharging, you can send the patient on oral antibiotics such as ciprofloxacin or amoxicillin. If there is any penicillin allergy, you can start on clindamycin. Whenever there is a moderate or severe neutropenic fever followed by sepsis, you please don't discharge the patient. Admit the patient in ICU, and you should start a broad spectrum antibiotic not lesser than piperacillin and tazobactam. And whenever you are suspecting any abdominal symptoms are there, please add metronidazole as well for the patient. So sepsis is another spectrum. This is a textbook definition: systemic inflammatory response to infection. Whenever is there, like how we are treating the normal sepsis patients, please treat the same way. Check for hypotension. If at all is there, fluid resuscitation to be started. And fluid resuscitation, if the patient is in shock, please start on 30 ml per kg fluids. And fluid, it is not responding, please start on a vasopressor, and your immediate vasopressor of choice will be noradrenaline infusion. Even the patient is refractory shock for both IV fluids and noradrenaline, please don't forget giving a shot of steroid such as dexamethasone or hydrocortisone 100 mg or dexamethasone 10 mg IV, followed by you need to give repeated doses in oncology patients every 6 hours, 4 mg IV. Okay. So this is due to local tumor effects, superior vena cava syndrome, very common. You will be seeing patients only upper half of the body will be discolored. The patient will have, because of the tumor burden which is compressing the superior vena cava, there will be venous congestion. You will be seeing engorged veins in the upper trunk of the patient, and you can ask the patient to try a Pemberton sign. Just ask him to lift his both fingers above his head, and patient face will be turning red in color. So this is called as a Pemberton sign, and which will be seen in superior vena cava syndrome. Commonest cause will be bronchogenic carcinomas and lung cancers. So clinically, they will have shortness of breath and headache and chest pain. Usually, whatever oncological emergencies, most of the patients most of the patients oxygen and BiPAP support or non-invasive ventilation will be initially sufficient unless the patient is completely collapsed. They will be supported by oxygen and BiPAP ventilation. And exact treatment will be discussed with your oncologist and discuss with your cardiologist also, because stunt placement is actual treatment for this superior vena cava, and the patient should be subjected to radiation as soon as possible. Tumor lysis syndrome, a common oncological emergency which we should not forget. As soon as the chemotherapy is started, the patient will be immediately brought to emergency with irrelevant complaints because of these metabolic disorders. Whenever the cell lies, everything is mixed in the blood. So you'll be seeing a sudden gush of hyperkalemia potassium, because intracellular potassium is more, suddenly it will be released into the blood. So you'll have a hyperkalemia symptoms, then hyperphosphatemia symptoms, and uric acid because of this kidney injury as well. And hypocalcemia. Whenever you are seeing hypocalcemia and tumor lysis syndrome, be vigilant. Don't run to start immediately calcium, because here the actual picture is the patient will have hypercalcemia as well. But because of the phosphate, what is happening is the phosphate is forming a calcium phosphate precipitate in the kidney, and it is getting lodged in the kidney in the form of nephrolithiasis. So immediately whatever calcium you are giving, it is going to be precipitated in the kidney. Unless there are cardiac abnormalities or arrhythmias, please don't give calcium in this patient. And if you are seeing definitely cardiac arrhythmias or any neurological symptoms, definitely we have to give a calcium gluconate. And this is the treatment of calcium. The hypercalcemia of malignancy, another common metabological emergency. The main treatment which we do in emergency is to rush out of the calcium by normal saline. Initial normal saline doses will be 1 to 2 liter initial bolus. Furosemide, please restrict the patients only for the patients who are in fluid overload. And palmitoronate zoledronic acid, these are bisphosphonates which we will not start in ED, but you can have a knowledge on this palmitoronate and zoledronic acid. And monoclonal antibodies you can consider whenever your bisphosphonate therapy is not actually working on the patient. That is, after admission, we will not start this monoclonal antibody and bisphosphonates in emergency. Our emergency will be like either subject the patient for IV fluids, or if it is not, if the patient is in fluid overload, subject the patient for dialysis. Spinal cord syndrome. Please remember, whenever a cancer patient who is subjected to therapy or diagnosed with a cancer complaining of back pain and severe back pain when he is lying on supine position, more than 80% of the patient is suffering from spinal cord syndrome. Either it could be spinal cord compression or spinal metastasis or vertebral metastasis is secondary, which we can think about it. And here, whenever you are suspecting like this, your x-rays are not going to helpful in any way. Subject the patient for MRI, and MRI, if it is not compatible or not available, please send the patient for CT myelography, and after that discuss with your neurosurgeon if at all any surgical improvement can be done, followed by radiotherapy. And whenever the patient is complaining of back pain, please don't forget giving a steroid dexamethasone 10 mg minimum, because here we want to avoid cord edema, because if you are not avoiding cord edema, slowly the patient is going to have a paraplegia or progressive muscle weakness, or slowly he will be going into bladder and bowel abnormalities, incontinence. Very common condition, chemotherapy induced vomiting. As soon as chemotherapy is subjected to the patient, he will have severe vomiting. So patient will be coming after starting chemotherapy, after discharge. Common, like for all patients how we are giving, you can consider serotonin receptor antagonistics such as ondansetron, which is very common, and granisetron. Please, whenever you are starting on an ondansetron, please take an ECG before giving an ondansetron, because QT prolongation we should not miss. And whenever it is refractory for all the medications which you are trying, you can actually try for benzodiazepines. And in literature, it is given dexamethasone you can give but 8 mg, but the mechanism for this anti-emesis is not known. As we all know, cardiology, cancer, whenever a patient is suffering from cancer, he'll have a lot of thromboembolic events because of hyperviscosity. He will be subjected to pulmonary embolism, DVT, or he can have, whenever the patient is on anticoagulants, he can bleed either through upper GI bleed or lower GI bleed. So whenever the patient is having thromboembolic events, please remember, talk to your cardiologist and dose stratify, risk stratify according to the Chadsworth score, and think about your anticoagulation, whether to stop or whether to give an antidote. And this is the same slide. Pain crisis. Whenever a pain patient come with pain, please address to the pain. Initially, you can have a NSAID such as diclofenac you can give to the patient. But the problem with diclofenac is NSAIDs, you cannot give how much ever doses what we want. So whenever the pain is not subsiding with NSAIDs, just switch over to opioids. The advantage with opioids is you can give multiple doses, you can escalate and you can increase the doses. But if you are sticking to NSAIDs, the dosage is minimum, and whenever you are giving more doses, it will be showing the pressure on the kidneys as well. So better pain control will be from opioids. Whenever a patient is coming with a respiratory distress, please address to the distress. He can be from lung metastasis or radiation pneumonitis or spontaneous pneumothorax as well. Address, support him on oxygen, bronchodilators. See if the patient is having any wheeze, please start on bronchodilators. And if at all it is not improving with your oxygen therapy and if efforts are increasing, you can start on non-invasive ventilation. Cardiac complications happens with all medications, which are all chemotherapeutic drugs are cardiac non-compliant. They are going to have cardiac complaints. What is going to happen? Immediately take an ECG, see if there is any arrhythmia and address to the arrhythmia. And if at all patient is having any arrhythmias, you can start on antiarrhythmic agents. Psychological emergencies, which we should never forget. The patient and patient family as well are going to go through severe emotional, psychological, and economical distress as well. Better to keep a social worker or counselor available in your emergency department or within the oncology department. You can call them and you can actually counsel the patient and keep a social worker along with the family member of the patient. So monitoring is very important. Whenever the patient is in emergency, please keep the patient to the monitoring, check his vitals before admitting. Record proper documentation is very important always. It will save you from severe medical aspects. So always emergency, like I said, don't try to be a hero. Keep everyone in the loop. Take help of wherever possible. You can take help. You discuss the case of oncologist, because oncologist will have an idea about the case because he will be treating the patient for a long time. Whenever the patient is coming to emergency, you just call the oncologist and tell like this patient had come. So he'll understand the picture. So you can take care of the airway breathing circulation and keep the nurses, tell the nurses to handle these catheters and indwelling lines properly. Talk to your pharmacist and to make the emergency drugs available. And you can talk to radiologist to send for an emergency MRI or CT myelography. And social workers and palliative care specialists, you should never forget. A coordinated approach ensures patients receive comprehensive care that address to the unique needs of the family and patients. So the key takeaway points from this presentation will be timely recognition of cancer patients' emergencies is very important. By the small tips, what we are understanding, we should never miss the basics. By that, you can actually stabilize the airway breathing circulation of the patient, and please admit the patient if it is a moderate or severe risk patients. So these are my references which I have collected, and thank you for being so patient. And if you have any doubts, you can reach up to me over email or WhatsApp. So I will be addressing you.
Greetings from Krishna Vishwavidyapit, Karad. As I told you, which was formerly known as Krishna Institute of Medical Sciences, deemed to be University Karad. To all of you, on behalf of our Chancellor, Dr. Suresh Bhosle, it gives me immense pleasure to be a part of this 10th edition of Merck Foundation, Africa, Asia, Luminary, 2023. Credit goes to Dr. Asha. Last time it was the proposal given by us. When I say us means on behalf of Krishna Institute of Medical Sciences, deemed to be University Karad, KVV, that why not to have this conference next time and it happened, and therefore I am here with you all. I always feel blessed that I am associated with Dr. Asha, CEO, Merck Foundation, President Merck More Than a Mother, and Krishna Vishwavidyapit Karad, because both these institutes are actually investing in the health for the well-being of the mankind. And they are contributing to the growth of the nations. And I think you all are witnessing that how it helps. Education is also another sector where they are investing, and that is another good investment for the development of the country. Dear friends,
welcome to Krishna Institute of Medical Sciences, deemed to be University Karad. Situated on the outskirts of Karad, we are well connected by rail, road and air. Our journey dates back to early 1980s when our visionary, late Honorable Founder Chancellor Sri Jayawantrauji Bhosle sowed the seeds of serving the society, which gradually turned this barren piece of land into 57 acres of tranquility. Keeping in tune with changing times, we have been growing since the past 40 years with 6 different faculties. Staying true to the vision of our legendary founder, we transformed into Center of Excellence under the able leadership of our Honorable Chancellor Dr. Suresh Bhosle. The university is ranked 73rd by NIRF in 2022 and also received various recognitions and awards. Medical College is ranked 42 by NIRF. It has the state-of-the-art museums with large collection of specimens and models, making it one of the finest and most well-stuffed museums in the country. A well-established simulation lab helps the students to gain advanced simulation training in situations like trauma, nursing and emergency responses. All lecture halls are well furnished and ICT-enabled tools with digitally interconnected with the latest technology. Our 1125 beds multi-speciality Krishna Hospital enjoys an enviable reputation and provides quality healthcare within reach of the common people. Upgraded and advanced diagnostic and imaging services like CT, MRI, mammography, etc. are offered for the patient care. There are 30 ultra-modern operation theatres with laminar airflow and 4 minor operation theatres for OPD patients, along with an exclusive cath lab facility. Apart from regular wards, super deluxe suites and master suites are also an offer for the patients. The academic infrastructure includes a modern and contemporary well-equipped central library. It is a digital library with an ambient seating facility along with research database and internet facilities and Wi-Fi. Well-furnished hostels, clubhouse with gym and indoor and outdoor sports facilities will spoil you for choices. A multi-level parking area and well-manicured lawns are a part of eco-friendly initiatives. A one-of-its-kind model physiotherapy college is a built-on green building concept and has a soothing ambience and spacious interiors and offers multidisciplinary rehabilitation services to all the age groups under one roof. The Faculty of Nursing Sciences is well equipped for skill training and audiovisual aids necessary for teaching and learning. Apart from the routine services, Faculty of Dentistry offers services like fast-track clinic, advanced diagnostic aids like CBCT, implant clinic, conscious sedation, customized comprehensive treatment with endodontic microscope, all at an affordable cost. A well-established Faculty of Allied Sciences offers UG, PG, PhD courses in microbiology and biotechnology. The latest inclusion in the university is Faculty of Pharmacy with advanced laboratories and classrooms, and its enthusiastic faculty are the main pillars of the institute. A media room for a telemedicine facility is also available. Equipped with the best that technology has to offer, we all welcome you to this self-sustained, eco-friendly and safe campus.
as I told you, our university is NAAC, NAAC, that is National Accreditation Assessment Council of India. We are graded with A+. And there are many other. I will skip that. Especially, I will talk about the Department of Oncology, where actually we initiated talks with Merck Foundation. Department of Oncology at KVV, with its most modern infrastructure, techniques, technology, and for the purpose of diagnosis, treatment, and palliative care, along with the team of oncologists, expert oncologists, they are always ready to provide easy and affordable access to the all cancer patients from the region of Maharashtra. I just want to tell you that we have an hospital exclusively for the training and a research center, that is the actually Department of Oncology. Its all services have been actually brought under the ambit of Krishna Cancer Institute and Research Center to do the research, to train the students for advanced training in subspecialties of oncology. So basically, what you see is that with this, it was next. Yeah. Next. On 7th, I still remember the date, on 7th December 2021, during this COVID, we signed MOU, an agreement basically to design the fellowships in the subspecialties of oncology. Next. And we started with surgical oncology, head and neck cancer surgery, carcinoma of breast, medical oncology, uro-oncology, pain and palliative care medicine, radiation oncology, and oncology nursing. These are the fellowship courses which we designed with the permission of National Commission of National Medical Commission of India, and we started training. And I'm very happy to tell you the first batch of 6 doctors you see here, they have already completed the training in 1 year of fellowship, and they are very happy to go back to the country. I think one person is going to be back today. So these are the doctors who have already been trained by us. Next. These are the nurses who received training, and you can see the countries from where they are. Malawi, all of them are from Malawi. These are the nurses who have completed the training. I am very happy to tell you that once I had an opportunity to have an interaction. Being a teacher, I always feel that the student should be interested in learning. Okay, and I was very happy to know that all these doctors as well as nurses, they were so keen in learning, and not only that, they were ready and eager to go back to their country and actually serve the nation. Next. Now these are the candidates, around 6 candidates. The training is going on at Krishna Vishwavidyapit Karad in various specialties and short-term training and all that. Next. Now recently, actually, the Merck Foundation has already started shortlisting the candidates for neurosurgery. I think yesterday, if you were there, you must have heard from our chancellor that our neurosurgery department is extremely well. It's well infrastructure and all that of its kind in country basically, and we are independently having 200 beds for neurosurgery. So I think this is a new opportunity, and the horizon of training has been expanded. Diabetology, we are doing this 1 year fellowship in diabetology, critical care medicine, and hypertension and cardiovascular medicine. These are the new areas that we have started training the student with the basically Merck Foundation. Next. Additional, now see what happened. We had a discussion with Madam Rasha, and she just asked, what are the other areas which you can, extend the training at Krishna Vishwavidyapit. So we have started fellowship in echocardiography. You know that now the doctors are doing investigation, and it's very important in field of medicine. It's not like dentistry, I am in dentistry, but keep that in mind. Without so there is a lot of training. We get doctors trained, but we don't get people who are trained in that. This is a fellowship. We are going to design very shortly, and we'll start training at the KB. Next. Now see, these are the short term training which will be designed for actually nurses, then technicians, assistants, and all that. Like for nurses, like critical care medicine, then emergency. Next. This is for technician, operation theater technician. You need a person who will assist the doctor. Dialysis and echocardiography, cath lab technicians, and ophthalmic. Next. This is for assistant, as I said, orthopedic. You know that now the problems related to orthopedics are day by day increasing. Medical coding, then geriatric assistant. So these are the areas which we actually want to design the courses. Next. Now this is the last slide to, I'm very happy to tell all of you, and then go back to your country. Keep in mind that whatever I have told you, our palliative care, pain and palliative care management and the center, ISMO has designated our center. That ISMO is European Society of Medical Oncologists, and our chancellor received the recognition in that direction. So basically, we are expert not only in oncology, but it is a medical university and the different faculties. So just keep in mind. Thank you so much for giving me time, because it is already 2:45. I promised him that I will finish in 15 minutes. Thank you so much. Thank you. See you soon again.
Thank you very much. Thank you for the kind introduction, and thank you very much for allowing me to spend some time with you this afternoon. As was said, my name's Tim Harris. I have a long-standing interest in syncope, and my background is emergency medicine and intensive care. So today I would like to talk a little bit about transient loss of consciousness, look at the epidemiology and pathophysiology of syncope, look at the causes, the assessment in the ED, and look at who to admit and what treatment, if any, we can offer. So transient loss of consciousness is a really common presentation to ED. In the UK, it's somewhere between 5 and 6%. And syncope is the commonest cause. Now, the first thing we need to think is, why is this patient unconscious? Is this from trauma? Is this psychological? Is this a metabolic problem, alcohol, drugs, or is this a syncopal episode? And each of these, of course, have a very, very different path that we will undertake in the ED. This talk is purely focused on syncope. Anybody recognize that painting? So this is Mary Louise, it was Picasso, and I'm going to use a few pieces of modern art to illustrate various points during this talk. So syncope is a symptom, not a disease. Our job really in the ED is to identify the underlying disease, and particularly if it's cardiac or sinister. And that's because cardiac syncope has got a mortality of around 1/3 at a year if not identified, whereas syncope with no cause has a background of around 6%, which equates to the age-matched population. Now, look, I'm sorry, this is a really wordy definition, but I still think it is the best definition of syncope. It's a transient, self-limited loss of consciousness, usually leading to falling, i.e. loss of tone, and the onset is rapid, and the recovery is spontaneous, prompt, and complete, and it's due to cerebral hypoperfusion. Now, this very strange picture is by Bridget Riley, and this reminds us that so many of our patients with syncope present with visual symptoms because the retina is the most metabolically active part of your body. So if you drop cardiac output, one of the first things you're going to see is a graying out or a confusion of your vision. So syncope is neurally mediated about 2/3 of the time, and by far the most common is vasovagal. Can also be situational, neuralgic, or due to carotid sinus hyperstimulation. And we're going to look at those in detail. About 1 in 10 are orthostatic, and somewhere between 10 and 1/3 are cardiac. And they're really the ones that worry us, because our job in ED is to identify high-risk disease and move it for treatment. Now, I don't care if you are interested in adults, children, or old people, you are interested in syncope. It's about 1 in 20 of ED visits, and it is somewhere between 1 in 100 and 1 in 20 hospital admissions. Now, I don't have the figures for India, for which I apologize, but in the UK, it was around the 75 admission rate 20 years ago, and it's still around half. The mean length of stay used to be 3.9 days. It's now falling to under 2. Now, syncope is so common, I think we question whether it's a disease process or just part of our physiology. Nearly half of the population at some time will have a syncopal episode, and around 1/3 will have recurrent syncope. And remember that in your elderly population, syncope may present as a 4 with a neck of femur fracture, distal radius fracture, etc. So this is Kandinsky. Kandinsky loves to play with light, just as the Impressionists did. And when I had my first syncopal episode, that's what I saw when I woke up. Unfortunately, I couldn't paint it. So this tells us that cerebral perfusion is around 15% of your cardiac output, and your brain is exquisitely sensitive to any change in cerebral hypoperfusion. Those of you that practice martial arts will know that a chop to the neck or squeezing the neck obliterates cerebral blood flow, and for as little as 5 or 10 seconds, that results in complete loss of consciousness. If you reduce cerebral blood flow by around 1/3, that will also reduce loss of consciousness. And indeed, if you drop your systolic to under 60, that will result in a loss of consciousness too. So this is a great video. I can't play it because I don't have enough bandwidth here, but if you Google goats and syncope, you'll find this wonderful breed of goats that have helped us understand a little about syncope. These goats have got really high vagal tone, and when surprised, that vagal stimulation causes them to faint. But don't worry, no goats were hurt in making this video. So neurally mediated syncope is a failure of autonomic regulation. Now, that may be resulting in bradycardia and drop of blood pressure and output, or vasodilation. So your patients may have pure bradycardia, pure vasodilation, or a mixture of both. And the commonest neurally mediated syncope is vasovagal, and that may be stimulated by a situation or by neuralgia. And the intense pain of glossopharyngeal neuralgia is a reasonably common cause of syncope. The other one that we perhaps need to consider more is carotid sinus hyperstimulation. And we're going to look at that particularly. Now, vasovagal, beloved of Victorian authors in the UK. There's a lot of words given to a simple faint or a vasovagal, neurocardiac, neurocardiogenic, but surely vasovagal is the best term. It just says what it does on the tin. It is an imbalance of your vaso and vagal, your sympathetic and parasympathetic nervous systems. As we've said, it's common. Alone, this occurs in about 1/4 of the population. It accounts for about 2/3 of all syncope you'll see in most EDs. And the great thing is, and the reason why I so like syncope as a disease, is half the patients you see in the ED, you can give a firm clinical diagnosis and manage expectantly. Now, a key point is myoclonic jerks are really common. Myoclonic jerks occur in about 9 out of 10 patients in syncope. This matters because often witnesses and paramedics may say, this patient was having jerking. I believe they're having epilepsy, not syncope. The key is myoclonic jerks are either symmetrical or asymmetrical and will finish within 30 seconds of the patient being horizontal. But of course, it can be very hard to tell the two apart. So why do people faint? Well, when you stand up, half a litre of blood leaves your thorax. You vasoconstrict to maintain cerebral and cardiac perfusion. Another 3/4 of a litre leaves the interstitium over the next 10 minutes. So as you stand up, you have a number of autonomic adjustments. And indeed, getting out of bed in the morning, it really is hard work. And of course, you rely on those low and high pressure aortic, carotid, and ventricular pressure receptors to detect those changes in cardiac output. Now, the exact mechanism we don't know, but something in our brainstem detects the hypercontraction of the ventricles, typically against an empty load. And for reasons we don't understand, although we can describe the pathway, this sees a shift towards vagal or parasympathetic over sympathetic tone. So carotid sinus hypersensitivity. Those of you that practice martial arts may be familiar that applying pressure to your carotid body sees your central nervous system register a very high blood pressure and rapidly cause vagal stimulation in order to counteract that. Now, as we get older, our carotid bodies become more sensitive to pressure. And we see this not from martial arts, but we see this from men putting on their ties, women putting scarves around their neck, etc., men doing up a tight shirt button. So history is key to diagnosing carotid sinus hypersensitivity. And this can result in either a bradycardia or a vasodilation, or of course, both. Now, the combination of hypersensitivity and syncope is carotid sinus hypersensitivity syncope, and it's very rare in patients under 50. Now, at medical school, we learned all about pressure in the abdomen. We learned about situational syncope. Syncope as a result of sneezing, coughing, blowing musical instruments, micturition against a hypertrophied prostate, or of defecation. And I'm sure all of you in the audience have seen this multiple times in your practice. Do remember that pain, and particularly neuralgic pain, is also able to stimulate a vagal response, as of course of any procedures such as rectal examination or proctoscopy. Orthostatic hypotension. So the definition of orthostatic hypotension is a fall of greater than 20 millimeters on standing, or a fall to less than 90 regardless of symptoms. And the combination of that fall in blood pressure combined with symptoms equal orthostatic syncope. Now, 90% occur within 2 to 3 minutes, but somewhere between 5 and 10% may take up to 5 minutes. And now, NICE in the UK suggests we do the blood pressure at 1 and 3 minutes. I must say, I do, my practice reflects that I also check at 5 minutes, and I check not just for blood pressure, but also for pulse rate, because a small number of patients will simply have an orthostatic bradycardia. Now, when I first got interested in syncope, postprandial hypotension was not well recognized. We now understand that this is a common disease in the elderly. After eating a good meal, and even more so if your good meal is washed down with a glass of wine, you will have a stimulation of your vagal nervous system, which again will result in bradycardia and hypotension. Indeed, one of my best ever diagnoses was in a restaurant in the south of France, when a lovely elderly lady had a huge meal, glass of wine, and you could see her just nodding off to sleep, and she rolled off her chair, having a syncopal episode, from which she made a full recovery, and I was able to explain to the family what was going on, and they paid for my meal, which is it's one of my favorite diagnoses. Everybody loves a free lunch. So some of you may have come across POTS, postural orthostatic tachycardia syndrome. This is a little contentious and is described by a orthostatic brady or tachycardia with a fall in blood pressure of 10 minutes of standing. Now, I'm not sure how you're finding this in India and Africa, but it's become almost a trendy disease, and we've got websites, and it's odd, but I'll have patients coming to the ED saying, I've got POTS and I need to be tested for it. That may or may not be something you see. Now, I'm mentioning that because the number of patients that we see that self-diagnose way outweighs the number of patients where we find objective evidence to make the diagnosis. Orthostatic hypotension in the emergency department should be assumed due to volume depletion until proven otherwise. The astute amongst you will notice that knife is going in at the wrong angle. This is a patient that we had to pick up 3 times from home because their personality disorder saw them like to insert blunt and sharp instruments into their abdomen. And one time we did see him, and he managed to breach his peritoneum. The rest of the time, the knife just laid subcutaneously. And this is to remind you that you do need to consider revealed or concealed blood loss. And the other thing not to miss here, of course, is melena, and that may take some hours before it becomes clinically apparent. The commonest cause of orthostatic hypotension, however, is not volume depletion, it's antihypertensive medication, and a small number are due to autonomic neuropathy, most commonly by far diabetes. Now, we do see a reasonable amount of neuropsychiatric collapse, i.e. histrionic behavior resulting in collapse plus or minus hyperventilation. Now, a quick pointer here is there's a lovely paper that shows hyperventilation itself increases your lactate. And certainly I see a lot of the junior doctors where I work do a venous gas, which is the only test we do on most patients with syncope, see the high lactate and become unduly alarmed. We do know that hyperventilation induces hyperlactemia. Now, the other thing to remember is, of course, psychiatric patients are often on a lot of medications that affect D and re cardiac polarization and give us a long QT syndrome. So while we do see a lot of psychiatric disease causing syncope, we do see these patients at increased risk of organic causes of medication-induced arrhythmia. So now let's turn our attention and look at cardiac disease, because this is really what interests us. Now you can see this is the right ventricle because it's full of lovely trabeculations, and the astute amongst you will see a tiny tumor lying across those trabeculations. This is a very rare tumor, but it is intensely thrombotic. And this heart belonged to a woman that presented with recurrent PE caused by that tiny tumor. Now, almost any cardiac disease, be tachy or bradyarrhythmia, can cause syncope. The commonest and least recognized is sick sinus syndrome, and I would caution you always to treat unexplained bradycardia in an elderly person as sick sinus till proven otherwise. We also need to look for structural heart disease. And of course, the thing that we're most worried about is the aortic valve and aortic stenosis. And you can see the aortic valve pictured over to the right. But again, almost any heart disease, ischemic, valvular, obstructive cardiomyopathy, PE, aortic dissection, pericardial effusion, atrial myxoma, pulmonary hypertension are all associated with syncope. Now in the UK, an echo is a second line test. The first line test is monitoring either in the ED or as an outpatient, because these diseases are relatively rare, but perhaps they're more common in your practice. Now, I'm going to turn my attention and look at a few more common diseases, a few rarer diseases that we absolutely do not want to miss. So you're in your ED and you get an ambulance call and there is a young man who's collapsed while running. Now, exercise-induced syncope is an absolute Red Bull. You should always consider exercise-induced syncope to be a guys, I'm just going to have to turn this off. Give me 1 minute. I'm sorry, there was some maintenance going on here. So exercise-induced syncope is a malignant cardiac cause till proven otherwise. Now, the most common of these is HOCM, hypertrophic obstructive cardiomyopathy. This is not a rare disease. It occurs in about 1 in 100 of the population. And if the patients present to you with syncope, then the chance of sudden death is around 1 in 100 a year. And, you know, these are young people, so it is not insignificant. May show hypertrophy or STT changes or an axis change. Many of you will be practicing echo. And while our NICE guideline in the UK says echo is a second line investigation, for me, anybody with exercise-induced syncope needs an echo. And if you can do that in the ED, all the better. Now, the treatment here is beta blockers, surgery, ICD, and ultimately, for those poor people where the disease progresses, transplant. Now, what can you see here? That runner, the paramedics picked up this VT, interesting pattern of VT, and the patient spontaneously reverted. And you can see this odd deflection in V1. What do you make of this? So this is an epsilon wave, and an epsilon wave is pathognomonic of right ventricular dysplasia. This is where the right ventricle will become dysplastic and replaced by fibrous tissue and will dilate up and become a good arrhythmogenic focus. Now, about half of these patients have a family history. This is increasingly recognized, but the disease was often lethal, so was more likely to present to the coroner and the pathologist in an emergency department. Now, about 8 out of 10 will have T-wave inversion of V1, 2, and 3 without a bundled branch block and an epsilon wave. The VT is a unique left bundle branch pattern and interestingly responds to adenosine. And from time to time, you may see a patient, much less now with ICDs, but 20 years ago, before they came commonly placed, patients may turn to your ED saying, if I go into VT, give me adenosine. This is why. Now, what can you see here? So this is long QT syndromes. Now, channelopathies, when I went to medical school, there were 2. Last time I looked, which was at the beginning of this year, there were 7 distinct channelopathies described. And there are increasing numbers of potassium channelopathies. Now, this matters because a lot of the medications we use, such as psychotics and macrolide antibiotics, are associated with channelopathies. And there's a lot of large studies that associate sudden death in young adults with these medications. The other thing to remember here is these VTs can be precipitated not only by exercise, but also emotion, and they're often to SARDs, and obviously that requires slightly different treatment. And what about this? Now, I'm sure many in the audience practice out in Asia and particularly out towards the Philippines and Indonesia, and this will be much commoner in your practice than it is in mine. This, of course, is Brugada syndromes, a distinct sodium channelopathy characterized by ST elevation in V1 and 2 and a polymorphic VT. This is increasingly recognized, and we understand that those ST changes may not always be visible on the 12-lead surface ECG, and any suspicion should be referred to cardiology for electrophysiological studies. This is a highly lethal disease. Now, let's turn to what we do in the ED. So history is absolutely key. It's one of the reasons I love this disease, because taking a good history gives you the diagnosis more times than not. So NICE, which is the National Institute of Clinical Excellence in the UK, an organisation to try and equalise the way we care for patients, notes that we need to look at the 4 Ps: posture, provoking event, prodromes, and pallor. And these are the features that make us consider vasovagal syncope. Nice quote, a lot of very well done observational studies that describe blurred vision that we mentioned earlier, and describe that palpitations post-event are very common, that it often occurs post-exercise, that jerking is common, and sweating and sickness and blurring and vision are common. Now, the exercise link here is really common. I'm sure all of you have watched the Olympics and you've seen those runners sprint across the line and get across the line, and they often claps. Now, I used to think this was a bit of drama. It's not. As soon as you cross the line and you stop running, your sympathetic nerves go woo, and your parasympathetic nerves shoot up, and you get vasovagal sympathy. So while exercise-related syncope is cardiac till proven otherwise, syncope post-exercise is vagal. Your history will also look at those obvious precipitants such as coughing and sneezing and micturition. Do remember head turning and pressure from carotid sinus hypersensitivity. Say it again because it's a take-home message. If there's no prodrome and the syncope occurred with exercise, or there's a family history of sudden death or syncope, please consider cardiac. Now, seizure is a common differential diagnosis. Seizures will be characterized by tongue biting laterally, but not anteriorly. Anterior tongue biting has no discriminative ability from syncope to seizure. You can consider looking at a blood pressure difference in both arms. It's not a particularly good sign, but it is ingrained into medical school and most of our nursing staff, and it may help you think of aortic dissection, of which 5 to 10% are indeed painless, or subclavian steel. And I'm going to just say this once for atrial myxoma. I'm still waiting to diagnose my first atrial myxoma, but if you have a patient that is horizontal, turns over in bed, and loses consciousness, do think of atrial myxoma and just grab your echo probe, because it is the easiest diagnosis. And if a patient presents to your ED with syncope from a large myxoma obstructing their mitral outflow, then they are very high risk of sudden death. Indeed, the cardiac surgeons tell me they would never let the sun set on an atrial myxoma. Now, another overstated differential is stroke and transient ischemic attack. And one of the biggest mistakes we see is the diagnosis of stroke where the diagnosis is syncope. Now, vertigo, diplopia, dysarthria do suggest stroke. And remember, if you've lost consciousness, your stroke is going to be either massive, in which case they're not presenting as syncope, or posterior circulation. Anterior circulation, TIA, does not cause a loss of tone and consciousness. So you're looking for symptoms of posterior circulation disease. And it is very, very rare to have a stroke that specifically takes out your vasomotor center without taking out something else. I've never seen it. So only suspect stroke if you have long tract or localizing signs. There are a few clinical pointers, and again, I've drawn this from NICE. If your patients have rapid, regular or rapid irregular heartbeat prior to syncope, and as their heart races more, they feel themselves grey out, that is a strong pointer of an arrhythmogenic cause. And as we've said, exercise-induced syncope is cardiac till proven other. If your patient is known to have untreated structural heart disease, then the relative risk, or the odds ratio rather, is 14. Syncope that occurs supine, as opposed to sitting or standing, is another red flag, as is no prodrome. If your patients are younger, if they're standing, if there's nausea, eye signs, or a feeling of warmth, or it's after exercise with a clear trigger, then you can be reasonably confident in a benign cause. So what are we going to do in the ED? So there are two great documents on this. The best, I think, is the European Society of Cardiology document, which is really goes beautifully to stop over investigation. And they point out that most vasovagal is a clinical diagnosis in ED, and if you've excluded pregnancy and anemia, depending on your population, and you've done an ECG, you probably don't need to do anything else. Most syncope with a sinister course is readily identified, and the syncope that is not readily identified is usually picked up by a good examination, listening carefully for heart sounds and a 12-lead ECG. Now, NICE does not recommend a venous gas. I must say, in my practice, I live in a very poor part of London, and I do a venous gas because undiagnosed diabetes, undiagnosed renal disease, undiagnosed anemia are very common. And of course, all of those may be useful in the diagnosis of the cause of syncope. Now, the ECG is the test you need to do. It doesn't give you the diagnosis that often, but it's the absolute key to risk analysis. So who do you monitor in the ED? Now, when I started my interest in syncope, we only had 6 monitors. Now I'm very lucky. I work in an ED where we can monitor every patient, so this is less of an issue. But in many parts of the world, monitors are still gold dust. So any patient that presents with exercise-induced syncope, syncope that follows palpitations, or a sinus brady, or bifascicular block, or a new bundle branch block, or indeed any bundle branch block, or QT repolarization abnormalities, absolutely needs to be monitored. We're going to talk about how long in a few minutes. Exercise, supine, syncope associated with breathlessness, or where there's no clear diagnosis, and arguably everybody over 60. Certainly in our population, elderly syncope is all monitored. So let's have a look at the other things we may do, the other tests we may want to do in a few of our patients. So if you suspect orthostatic syncope, you're going to do a lying and standing blood pressure. And as I said earlier, the NICE recommendations are lying, and you need to lie for 5 minutes before you stand, and then doing pulse and blood pressure at 1 and 3 minutes. Personally, I add 5 because there is some data that a small proportion of patients do not drop their blood pressure or pulse till after that. And in part, that's why we used to recommend tilt tables, although tilt tables are no longer recommended either by NICE or by the European guidelines. Now, one test I think we do need to consider more is carotid sinus massage. Now, in medical school, we learned fear of stroke. Now, in fact, the probability of causing stroke is very, very small, and some guidelines have actually removed contraindications such as listening for a bruit or history of stroke. Now, you can take that with as many pinches of salt as you like, but there's no doubt the risk has been overestimated. Now, what you're doing here is in patients that have syncope that you think is due to carotid sinus hypersensitivity, you're applying light pressure over the left, then the right carotid body. So that's at the level of the cricoid pressure, line with the sternocleidomastoid. And what you're looking for is 1, a ventricular pause of 3 seconds, because that patient needs a pacemaker, or 2, a fall in systolic of over 50 millimeters of mercury. Now, half the patients, you do this and you're going to have a clear diagnosis. But what do you do with the other half? Well, this is all about risk stratification. Your concern is who's got cardiac syncope, and that's because these have a high mortality. So what you're going to do first of all is, does my patient have a history of structural heart disease that's untreated? Now, by untreated, I mean, if you've got a patient with ischemic heart disease, you look at their cath, they had a focal LAD lesion, and they've now got a they've had an angioplasty and they've got a stent in situ, they've got treated cardiac disease. But if you've got a patient with known structural heart disease, there's a sensitivity of 95 and a specificity of 45% that the syncope is related to cardiac disease. And there's no harm in just saying, you know, I'm going to admit all these patients. Now, if your physical examination is normal, your ECG is normal, your venous blood gas is normal, then the probability of cardiac disease is very, very small, and these patients are stratified usually as low risk and discharged as probable vasovagal. However, there are some patients that you do need to be more careful with. So if you give a firm diagnosis, you're going to discharge the patient with advice. If you think it's likely non-cardiac based on history, ECG, venous gas, you can manage them expectantly. You may choose to follow them with GP, you may choose to follow them outpatients depending on your resources. Now, if a patient had a serious injury, neck of femur, fractured wrist, or then a high-risk profession, taxi driver, pilot, then you're going to have to investigate these further. Now, we're going to talk a little bit later about how we investigate them, because it's either with a Holter or an external implantable loop recorder. And these recommendations are changing rapidly as our external loop recorders become more and more advanced. Now, what I would like to say is there is an overestimation of neurological disease causing syncope. Syncope is a cardiac disease. It is not a neurological disease. And for most patients, there is no justification for CT brains, duplex carotids, or EEGs. Now, what I'd like to do is run through a few key papers. Some of these papers are quite old, but these are the papers I think if you're interested in syncope, you need to know because they may help you make decisions. So the SEEDS paper was published nearly 20 years ago. The SEEDS paper was a single center randomized trial that looked at intermediate risk patients, and that's patients that you can't clearly diagnose. They don't definitely have a vasovagal syncope, and you're not sure if they need further tests. So it took this intermediate group, so that's not patients that have clearly got a problem with their heart, such as structural heart disease or new bundled branch block or QT. They're not patients with a vasovagal, they're in that intermediate group. Now, in this group, often patients are admitted to hospital. The trial that is underway here was to say, do I admit these to a dedicated CDU or hospital? Now, that CDU was set up as a dedicated syncope unit. They had access to a tilt table, no longer recommended. They did carotid sinus massage. They did an echo. They had continuous monitoring, and they did a review of medications, and they did serial orthostatic measurements. Now, the patients that were randomized to ED care in their dedicated CDU had an increased diagnostic yield. It's not a surprise because often patients that are admitted to the ward with syncope are simply on a normal ward with a monitor and nobody's watching it, and nobody's dedicated the alarms to look for syncope, i.e. to look for a period of bradycardia or a period of an SVT or AF or whatever. So this showed us that the syncope unit run by the ED improved diagnostic yield, reduced costs, and reduced inpatient. Now, a similar trial, slightly more recent, but again set out in the US. This is a multi-center trial with very much the similar aims to the SEEDS trial. Now, they only recruited 124 patients, real surprise given how common syncope is. And they again looked at that intermediate risk. Now, they defined it as 50-year-olds with syncope or near syncope that didn't meet criteria for coming in, didn't meet those ECG criteria we met earlier, but didn't have a clear diagnosis of vasovagal and had risk factors, cardiac disease, age, or palpitations before their event, or exercise related. Now, these patients were observed for 12 hours and got an echo as required, an orthostatic test as required. And again, the ED observation protocol reduced admissions, reduced length of stay. And this study, unlike SEEDS, did a longer term follow-up, and there was no difference in the long-term follow-up in the quality of life or patient satisfaction. So those are two studies that may help you if you want to set up a unit in your ED. Now, the biggest single mistake I see in the UK about care for syncope is the overuse of CT brain. Now, it's a little bit like vertigo, and in vertigo and syncope, experts are really clear. CT brain is not a routine test. It has a very specific remit in a very small number of patients. So this is a systematic review of over 3,000 patients, 17 observational studies. So the CT is abnormal in somewhere between 1% and 4% of patients with syncope. And most of the abnormalities found are nothing to do with the syncope. They're incidental findings. Now, not surprisingly, you can predict who's more likely to benefit from a CT brain: older people, abnormal neurology, trauma, anticoagulation, or patients that indeed have a history of falling. And that's often the problem is, oh, my patient had syncope, they fell and banged their head. Do they need a CT? And that for sure is a case-by-case judgment. I would say what we need is a decision rule to help us choose who needs a CT brain. Now, the next overcooked test is troponin. Now, troponin is a great measure of badness, and that applies for almost every medical condition. This is a systematic review by colleagues in Australia that looked at 9 studies where syncope was measured, troponin was measured in the assessment of syncope. Now, 1 in 5 patients with syncope will have a troponin outside the normal range. The number of patients where syncope is caused by cardiac ischemia is minuscule. The number of patients where syncope is caused by cardiac ischemia that does not declare itself with a malignant arrhythmia or breathlessness or chest pain is very, very small. I could count on my hand the number I've seen in 30 years. So a raised troponin may help you identify higher risk patients, but it seems to add very little to the ECG. However, we have this beautiful study, and this is one of the most elegant studies of syncope I've ever seen. It's by a Swiss group that did a multi-center European study of just shy of 1,600 patients. And again, they looked at intermediate risk designed by cardiac factors, by age, by presenting complaint. And they did troponin and BNP in all of them. Now, what they did here was they said, how good are these tests at risk stratification? And they set a pre-specified 95% sensitivity specificity rule for ruling in and ruling out cardiac syncope. And what they say here is in that intermediate group that the use of a BNP and a troponin may be useful to rule out cardiac causes. Now, I don't think we're quite there yet, but this is interesting because this may allow us to, you know, you're an intermediate risk group and I can measure you as an out, not an in patient. The problem here is, as we've said, one of the missed groups is sick sinus syndrome, particularly in the elderly, and that group was not picked up. So while it's interesting and while there's a signal that is concern that applying the use of troponin as a you can go home tool, a get out of jail card in the ED, may risk us missing important disease. So I've mentioned the European Society of Cardiology guidelines. This is their approach to syncope. They divide into high risk, where you come into a monitored bed, low risk, where an arrhythmia is quite likely but not life-threatening, and they say use an internal loop recorder. Low risk again, internal loop recorder, and then very low risk, where that presumed is where you've made a diagnosis of vasovagal, home, no need to monitor. NICE guidelines in the UK are similar. NICE suggests that we use a Holter, i.e. a external recording device, which should be on for a minimum of 48 and preferably 72 hours. This is not a 24-hour tape. That is only useful if your patients have transient loss of consciousness several times a week. They suggest that if it's 1 to 2 weeks between transient loss of consciousness, use an external loop recorder. And if it's less than every 2 weeks, fit an internal loop recorder. And certainly in the past, we fitted these in our ED. And they also say, you know, most patients with syncope, the cardiac disease you're looking for is an arrhythmogenic cause, not a structural cause. So they say echo is just second line. Now, when I started to teach syncope, most of my talk, well, about half of the talk, was made up of running through the clinical decision tools. We now know that no clinical decision tool has really proven to be sensitive and specific enough for general use. And when you compare those decision tools to an experienced clinician, the experienced clinician outperforms them. And it's not a surprise, any clinical decision tool will rely on typically 3, 4, 5, 6 factors. An experienced clinician will use all their historical and all their investigational knowledge, and will perhaps use 10, 20 or more factors in their decision making. Now, the best performing decision rule is the Canadian syncope score. I've put that up in detail because it does outperform the others. And I think if you do want a decision tool, this is the one I would suggest you use. However, it does rely on a lot of clinical judgment compared to the others. It says, are the vasovagal symptoms? Now, it does define them. History of heart disease, again, not defined as well as it might be. Extremes of blood pressure, and this they do use the troponin, and they use a fairly complex ECG analysis. But of course, that EG analysis will be available to you from your machine. And again, they say if you've made a firm diagnosis of vasovagal in the ED, -2. If you made a diagnosis of cardiac syncope in the ED, +2. So low risk is less than nearer, intermediate is 0 to 5, and high risk admission is greater than 6. I use this, but I use this more as an aide-memoire, and it would be fair to say it's not been embedded in the EDs where I work. Now, this is one study I wish to highlight because it concerns me. Now, this is a New England paper that looked at the incidence of pulmonary embolism in patients admitted with syncope. It's an observational cohort study in 11 hospitals in Italy, and it looked at patients for admission from the ED to answer the question, are we missing PE? Is PE a much commoner cause of syncope than we think? Now, this was North Italy, high proportion of elderly people. In this trial, they took best part of 2,000 patients that were presenting with syncope. They then took the 717 that were being admitted to hospital. They excluded those that were anticoagulated, those that had AF, those that had clear other reasons for syncope. That left them with 560 of their original cohort. They then did a D-dimer and a CTPA on those studies, and they concluded that 230 had a high pretest probability and 97 had a pulmonary embolism confirmed. Now, this, of course, is rather shocking because that's a very high number of pulmonary embolism, and that would concern us and make us think, wow, should we be evaluating this population much more extensively for pulmonary embolism? I would argue, no, we should not. One, subsequent papers have not borne out these results. Two, we know that PEs occur asymptomatically in a high proportion of the population. If we look at post-mortem data in hospital, around 1 in 3 patients have a PE of varying sizes. And when we look at the CTPA data, we can see that the bulk of these clots were small and could not have caused syncope. They were incidental findings. So this New England paper is disconcordant with what most of us observe in practice. It's disconcordant with subsequent trials. And I think, again, we're looking for a disease that may be an incidental finding. Of course, PE can present with syncope, but PE that is big enough to present with syncope is going to give you symptoms or be visible by a large RV on echo or S1QT3 on your ECG. So I think the use of a D-dimer and CTPA in an unsolicited, unselected group is not justified. I cannot agree with the paper's findings. So finally, let's look at treatment. So for most patients, you're going to tell them it's a vasovagal, you're going to give them advice, you're going to tell them to avoid stressors, keep hydrated, avoid prolonged standing, avoid temperature change. If you feel giddy, faint, if you feel your eyes graying out, take an aborting maneuver. An aborting maneuver is lie down. It does not mean sit with your head between your legs, which just increases your intra-abdominal pressure. I have no idea why that came as an aborting maneuver. An aborting maneuver is get horizontal, restore your cerebral blood flow. Now, for those who suspect vasovagal but can't make a firm diagnosis, we used to suggest tilt table. That's no longer suggested. And for those with recurrent vasovagals, you can consider medication, you can consider a high salt diet, a high volume, but there's really very, very little data for these. And personally, the patients that are so troubled by vasovagal syncope, I will be sending to one of my cardiological colleagues with an interest in that disease. For me, I would not start medication. I simply don't have the expertise to do that. So all cardiac syncope warrants a specialist opinion. Whether that's as an inpatient or outpatient will depend on your resources. Please do remember carotid sinus hypersensitivity. Remember, a 3-second pause is a pacemaker. Please remember orthostatic hypotension. Please remember that a small proportion of patients will take up to 5 minutes to drop their blood pressure. Please remember to think of occult bleed, such as GI bleed, but most of these will be drug-induced. Now, we're all from a variety of countries. In the UK, if you discharge a patient from ED with a clear diagnosis of vasovagal, they can return for driving. If you refer them for an opinion, then the DVLA, our driving authority, says, well, there's no clear diagnosis. They must not drive again until they've seen the specialist. Now, that can have a huge effect on people's lives and livelihoods. So what's changing? Well, I think the things to watch are, what is the role of BMP? What is the role of troponin? And we've seen one large trial, and that trial is continuing. It's a database study. We've also seen a number of studies quite recently published, such as the iPad, that look at devices that the patient can hold on their chest or strap to their chest or place on their chest immediately post syncope that can then go to the phone. I've done a number of these trials, and they could either come to my phone or my monitor in the office, and we could then play back the arrhythmia. And if the patient had a high risk arrhythmia, run of VT, run of SVT, run of AF, we could call them in. So in summary, syncope is a common cause of transient loss of consciousness. It is due to cerebral hypoperfusion. The easy way to characterize it is neural, orthostatic, and cardiac. Your job in ED is to make a diagnosis and to risk assess your patients. You're risk assessing to try and pick up those with cardiac disease. Half the time, you're going to make a firm clinical diagnosis and discharge your patients. The ECG and a period of monitoring is key. There is no evidence that monitoring for more than 12 hours adds to diagnostic yield, and that is one of the many facts behind those 2 studies I showed you, the SEEDS and the multi-center trial. I use the mnemomic HERS to think of my patients. I like mnemomics. It's the way my mind works. It gives me structure. So when I see someone with syncope, I think, have they got heart disease, particularly if they've got a low ejection fraction? Because the lower the ejection fraction, the poorer the cardiac performance, the higher the chance that the syncope is cardiac related. Have they got an abnormal ECG, particularly Q waves, bundled branch block, 2nd or 3rd degree block, and that thing we miss most, sinus bradycardia? Are they aged? And was the syncope related to exercise? Was it sudden with no prodrome? Was it supine, or has it resulted in external injury? If my HERS is positive, I will evaluate the patients further. So, ladies and gentlemen, I am going to thank you very much for your time, and I'm going to ask if there are any questions that you would like me to take. And thank you very much to the organizers for this invitation. I will stop sharing my screen now.
Good afternoon, everyone. So today's topic for the discussion is actually pulmonary rehabilitation in patient with chronic obstructive lung disease, a part toward the better breathing. So chronic obstructive pulmonary disease is a common disease with persistent respiratory symptoms and respiratory limitation. COPD is it is not only the lung disease, it's a multi-system inflammatory disease. According to the CDC, COPD is the 3rd leading cause of death. COPD is one of the progressive and debilitating respiratory disease leading to the severe burden on the individual and society as well. COPD is a major cause of chronic respiratory, chronic morbidity and mortality throughout the world, and it is third leading cause of the global disability adjusted life years. That is a Delhi. Among the non-communicable diseases, various concomitant diseases which are encountered or seen together with the COPD, like hypertension, chronic coronary artery disease, diabetes mellitus, obesity, and other diseases, which also receiving n number of medication or other kind of therapy for their management, which add the additional management of COPD in this patient. Recent year, it has been observed that new program model that has actually aimed toward the improvement of patient with the COPD through pulmonary rehabilitation, like a tele-rehabilitation, which is a little bit low cost and home-based model and more comprehensive, and it is better for the patient, those who are not able to attend the hospital or able to travel towards the hospital. Pulmonary rehabilitation are organized according to the patient, his or her need, because every individual is of different subset of trait, because they are having different problems other than COPD, like a hypertension, diabetes, coronary artery disease, and so other comorbid condition including stroke. According to American Thoracic Society and European Society, pulmonary rehabilitation is one of the integral component in the management of patient with COPD. Pulmonary rehabilitation is it's a multidisciplinary and multimodal approach to improve the quality of life in patient with COPD. Overall, pulmonary rehabilitation is a comprehensive intervention based on the thorough patient's assessment, followed by the patient-tailored therapy that include but not limited to exercise training, education, behavioral changes, and designed to improve the physical and psychological condition of patient with COPD and to promote the long-term adherence to the health-enhancing behavior. The objective of pulmonary rehabilitation is to achieve the maximum level of independence, autonomy, and function of the patient by the targeted therapy and intervention provided by the dedicated interdisciplinary expertise. If you see the pathophysiology of the chronic pulmonary lung disease, it's altogether contribution done by the environmental pollution, biomass fuel, cigarette smoking, aging factor, reduced physical inactivity, and lung inflammation. So altogether, ultimately, it leads to the thing which is called as a hypoxia, and the spillover effect of this systemic, this lung inflammation through different cytokines like interleukin, beta interferon, interleukin 6, interleukin 18, and tumor necrosis factor alpha, and other acute phase reactant will affect the skeletal muscle, which causes ultimately weakness and cachexia. Then cardiovascular disease, which promote the coronary artery disease, chronic heart failure, chronic cardiopulmonary hypertension, metabolic diseases like diabetes, metabolic syndrome, and related disorder, then obesity or overweight, and indirectly affect the bone disease and osteoporosis, which ultimately because of a osteopenia. The COPD ultimately result of ventilation perfusion mismatch, which ultimately causes the reduction in oxygen content of blood, probably plus minus effect of retention of CO2 and abnormal ventilatory mechanism, which indirectly manifested by the reduction in FEV1 and airway narrowing. There is a definitive reduction in the elastic recoil or hyperinflation in the lung in patient with COPD. There is a definitive ventilation perfusion mismatch, reduction PaO2, reduction in pH, increase in PCO2, reduced in ATPs, increase in lactate, and reduction in increase in CO2, which ultimately lead to muscle deconditioning and muscle fatigue. The ventilatory insufficiency ultimately lead to difficulty in or inadequate gas exchange, muscle deconditioning, exercise limitation, and dynamic hyperinflation. If you see the flow chart of the pulmonary rehabilitation, it is one of the important pillar in the management of pulmonary rehabilitation and conditioning of patient with COPD. Central desensitization to the dyspnea is integral part of pulmonary rehabilitation, which is required to be emphasized and has been quoted in gold guideline also. Reduction in dynamic hyperinflation and improved skeletal muscle function, promotion of healthy lifestyle, cessation of smoking, reduction in anxiety depression related with the COPD or disease, adherence to the treatment modality including exercise and beta-2 agonist on other drugs, exercise training and breathing retraining, education and proper nutrition all are the important part of the pulmonary rehabilitation program. So if you see the objective of pulmonary rehabilitation, main objective is to improve the quality of life or health related quality of life, reduction in frequency of frequent hospitalization and improvement in the recovery in the hospitalization over period of short duration, improvement in the exercise endurance to reduce the fatigue and muscle weakness, reduce the anxiety depression, to reduce the dyspnea, improve lung function capacity, and ultimately improve the survival of patient with COPD. Always it is important to reassess patient because each individual patient with COPD, they are having certain different types of comorbid condition, their musculoskeletal problem, their neurological problem, their coronary artery, cardiac reserve, and so many factors are important to be looked toward. So among this, before choosing the pulmonary rehabilitation program, it is better to reassess and re-evaluate patient so that they will be fit for doing the adequate amount of exercise, and particular type of exercise can be advisable to this patient. So cardiopulmonary exercise stress test to measure the oxygen level of the and blood pressure and heart rate in response to exercise is very important. Having a adequate clinical history, examination finding chest radiogram, hemoglobin level, electrocardiogram, creatinine level, BSL. These are the important basic parameter which we should look before assigning patient for the pulmonary rehabilitation. And as and when required, two-dimensional echocardiogram and arterial blood gas analysis also we should do it for this patient. So before going ahead with the pulmonary rehabilitation or exercise, it is better to have a baseline spirometric analysis or their parameter, so that particular individual can be advised to have a particular level of exercise. Diffusion capacity for CO, assessment of cardiac function and other comorbid conditions which are directly or indirectly going to affect the implementation of pulmonary rehabilitation program are also should be stressed down. Exercise capacity testing like a 6-minute walk test also you can do as a bedside test, which will give you the better and rough idea for the planning of pulmonary rehabilitation and exercise. Then selection of patient for the pulmonary rehabilitation, that certain condition which you should exclude as a relative contraindication, like angina pectoris or recent myocardial infarction within 6 months or 1 year, congestive heart failure on diuretic therapy, psychiatric illness, dementia, or other cognitive deficit, inability to do the exercise due to some orthopedic problem, severe exercise induced the hypoxia, which is not corrected with the oxygen supplementation. These are the, you can say, relative contraindication to avoid for the pulmonary rehabilitation or exercise. Then there are different modalities of pulmonary rehabilitations are there, like cardiopulmonary exercise testing, selection of training modalities, different modes of exercise training, like aerobic training, continuous endurance training, interval training, single leg cycling, resistance training, non-linear periodized exercise, neuromuscular electrical stimulation in patient with COPD, training with supplementation of oxygen or non-invasive ventilatory support, pulse inhaled nitric oxide in rehabilitation of COPD patient with pulmonary hypertension, lung volume reduction surgeries or manual or procedure also can be adapted for certain individual. Then adequate and proper nutritional support is mandatory in the patient with the COPD before planning for the pulmonary rehabilitation program. So in endurance or conditioning training, stationary cycling, treadmill, free walking, breathing retraining, ventilatory muscle training, resistance strength training, transcutaneous neuromuscular electrical stimulation, interval training, alternative exercise modality, and you can modify this modality depending upon the need and capability of the patient and their co-associated comorbid conditions. Pulmonary rehabilitation is not done by the single individual, but multimodality, different individual required to be get involved as a team. So physiotherapist, occupational therapist, respiratory therapist, exercise physiotherapist, nurses, psychologists, behavioral therapists, specialists, nutritionalists, social worker. These are the n number of people actually required to be there in the team of pulmonary rehabilitation. So there are certain equipment or prerequisite are required before planning for pulmonary rehabilitation program, like exercise equipment which require treadmill, stationary bicycle, access stair or step box, arm crank ergometer, hand weights, resistance training bands and weights, cycle ergometers and treadmill for the endurance training, and weight machines for the assistance resistance training. And for the monitoring of the pulmonary rehabilitation and cardiopulmonary status, we require to have a pulmonary oximeter, sphygmomanometer, tape, and measure for the incremental shuttle walk test. So at least minimal duration of pulmonary rehabilitation program of one setting should be around 8 to 12 weeks, so that you can reassess and modify the pulmonary rehabilitation and exercise program according to the need and feedback from the patient and their improvement. In conclusion, pulmonary rehabilitation should be started as early as possible, because as we delay the pulmonary rehabilitation, the muscle weakness, fatigue, and hypoxemia, and the disease as such will progress from moderate to severe condition, in which we may not be able to program the pulmonary rehabilitation adequately. Pulmonary rehabilitation improves symptoms, quality of life, and may improve the survival in patient with COPD. Pulmonary rehabilitation is one of the underrated, or you can say little bit neglected part of management in the pulmonary rehabilitation because of many reasons. Patients with less severe disease are likely to get more benefit from the reduced in the form of reduced the dyspnea, improved exercise tolerance, improved muscle strength, conditioning of the muscle or endurance, improvement of the cardiopulmonary functions and physiology, reduce the dynamic hyperinflation of the lung that accompany the pulmonary rehabilitation program. The contraindications are mainly, they are relative, like severe angina, mild angina, and severe and strict contraindication will be a severe LV dysfunction or untreated angina, or having a significant coronary artery disease which is not treated, significant orthopedic problem, or significant neurological disease because of which they are not able to do the muscle exercise or limb exercise. The recent guideline have recommended the consideration for the referral to the pulmonary rehabilitation for the stable, moderate to severe COPD as a defined by the GOLD report. Pulmonary rehabilitation is definitely an underutilized tool which should be emphasized to have emphasized and utilized in better way for the improvement of morbidity and mortality in patient with COPD. Pulmonary rehabilitation is one of the core component in the management of COPD at large. So these are the references. Even though this was a simple topic, the things which has been covered are relatively less utilized, and many people, many individuals are unaware of use of this pulmonary rehabilitation program or this different center. Definitely the resource limitation or awareness is definite important hurdle for implementation of this pulmonary rehabilitation program. Thank you very much. If you have any question, please go ahead.
Thank you very much, Dr. Patil, for your presentation. I just have maybe two questions. I think some of which you've already responded to. I wanted to ask, as India, how is your uptake of pulmonary rehabilitation amongst your patients, and also how likely are other health practitioners to actually recommend or refer patients for pulmonary rehabilitation? That's my first question. And then the second one is to say, I think for Africa, COPD is not very common. One of the things that we are battling with is TB. And because we have a high burden of TB, we also have some that we have sort of neglected, which is post-TB disease. Have there been any studies in India, because I know India is one of the countries that is also highly burdened by TB. Have there been any studies to actually find out if pulmonary rehabilitation is actually effective in patients who have post-TB disease? Those are my two questions.
Okay. So we are working in tertiary care institute, which is one medical college. What we have observed, the patient with COPD, you can say almost 6th or 7th patient in winter and rainy season is presenting to the OPD for follow-up as a exacerbation of COPD. So identification of exacerbation which require admission, identification or triaging patient, those who can manage at level of community with simple rehabilitation program like exercise, limb muscle exercise, which can be done at community level where there are a limitation or a resource limitation, can be done easily at the level of community, which prevent the recurrent and frequent admission and unnecessary antimicrobial agent treatment, or increase in the beta-2 agonist and other modality treatment, which will also affect the adverse reaction on the patient. So if patient require admission in the hospital, we have a team which will take care of the pulmonary rehabilitation in the form of limb exercise, respiratory muscle exercise by the respiratory physiotherapist, and they also help them to how properly perform the spirometric exercise, which will definitely reduce the duration of their admission to the hospital and indirectly the expenses on the frequent exacerbation.
Thank you, Prof. Thank you, Professor. Any other questions?
We have online, there is one if you want to.
Okay, thank you very much, Prof. We shall release you now.
Next.
There's a question online.
Yeah, if you want to.
Okay, there's a question online. It says one of COPD rehabilitation are also vaccinations such as pneumococcal above 60 years old and annual influenza. How are they promoted?
Pardon me?
Should I repeat the question?
Can you repeat?
There's a question online.
Okay.
And it says one of COPD rehabilitation involves vaccination with pneumococcal and also influenza vaccine. How are these promoted in India?
Okay. So various vaccines which are recommended for the patient with the COPD, say pneumococcal, H influenza, or swine flu, H1N1, and in recent past we had a COVID. So actually these are the high risk people, those who are prone to acquire a pulmonary infection, but the awareness and the you can say the accessibility for receiving these vaccines are still limited. It is not been used routinely in the rural area. In certain developed part in metros, the people, those who can afford, they definitely receive this vaccination in patient with COPD. Even though it is not a part of a actual pulmonary rehabilitation, it is more of a prevention and treatment management of frequent exacerbations.
Thank you.
Yes.
Great. Well, thank you very much for the opportunity to speak to you today. It was a very specific request, Raynaud's and migraine and the association with connective tissue disease. So it's not a lecture I've given before in that specifically, but it made me go back and review all the literature, and there are some common themes to go through. So Raynaud's, migraine, and connective tissue disease. So first of all, I'll cover Raynaud's phenomenon and Raynaud's disease. And so the crux of the issue really is between primary and secondary Raynaud's. Now, primary Raynaud's is particularly common, particularly in my neck of the woods with the current weather, although less so with global warming. And then obviously secondary Raynaud's, which is much more severe. And you can see this would be this may be a young lady with primary Raynaud's in her teens, quite with other predisposing factors such as being underweight rather. And this is obviously, you'd be much more concerned about an underlying connective tissue disease here with secondary Raynaud's with ulcer pits and pre-gangrene and severe involvement. So that's the spectrum that we're dealing with, and I'll try and guide you to how to place a patient along that spectrum. So these are the sort of common features between primary and secondary Raynaud's. So with primary Raynaud's, vasospastic attacks brought on by cold or stress with no underlying systemic disease, and I'll cover those diseases shortly. Symptoms are usually mild. They can spontaneously improve at about 15%, and in about 40% they can get worse. The attacks are normally symmetrical, involving both hands. There isn't any tissue necrosis or gangrene, and there should be strong symmetrical peripheral pulses and normal nail fold capillaries. And I'll come back to a nail fold capillaroscopy in a moment. The ESR would normally be normal, and you expect negative serology, particularly for anti-nuclear antibodies. And one of the main things is it's much more common in women, and its age of onset is young, usually in the teenage years. Now, with secondary Raynaud's, you'd be looking for clinical features of connective tissue disease, atherosclerosis. The symptoms are usually more pronounced, they're intense and painful, and they progress unless you treat it. The attacks can be asymmetrical. You can get pitting, scars or ulcers, ischemic skin lesions, even digital gangrene. And there will be evidence of microvascular disease on microscopy of the neurofold capillaries. And depending upon the underlying connective tissue disease, there may be an elevation of the ESR. You'd also look for the presence of autoantibodies, particularly ones associated with scleroderma. And late onset. So somebody who's never had Raynaud's in their teenage years and gets Raynaud's later in life, or particularly a man getting Raynaud's, you really have to go looking for connective tissue disease or other causes. Now, the classical connective tissue diseases associated with Raynaud's is systemic sclerosis, lupus, Sjögren's, rheumatoid, and undifferentiated connective tissue disease. Now, I'll just go through a bit of classification there. So scleroderma is, strictly speaking, skin thickening. Sclerodactyly is scleroderma up to the level of the MCP joint. So the diagnosis is systemic sclerosis. It's limited cutaneous systemic sclerosis if it doesn't go, if the scleroderma doesn't go above the elbow, above the knee, or involve the torso. If there's involvement of scleroderma above the elbow, above the knee, or on the torso, that's diffuse cutaneous systemic sclerosis. Now, both can be associated with Raynaud's. The Raynaud's in limited cutaneous systemic sclerosis can be there for several years before the other features of systemic sclerosis are apparent. Whereas in diffuse cutaneous systemic sclerosis, both usually occur quite closely together, the Raynaud's and the other symptoms. Organ involvement, particularly pulmonary fibrosis and pulmonary arterial hypertension, can occur in both, but they are more common in diffuse and more aggressive in diffuse. Now, as regards SLE, there's a new diagnostic criteria from the American College of Rheumatologists and the European League Against Rheumatology. They're quite helpful, and I would advise looking those up, and I've got them on a slide. Sjögren's, and again, I've got diagnostic criteria for Sjögren's because serology can be normal in up to a third of patients with Sjögren's. So they quite often get labeled as having fibromyalgia. And you should be careful about diagnosing fibromyalgia in anybody over the age of 50, really. It's usually a young woman's disease. Rheumatoid arthritis, and then undifferentiated connective tissue disease. Now, undifferentiated connective tissue disease used to be called things like lupus-like syndromes, but strictly speaking, you have features of connective tissue disease, but not enough to satisfy a diagnostic criteria for SLE or Sjögren's or scleroderma. A lot of the undifferentiated connective tissue disease will eventually evolve into systemic sclerosis. So here's some diagnostic criteria. So for SLE, you have to have a positive ANA. You cannot have lupus under the current diagnostic criteria with a negative ANA. Then you're looking for things like fever, hematological abnormalities, particularly leukopenia and thrombocytopenia, neuropsychiatric, delirium, psychosis, and seizures, non-scarring alopecia, oral ulcers, cutaneous lupus, serositis, joint involvement, so usually a non-erosive small joint polyarthralgia. You always have to dipstick the urine if you've got somebody with connective tissue disease, so don't forget that. That quite often gets quite missed in clinic. And then the other antibodies that are very useful doing, and particularly a screen for antiphospholipid antibody syndrome or Hughes' syndrome, where you're looking for lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2-GP1. Now, if any of those are positive, they have to be repeated after 3 months and still remain positive to be clinically relevant. The most relevant is lupus anticoagulant, followed by anticardiolipin antibodies, followed by anti-beta-2-GP1. Sorry, for lupus anticoagulant, followed by anti-beta-2-GP1, followed by anticardiolipin antibodies. And for anti-beta-2-GP1 and anticardiolipin antibodies, the IgG carries more weight than the IgM antibody. And also, the criteria for antiphospholipid antibody syndrome are being revised by the ACR and EULAR, and then this will take into account the degree of the titer. So it's not uncommon to turn somebody up with a low-level IgM anticardiolipin antibody, and it's not really clinically relevant. But somebody who's got a persistent lupus anticoagulant, you pay more heed to. Also, it's important to make sure that there's no history of venous or arterial thromboembolism, and take an obstetric history, because if you're looking for recurrent miscarriages, particularly in the first trimester, or preeclampsia, or placental insufficiency. And if you've got somebody with a history of venous and arterial thrombosis, then that's very suggestive. The only other rheumatological condition that really gives you both arterial and venous thrombosis is Behçet's. And remember, when you're doing a lupus anticoagulant, it's a citrate sample. Commonly, this test doesn't get processed in our laboratories because the phlebotomists, the people who take the blood tests, assume that because it's a rheumatology investigation, it goes into a yellow top. That's a clotted serum sample as opposed to a citrate sample. Look for low complement levels, and look for SLE-specific antibodies, particularly double-stranded DNA binding and anti-Smith. So anti-SM is anti-Smith, not anti-smooth muscle, which obviously is associated with autoimmune liver disease. The double-stranded DNA antibody test can be a bit variable depending upon how accurate the kit is. You can do it the old-fashioned way by asking for a Cryptidia double-stranded DNA, which is the old-fashioned way of doing it, but more accurate. So if you've got a positive ANA and you score 10 or more across these domains, then you'd satisfy the criteria for SLE. Now, the criteria for primary Sjögren's syndrome, and a lot of Sjögren's can be secondary, associated particularly with SLE and the systemic sclerosis and rheumatoid. So you can test for the antibodies on an ENA panel, anti-Rho, anti-LAR. You do ocular staining, but at the bedside, what's easier is a Schirmer's test. You can measure somebody's salivary flow rate, but again, that's a bit more involved. And if that is, and if you've got you're not sure, you can do a salivary gland ultrasound scan, which can be helpful, particularly if the symptoms are long-standing, or a labial gland biopsy, which usually involves about 4 stitches on the inner part of the lower lip. But you need to make sure that there isn't anything else that could be causing sicker symptoms, particularly a history of head and neck radiation, hepatitis C, AIDS, sarcoid, amyloidosis, graft versus host disease, and IgG4 related disease. Now, I routinely screen all my patients with atypical features of connective tissue disease, or before I start them on a biological therapy for Hep B, Hep C, and HIV. And I can't remember the last time anybody came back positive. But my understanding is that Hep C is much more of a problem in India, Pakistan, Bangladesh, and Africa, and also to a lesser degree in Eastern Europe. I've had several patients who picked up Hep C from dental work or gone abroad for cosmetic work. So don't forget to screen for bloodborne viruses when you're investigating anybody with either an atypical inflammatory arthritis or connective tissue disease. Right, what are the other causes of secondary Raynaud's? Well, old-fashioned hardening up of the arteries, pulmonary arterial hypertension, and they can present quite subtly, sometimes just with fatigue. Carpal tunnel syndrome, thoracic outlet syndrome. Symptoms with thoracic outlet syndrome would usually be unilateral, and you can usually test for that by putting the patient into the Roos position with abduction of the arm and lateral flexion of the neck on the relevant side, and then checking to see if the hand changes color, if the pulse diminishes, or if there are any vasomotor changes in the hand. Vibrating tools, smoking, following trauma, particularly wrist fracture or any surgery or frostbite, exposure to vinyl chloride, and drugs. Well, the obvious ones, beta blockers and migraine treatment, but also the cancer drugs. So some of the old-fashioned chemotherapy, such as cisplatin and bleomycin, but also the newer sort of immunotherapies that are used for cancer now, such as the tyrosine kinase inhibitors, can be associated with Raynaud's. Now, investigations. So take a good history, as for all things, particularly in rheumatology, where 85% of diagnoses are based on history. Check an ANA, an ENA, and an antiphospholipid antibody screen and if available, an extended antibody panel. There are these extended antibody panels now for scleroderma and myositis. Those can give rather equivocal results, not unusual to have a weak positive or an equivocal result, and be cautious of putting a lot of weight on equivocal or weak positive results on these extended antibody screens, particularly if the ANA and ENA are negative. Now remember, with Sjögren's, a third of patients will have a negative ANA, a negative ENA, normal immunoglobulins. Now, nail fold capillaroscopy is useful because if you have a patient with a negative ANA, a negative ENA, and normal nail fold capillaroscopy, you can exclude connective tissue disease with a sensitivity of about 95%. Now, nail fold capillaroscopy can be done with quite a high-tech setup, which is how we do it, or you can do it at the bedside with a dermatoscope, which the dermatologists use for looking in more detail. And there are various courses where one can go along to be trained to interpreting nail fold capillaroscopy, and I'll show a slide of that in a moment. Now, anybody with suspected connective tissue disease should have an echocardiogram, particularly screening for pulmonary arterial hypertension. Should have a lung function test, particularly looking for a restrictive defect from pulmonary fibrosis. And particularly if you suspect a systemic sclerosis, a baseline CT of thorax to pick up any early asymptomatic interstitial lung disease, because that would push you towards more aggressive treatment. And barium swallows can be helpful because you can get some characteristic hypomotility patterns in the distal third of the esophagus in systemic sclerosis, particularly what used to be called CREST, calcinosis, Raynaud's, esophageal hypomotility, sclerodactyly, and telangiectasia. CREST is a sort of more benign, late onset of limited cutaneous systemic sclerosis. Right, so normal nail fold capillaroscopy, abnormal nail fold capillaroscopy. You can either do it like this, which is how we do it in our department, or you can do it at the bedside with a dermatoscope. Okay, it can be very useful. So I'm happy to take questions on that part, unless you want me to take questions at the end. How would you like to proceed? Okay, I'll carry on then.
Yes, questions.
Questions on the first part, or should I take questions at the end?
Questions at the end, Doctor.
Okay, right. So migraine. Migraine is very common. We have specific clinics for it run by the neurologists. So the difficult migraines don't normally come into rheumatology clinic. As you know, it's all about vasodilation of the dural arteries and various triggers, some of which are easier to control than others. And some migraine can be so severe that they can present almost like they've had a stroke. But headache is a common problem in connective tissue disease, and it's more prevalent in Sjögren's, systemic sclerosis, SLE, and rheumatoid compared to controls. And there may be an association between Raynaud's and migraine. There's also been an association argued between antiphospholipid antibody syndrome and migraine. Obviously, don't miss giant cell arteritis, and anecdotally, the incidence of giant cell arteritis in our clinics has massively increased since the onset of COVID. I used to see maybe 1 or 2 new GCA patients a month. Now I'm probably seeing 3 or 4 new ones a week. There's been a several-fold increase. And I think that's down to either COVID or COVID vaccinations. And interestingly, I was speaking to a respiratory colleague who has a specific interest in pulmonary arterial hypertension. And since COVID, he's noticed a massive increase in the number of cases of idiopathic pulmonary arterial hypertension. So I just wonder whether it's a virus that really stimulates the endothelium. Neurosarcoidosis, rare, but if you don't think about it, you won't diagnose it. And then when it comes to SLE and antiphospholipid antibody syndrome, you can just have a non-specific headache. But also, lupus patients are more prone to idiopathic intracranial hypertension, and also more prone to a cerebral venous sinus thrombosis, as as is with COVID. So those need to be factored in as well. You can also have direct meningeal involvement in sarcoidosis, Behçet, Sjögren's, lupus, and Wegener's. You can get an aseptic meningitis with various drugs, the classical ones being anti-inflammatories, but also antibiotics, intravenous gamma globulin, monoclonal antibodies, of which now we use many, and paraneoplasia. Also, you can get a CSF leak due to dural weakness in various connective tissue disorders, such as Marfan's, Ehlers-Danlos syndrome, autosomal dominant polycystic kidney disease, and benign joint hypermobility syndrome. Now, EDS and benign joint hypermobility syndrome are quite often associated with POTS, and I was listening to the lecture of Professor Harris, and we've seen a massive increase in patients who are self-diagnosing themselves with Ehlers-Danlos, whereas most of them have benign joint hypermobility syndrome, but both can be associated with POTS syndrome. And they come along to rheumatology expecting us to cure them, and then are rather disappointed when they're told to increase their salt intake and wear compression stockings and take care when standing up. And then they can be referred on, usually we refer on to cardiology for consideration of drugs such as Debrine and beta blockers, which can be helpful. So more specifically, migraine antiphospholipid antibody syndrome. So migraine is not uncommon in antiphospholipid antibody syndrome, and it can respond to anticoagulation. Now, the Raptor trial done out of St. Thomas's in London showed unequivocally that patients have a much lower incidence of a further stroke, or if they are on warfarin as opposed to one of the NOACs. So patients with a diagnosis of antiphospholipid antibody syndrome should ideally be anticoagulated with old-fashioned warfarin. You can do MRI findings, and MRI findings can be difficult because you can get a rather non-specific pattern, which can be put down to migraine versus microthrombi. Anecdotally, I've had patients where I've treated them with warfarin and you get the INR above 2.5 and their odd neurological symptoms and their migraine get better. And they can predict when their INR is low because the symptoms come back. And patients with antiphospholipid antibody syndrome are difficult to anticoagulate. So their INR can be quite variable. And I had a patient who was a doctor herself who had antiphospholipid antibody syndrome, and she couldn't understand why her INR was all over the shop. And she was accused of drinking on the sly, and she said, no, I've been teetotal. And I said, well, it's your antibody level. I said, you know, if you've got antiphospholipid antibodies, it makes the INR unpredictable, more difficult to control. And then she looked rather shocked and realized that she'd accused several patients over her career of secretly drinking when it was down to the fact that they'd had positive antibodies. So one can base it treatment on evidence or eminence-based medicine. Quite often some of the more elderly, long-standing rheumatologists will pursue things which are not necessarily always in the guidance. So, for example, anybody who's got antiphospholipid antibodies and is pregnant is now put on aspirin and Clexane. But there's evidence that hasn't extensively been published, but they've got large cohorts. And if you put patients also on a small dose of steroid, that improves the outcome even more. So consider that for your patients with a precious pregnancy who've had several miscarriages, not as young as they were, and you really need to make sure the pregnancy goes to term. So in those patients, I normally give them aspirin, Clexane, and steroids, even though it's not necessarily in the guidelines. Right, so that's the end of my presentation. I'll be quite happy now to take questions.
The Merck Foundation has been helping on many fronts, especially in the human resource development or capacity advancement. Our panel discussion today will be to talk about or to discuss the challenges and solutions healthcare in Africa and Asia, and the impact of the Merck Foundation scholarships in transforming patient care, in transforming the patient care landscape in Africa and Asia. We have our esteemed panelists here to share with us their experiences, their success stories, and guide us as to what could be solutions to the challenges we are currently facing on both continents. And so I'll just formally introduce each of them. I was supposed to call them to come and take a seat, but as we can see, they're all here. So I'll just go through each and every one of them. First panelist is Dr. Kudzai Machingota, technical lead, COVID Go project, and Merck Foundation alumni from Zimbabwe. And we have Dr. Marjanina Angela Esguera Okolan, department head and emergency room consultant, St. Matthew's Medical Hospital and Merck Foundation alumni in the Philippines. I'd also like to say she was my classmate during our acute medicine training. Yes, and we have Dr. Sylvester Jordan Kaki, medical officer from Mota Engel, Malawi, and Merck Foundation alumni, of course, Malawi. And we have Dr. Suzy Maria, Secretary of the Indonesian Association of Physicians in Aged Care, Deputy Secretary of Indonesian Society of Allergy and Immunology, Medical Staff of Allergy and Clinical Immunology Division, Internal Medicine Department, Faculty of Medicine, Universitas Indonesia, Dr. Kipto Manggung Kusumo General Hospital. Then we have Dr. Simitri Dina, yes, Doctor Medical Unit at the Ministry of Social Security and Merck Foundation alumni issues. Then Dr. Joseph Edwin Kano, Lieutenant Colonel in the Republic of Sierra Leone Armed Forces, consultant physician, gastroenterologist, Merck Foundation alumni, Sierra Leone. Then we have Dr. Ama Yadua Bualu, internal medicine specialist and Merck Foundation alumni, Ghana. We have Dr. Timothy Mugabe, physician specialist, internal medicine, head of pulmonology unit and Merck Foundation alumni, Uganda. And last on the list, we have Dr. Gideon Chombo, physician, senior registrar, Kitwe Teaching Hospital, Merck Foundation alumni, Zambia. And you're all welcome, ladies and gentlemen. So we're informed that we have 1 hour to have this discussion. I'm done with. This is the last session of the day, and I'm sure all of us are tired. So we'll just move quickly into business. Yes. So we'll start with Dr. Kudzai. Share a few words on the following subject. Please tell us about the public health initiatives in your country. What is the role played by you as ECP and how it has impacted the overall public health environment? And then the follow-up question to that would be, how has the Merck Foundation training helped you offer respiratory care in Zimbabwe during the COVID-19 pandemic and beyond?
Thank you very much to the Foundation for the opportunity to be a panelist, and thank you very much for the host. My name is Dr. Kudzai Machingota, as shared previously in Muremwe. I am from Zimbabwe. I am a doctor based in Zimbabwe, and I come from public health organization. And I did my MSc in respiratory medicine with the Foundation between 2020 and 2022, which coincidentally coincided with the COVID-19 pandemic. So for me, this was really transformative. I was getting equipped as the COVID-19 pandemic was unfolding. I think that Doc already indicated the challenges that are facing Africa. Generally, currently, we have a high turnover of healthcare workers in Zimbabwe. Not only we have a few people that are into respiratory medicine, we mostly have physicians who are mostly guys from internal medicine, and those are the ones who are actually offering respiratory care within the country. But beyond that, we have a huge brain attrition. So the few healthcare workers that we have in the various disciplines, they are living in the country development center. So there's already a gap in all the areas that we have. And then also we are currently battling HIV and TB. Those have been there and we're still fighting those. And now we have a new pandemic to do with substance abuse that is on the rise. And then coming from the perspective of respiratory care, Zimbabwe is one of the countries that used to be on the list of countries with the highest TB. I think the first, the third country with the highest level of TB, we used to be on that list, but I have to report that we have now transitioned out of that list. Thanks to some of the recognition that we are doing, in the program. So currently, most of our efforts are focused on TB control because that is the highest burden that we have. But we've also seen that we have non-communicable diseases actually coming up. The previous president was talking about COPD and the importance of pulmonary rehabilitation. Currently, we are not seeing much of COPD, but we are seeing a lot of lung cancers. So there is indication that there's actually a rise in these conditions. And as a country, we are still lagging behind. But as we have more and more people who are interested in respiratory medicine, we have actually more advocates who can now raise awareness about these things. The other thing I want to talk about is to do with post-TB disease. Our focus currently is on controlling TB, but we are going to have patients that still remain with TB disease. And currently, these are our forgotten patients. And very soon, they are going to become a problem. And we are now wanting to focus on those. So as a respiratory trained people, we are now trying to actually catch up to what has been done with the guys who are into communicable diseases, particularly in the control of TB. So as I think for me, one of the things that I've benefited from doing the MSc is learning new things that are of importance that were never really of importance before. And I think also the issue of research. I think the previous host also talked about the need for research in Africa, because you find that we have a lot of data that we have, but our data is in papers. Our data at times is not even written down. So we need to move our data from the papers, we need to move it into electronic systems, we need to keep a record of the things that we are doing. So as someone who's been trained in MSc, I think my research capacity has increased. For the program that I'm doing, the COVID Go project, I think one of the things that you actually aim to do is to bring COVID-19 vaccines closer to the people. So that is one step towards an aspect of pulmonary rehabilitation, which advocates for vaccinations. Because in our countries, routine vaccinations for adults are not very common. We only vaccinate the children. Thereafter, we are always questioning what is in this vaccine that I'm being given. We're not very willing. So through that project, I've been advocating for adult vaccinations. So one of the focus of this project and my role in terms of public health intervention and what I used this MSc for was to actually help people get their COVID-19 vaccines. Now there's de-escalation of COVID-19, but there are those that still remain at high risk. That is our pregnant and teaching women, our people live with HIV, which is a high region where I come from, and then also our elderly. So those people, now that everyone else is relaxed about COVID-19, those ones still need an advocate who still stand for them and fight for them and ensure that they continue to get those vaccines and ensure that we continue to use the same momentum that we had. So that is what I'm actually working on, to continue doing a project that focuses on providing vaccinations to these high risk groups in as much as COVID-19 is no longer reach to so many other people. I think that's what
I'm right. It's not only three very important things to Africa. You know, like we have a triple burden of disease. We have the NCDs on the rise, we have the infectious disease still present. We also have trauma increasing in certain parts of the continent. I was just having a discussion with Selma a little while ago about trauma being a major big thing in the Gambia because we rank 8 in the world. She was telling me there are 4th or 2nd, 4th globally. Yeah. So that triple burden of disease is a challenge on the continent. And I'm glad to see that you are doing a lot of work on infectious diseases, tuberculosis, COVID-19. Yes. And something very important for our continent is research. Yes, it's something to really like. At this moment in time, I am working with the Medical Research Council in my country. It's already London School of Hygiene and Tropical Medicine. You realize that we have a lot of data, but we are not putting it on paper. Yes, most of the things we depend on is foreign data or assumptions of people most of the time. So this is important, we're all correct. And something very important she has mentioned is the attrition rate of doctors from the audience. The brain drain is serious. You have many people being trained, but we all fly to the Americans and the Europe. Yes, this is something that we have to find a mechanism for reducing. If not, it's going to be a challenge. Because once you train the people and they're all go away and the populations are increasing, that means we're not solving the problem somehow. Yes, thank you very much for that. Yes, then I'll move to Dr. Janina Angela Esquera. You have started an acute medicine clinic in your hospital. It is the first of its kind in your country or region. How has it helped manage emergency cases? And what is the response of your patients on the clinics you provide? I believe some of them are free.
Okay, so hi, I'm Makulan, and I came from Philippines. The Philippines has 7,105 islands, and almost all those islands are have a population. So you can see the problem there. Before you can go to the city, you have to cross the sea. So, but this one is a landscape, the healthcare landscape that our government wishes for the Philippines. So there are two kinds of patients. We have patients who cannot afford to pay their medical expenses, and they go to the public healthcare facilities. And you see many arrows, they go through a lot of steps and a lot of process before they could get treated. And the next one, the second group of patients are those who can afford. So they go directly to specialists and they can pay. And they can go to the city and they have no problems, they can be treated. Problem that we see here is how to bring these people to the hospitals, to the clinics, to have themselves see consult. So since our islands are divided, there are a lot of doctors who are trained, but only a few skills. So yes, there's also brain drain in our country. So those who are left behind in the Philippines, they're overworked. They're overworked. There's so many patients, and we can't get a day off or a year off to study. Because even if we could, even if we would want to, we still need to have the means, the funds, and to stop working and continue studying to better serve the people. So what happens is there is brain stagnation among doctors. I mean, what we knew when we graduated med school is still there, and then we keep on practicing and we keep on doing our own research, but there will be no formal education right after med school or right after training. So with Merck Foundation, I was able to do that. I was able to take a course in acute medicine, and well, research has been one of the gifts that this foundation, the Merck Foundation, has given me and my community. Because as of this moment, I do 3 clinics in my community in Rizal. It's a small province, it's very near the city, about 2 to 3 hour drive, but you would be amazed that there are still a lot of people who wouldn't want to go to the city to see consults because they don't have the means, the money to transport themselves. So when I go there, that's the time that they seek me. So I think that's a good thing. And sometimes I go to their homes in Rizal. So from there, I was able to collect data. And recently, the research that I've done would be about tuberculosis mastitis. Because tuberculosis nowadays, since 2019, I've had several patients that have biliary tuberculosis. Not only respiratory, because we have pulmonologists who handles these cases, but tuberculosis mastitis is there, hepatobiliary tuberculosis, and gastrointestinal tuberculosis are rampant in the Philippines. And that's the topic of my interest at present, and that's an ongoing research. And thank God, it has been recently published in the International Gastrointestinal Journal.
That's great.
From USW. Yeah, I have some notes here, so I would need to extend.
Before those come up, what has been the contribution of Mark Foundation? You mentioned research.
Yeah, research and sponsorship and the new innovations, the data, the resources that we have, the library that's accessible to me, to us. In the foundation, even as an alumni, it's still accessible. So I make use of those, and it's really been helpful for me and, of course, my community. And the next slide. These are the fruit of my education from Merck's Foundation. I have cases. I'm a general surgeon, and I'm in acute med. I finished acute medicine, but I know it's separate from what I trained for. I'm a trained general surgeon, but there are few specialists who stay in the rural areas. Most of them go to the city or they go abroad. So there is in San Mateo Rizal, there are only two in Rizal area, Rizal, San Mateo, and Montalban. Those are two big areas in the rural area near the city. But there are only two of us who does emergency care. So in a hospital, there are around 10 hospitals. When there is a difficult case that a general practitioner cannot handle, they call on us and we have to travel there. Or we can use Viber or Messenger to give the proper treatment and intervention. So these are actually the fruits of education. I have research topics, and on the last slide, that is just near the city. It's about 1 hour away from my residence. You have to sail to cross a river to get to a small island within an island, a smaller island, and those are the people who are waiting for us to give medicines and consultations. So that's what I basically do every month. That. And I have the Philippine Medical Association supporting them.
That's incredible. I think that's one thing in the developing world provide outreach service, free service. We have Dr. Modubel Ajalo here, he's the president of the Gambia's Association of Resident Doctors. And it's a routine now for every Monday, select a place in the rural part of the Gambia and go and provide free service there. So this is something common to us. That's a good thing.
Yes. And there are actually four, I know, there are 5 of us, right? 4 more from the Philippines, from the different islands in the Philippines that are here with me. And if there are more of us, then we could at least address about 1/10 of the 7,105 islands that we have.
Wow. You mentioned something very important. It is mediality. I've only read about mediality medical school. I don't think I've come across a patient of mediality. Though we have a high volume of PTB in Gambia, but mediality is hard to come by. So those are things important for me. No, I've been working in province. Yes. So thank you very much for the work you're doing. Thank you so much. Yes. So Dr. Susie Maria. Dr. Susie Maria. As a senior physician. Sylvester, it's no problem. No. So we follow the list. Let them change PowerPoint.
Susie Maria.
Oh, sorry, Sylvester. Sorry, I apologize.
Susie Maria.
I see. Sorry. Dr. Sylvester George Taki. My greetings, sir, again. Yes, as you have volunteered the Sylvie community, what were the issues observed and what have been the plans for those issues? You still have observed many things there, what you volunteered.
I think this is this topic is interesting. One reason. When my colleagues started explaining what's happening in their countries, I figured they say everything I want to present. It was everything. So it seems our problems are the same. Yeah, because now we ask the questions. Okay, let me start like this. As it's already been said, I'm Dr. Sylvester from Malawi. I will not say make friends with, because now I just completed diploma in internal medicine, and I'm sure they're not about to throw me under the bus. So I think it's a continuing thing. So I come from Malawi, which is also known as warm heart of Africa. It's in the southern east of Africa, with a population estimated about 21 million. Okay? So to talk about the challenges, I would like to give you a picture first of our healthcare system, how it is. Okay, so it's categorized in three. We have primary healthcare, which is includes health posts, dispensary, village clinics, and then we have secondary healthcare and tertiary healthcare. Right? So 80% of our population live in the rural areas, and that is where primary and secondary healthcare is. So the first point of care is primary, and mostly you'll find either a nurse, medical assistant, or a clinical officer. Clinical officer is like someone who's doing medicine at a diploma level. Okay. So they'll be the one managing primary health care. When it's beyond their expertise, then they send to secondary health care. So at some secondary health care, these are pretty much district hospitals. This is where you may find doctors. And when it's beyond their expertise, they are sent to the tertiary health care. And in our country, we have about 4 of the 21 million admission. So, one of the main challenges we have, there are so many of them, funding and everything, they're there. But I think I took a moment to just pick one, which I think is one of the main challenges we are facing. And it's that of shortage of medical experts. Now, the total registered doctors in Malawi, they are about 2,800, of which, when you talk about experts now, those who specialize, is 805. Now I'm doing internal medicine. The internal medicine, those that are registered, is 50 of them for a population of 25 million. Right? So, effects of that have indicated long patient turnarounds, time and expensive, high mortality from treatable cases, doctor burnout. But to get a picture, let me do this. Let's say a patient from primary health care, let's say he's a businessman or he's a farmer. He's sick, it will take the expertise of a nurse to be able to decide that this will need specialized care. Now, at primary health care, we don't have ambulances. They come from district, they come from secondary health care, district hospitals. And every month there is funding for that. Now, they will call for an ambulance, which will go to primary health care, get a patient, bring to secondary health care. They will take their time to understand the issues, to diagnose the case. If it's beyond them, then you need specialized care. The same ambulance now take that patient to station.
The same ambulance?
Yeah, at the district. You'll be the same one taking the patient out to.
Wow, because we have a similar system in Uganda, exactly like this. But once the primary healthcare ambulance drops the patient at the secondary facility, then one goes back to its facility.
Yeah, but now we hardly have one in primary.
Oh, okay.
It comes from secondary. So they have to call for one.
Oh, okay.
Yeah. And at times, it might be that we don't have diesel. It happens. So sometimes people in the villages will have to fend for themselves. Sometimes it does happen. Because sometimes we find that we don't have, as we said, in the funding for the hospital, there are so many. So And then that patient will be taken to tertiary care. When they are done with him, so I talked about patient turnaround time. So it comes from the here and there. By the time it goes back, if it was a storekeeper, it is being closed, which is the impact is felt in as it affects the profit of the account. Now, I talked about high mortality rate from treatable cases. 6% of the total annual deaths in Malawi is diarrhea. Diarrhea. Yes, that's what statistics say. Diarrhea is about 6%. You would have lower respiratory infection, about 6%. So we would have people dying from bacterial infections, people dying from diarrhea. Right? Now,
diarrhea linked to chronic conditions like HIV or just diarrhea standing up due to bacterial infection.
When we have coronary cases, it's a big issue. But now we're talking about diarrhea just in general. Okay. About 6% of our deaths, according to last year's statistics. Okay. Now, to talk about solutions, one of the main points that I thought would be one of the solutions would be improving the doctor-patient ratio, which is about, for general doctors, about 1 to 10,000. Okay? So if we can improve that, we'll be able to handle all those effects that we saw. Okay? Now, Merck Foundation's initiative and contribution to combat this scarcity of health experts has a positive impact in reducing workload that has afforded rural population otherwise would not have easy access to specialized care. So like I said, coming from primary care, and let's say they want to see internal medicine expert, and those people, some of them are in the private sector. Yeah, so it's a big issue. So what Merck is doing is making sure that if they've treated more, for example, they are already tertiary health center, there are many experts. Let's say I'm done with internal medicine, I'll probably need stations at the district level. If I'm there, then some doctors will go to primary. Yes. Yes, okay. I'm single. Yeah. I'm single. Yeah. So answering your question, how I tend to, you said my experience at this community hospital. Yes, I do volunteer at public hospitals, and that's why I'm able to talk about all this. But one thing that I've said that will be able to handle these problems, the first thing is that when we've obtained this knowledge and experience, we have to go back home and train those that otherwise don't have the opportunity. Because like I said, in primary care, we have nurses. If we impart this knowledge to them to some level, they'll be able to treat patients. Will reduce the turnaround time of patients. And what I've learned from Merck, the training that Merck is giving, is confidence, exposure, and relevance in the field. I know they're very
that was a beautiful conclusion. Yes. So we mentioned things that are very important. Let's say we have a few facilities to cover life operation. You mentioned the importance of more facilities and more doctors. So it's like we need an increment in everything. So thank you very much, Dr. Silva as well. Dr. Susie Maria, as a senior physician, how concerning is the growing prevalence of rheumatological diseases? How would you describe the long-term quality of life for the patients that you see? How important is it to provide special training in the field?
All right. I know that we are running late than the schedule, so I will just speak with my presentation. So I'm Suzy from Indonesia.
Are you seeing her? Yeah, let me move on.
For you who don't know where Indonesia is, it is a archipelago countries located between Asia and North American continents. And there is Philippines too. So, Indonesia has 17,000 of islands, but only around 6,000 inhabitants. And you can imagine with the very spread distribution of the islands, our government has challenges to make the balanced distribution of healthcare.
You can sit there so that
in
you will be in the
our
council.
country.
This is the back.
So,
If you stop, no,
we only have
people are seeing that.
500
So you can
hospital.
just sit.
We only have hospital at the level for emergencies and cities, and for the lower level for like industries or villages, our government only can serve the community with the community health centers. Community health centers still have doctors, but many of the centers doesn't have doctor, only have midwives or nurses, and the specialty care mostly located in the capital of the province and big cities. So now we proceed to my study with this PG diploma from the foundation. So I took dermatology plus. So currently there are 67 dermatologists. Because I'm also a psychologist, there are 37 dermatologists serving around 270 million people in Asia. And unfortunately, like in most countries, that the doctors, especially the specialists and subspecialists, find in big cities, beside the capital of the province and also in my city, Jakarta, the capital of Indonesia. The access for healthcare, we can say it's free for Indonesian because it's covered by our national health insurance. To be member of the national health insurance, those who cannot afford for the payment can be a member for free. And the diagnostic procedure and also the care and treatment for rheumatic diseases can only be covered in tertiary care in Indonesia. So those patients need to travel from maybe the rural area, maybe from the outer side of Indonesia to the specialty care located in the capital of the province and also in the capital of Indonesia. So this is the place that I work, Cikonang General Hospital. This is my clinic, and these are my team. And now you may ask why allergy and immunology also cover rheumatological disorders. So our division sees the problem as a spectrum of immunological disorders. So we cover this case of autoimmune diseases, allergic diseases, and immunodeficiency. That's why I took this diploma in rheumatology. And we have as a teaching university teaching hospital for Universitas Indonesia. So to serve our patient, we get help from the residents and also the subspecialist trainees. Then after completing my study in PG diploma rheumatology, this training improves rheumatology services in my place. And also I transfer the knowledge to my residents, the medical students, and also the training in place. And also, me and my colleague also hold regularly seminars and workshops for the doctors working in primary and secondary services. And the seminars that we hold usually is free of registration fee. And we also have hold seminars for other healthcare workers, including nurse. And also we have seminars for patient communities and also public in general. And I personally also get invited several times by our national TV stations to become a source person, and I talk about rheumatic conditions. That's it.
Thank you very much.
We realize something from the development. In a very sophisticated way. Yeah. Can you please just tell us about the leadership positions you're currently holding?
Well, yeah. Currently, I'm the secretary of Adult Immunization Task Force of Indonesian Society of Internal Medicine. I'm also the secretary of Indonesian Association of Physicians in Healthcare. And I am a former vice secretary of Indonesian Association of Allergy and Immunology. So with the association, we provide the need of continuing medical education for Indonesian doctors by holding seminars so they can continue to increase their competence, especially in the field they are covered. And also, every time there is an issue in healthcare, the organization that I work for used to do like assessment and then give a suggestion to our government about the issue, as well as the organization become the bridge for our for between the colleagues and also the government for mediating any issue or about the health care system and also about our profession.
Thank you very much. We are informed that we have time till 6 p.m. That is about 30 minutes away. So just ask all the speakers to keep it at 3 sides of COVID. Yeah, so I'll follow the next Dr. Simiriti. So Doctor, how many specialized dermatologists do you have in the public sector in the country? Please tell us about your experience as one after training in dermatology.
Good afternoon, doctors. So I'm Dr. Smriti Chadeshwar. I'm a general practitioner actually in Mauritius, and I trained in the PGD with my foundation in 2021 to 2022, and completed my MSc this year. The actual number of dermatologists in Mauritius is restricted compared to the population. So we have 4 public hospitals and around 5 dermatologists per hospital. So that makes around 16 to 20 dermatologists in the country to manage all the dermatological patients that we have. The issue here actually is not about dermatology, it's about specialization. Like all of you have said, it's actually true. So in Mauritius too, as a developing country, we might not have exactly the same issues, but it's overlapping. It's overlapping. We do not have a lack of doctors. We have a lot of GPs. We have untrained GPs. They are here after their initial studies, and they want to specialize because of lack of finance. So nobody can go out, nobody can leave the country, nobody can get specialized in the country. So there's no education in the country, and we can't leave the country to get specialized. So
there's no postgraduate training in Mauritius.
Yeah, no postgraduate training. And if you have like a theoretical postgraduate baggage, like with Merck Foundation, we don't get the physical training as well. Okay, and it is essential, according to the Medical Council of Mauritius, to have physical training to be recognized as a specialist. So what we are right now, we are MSc holders, we're not specialists. That also is not an issue as long as we can help the population. Okay. The actual problem here is that our general practitioners are not trained to do the correct diagnosis. We have some specialists that can help, but provided that these patients are guided into the proper channel. So what happens is that for any particular disease that needs to be diagnosed early, these patients are in the dark for a long, long time until somebody incidentally finds something and it's usually too late. whether it's a cancer, whether it's a skin issue, it just affects lifestyle, you know. And eventually, the cost of treatment is so high that we just have to live with the problem, with no care to how to say, to have a better life, with no money to have treatment either. So that's the main issue that I wanted to address, because everything that I actually prepared has already been said, and we all know that we need to address these problems. Okay, it's a lot of good theories on paper, but we know that it's very difficult to implement in our countries. We need a lot of support, and the first support that we actually found is from the foundation scholarships. I think everybody will agree with me that we are now a community in ourselves. We are all here with the motivation to bring change in our country. We are not having support anywhere else, so we are here. We're talking about issues in our countries. We want to move. We want to do something. Okay, and maybe if we can help each other even internationally, that would be good. So if you don't have, like, I'll say, dermatologists in your country, you know where to find them. Okay, and if you don't have, like, internal medicine specialists, you know where to find them. It's an open platform. We're all here. We are in communication. We know where we come from. We know the baggage is good. The universities we've learned from are very good. So it's a proper step to start. Okay. So it takes a long time to gain practice, to become as good as specialists who have done their full course, not part-time, but in universities. But I think we are doing much more, because we are still helping the country and studying at the same time. We have not left the country, we are there working and studying at the same time. So we are actually in the system. And everything that we have learned from our foundation, it's the diligence, the perseverance, okay, to keep bettering ourselves. And that's something that a doctor needs to do till the end of his career. And I don't think it's a career that ever in your doctors for life. And the need to actually help our country needs to be ingrained. It needs to be ingrained. So thank you, Merck Foundation. I think I had some statistics here. It's not for Asia, it's for Africa. I've not been able to find for Asia. But if you see these numbers, you'll see that healthcare in Africa is underrepresented. We have a lot of money in our budgets, in our governmental budgets, that go towards healthcare, but much of it is towards infrastructure. Not much of it is directed to HPA doctors.
Not in my government. The government is spending much of it in vehicles.
Vehicles.
Nice vehicles.
Yeah. So we have good hospitals in Mauritius. We have good infrastructure. But the issue is that we need trained people to use these. If a doctor is not good, it's not good, who's going to use the infrastructure? That's the thing. So I hope that we understand that the point from my presentation actually is that we are a community. We need to help ourselves. We are starting, I see a lot of initiative being taken by single doctors. Okay, you don't have anybody behind you, but you are starting projects in your islands, in your countries, and this is really motivating. I think everybody should start doing that and try to rally people around you. And so on.
Yeah, thank you very much. And for the community, yeah, definitely. Thank you very much, Dr. Simedi. Dr. Joseph?
Emma.
That's Lieutenant Joseph, right? Colonel. It's okay. Emma. Sorry, let me. Next. No, it's Dr. Joseph.
Emma? No, good. Presentation. What numbers?
No,
And that's.
Wait, okay. Lieutenant Colonel. Dr. Joseph. Should I start with saluting? He gave it to her. Okay, I'm talking to the gastroenterologist. So, sir, as a gastroenterology consultant, how helpful is a specialized endoscopic unit in addressing gastroenterology cases in Sierra Leone?
Yes, thank you very much. My name is Joseph. I'm from Sierra Leone, a small nation in West Africa, about 8.5 million population. I've been a migrating doctor for quite some time now. In 2012, I left Sierra Leone to do my residency training in internal medicine in Kenya at the University of Nairobi, because by then we haven't started the local postgraduate training in medicine. And then I returned in 2016, and then I realized we have quite a huge burden of gastroenterological and hepatology cases in Sierra Leone with chronic hepatitis B infection and H. pylori burden. So I had to seek for a fellowship program from the World Gastroenterology Organization, WGO, which is a good resource you can tap from. And I was awarded the fellowship. I came to India at ILBS, Institute of Liver and Biliary Sciences, one of the biggest hepatology centers in Asia. So I did my training, and then I returned to Sierra Leone. On the background of this presentation, like many of the speakers have already highlighted, I think these problems or challenges are not new. Okay, they've been existing despite persistent global political rhetorics and sentiments about making a change, but we've seen quite a little. And some of the causes for these problems are shared responsibility between ourselves and, of course, Western nations. Like many other speakers highlighted, the mass exodus of healthcare workers from developing countries, as well as having failed policies back in our own countries. So we have a shared responsibility causing these challenges to stay within our nations. So let me give you a picture of what is happening in Sierra Leone. So we had a civil war which ended in 2001, 2002. It was quite a very difficult time. So but that civil war, it's really hampered our healthcare system. And then we also had the Ebola epidemic in 2014, which also exhausted our healthcare system. And about in 2017, we also have a devastating outside, which also contributed negatively in our healthcare system. So in rural parts of Sierra Leone, you still find communities that are struggling with basic sanitation and drinking water, and with poor healthcare setups as well. So we are not immune to these problems that have been shared by my colleagues within Africa and across the continent. So what's my story? So when I finished training in India, so I returned home, and together with some friends, we were able to set up an endoscopic unit with a refurbished system. This picture is quite symbolic because it was my first endoscopy back home then, alone. So it's the second endoscopy unit serving a population of 8.5 million people. So we started with diagnostic upper and lower GI endoscopy, which we are doing for our people. We are currently doing a lot of varicella bandagization. Before 2020, people used to go to probably like Ghana to have a basic diagnostic upper GI endoscopy, and for variceal band ligation, they will have to come to either Ghana or probably across the continent. But now with these facilities, we can be able to treat upper GI bleeding and also prevent upper GI bleeding, especially in the background that we have a huge burden of chronic hepatitis B infection causing liver cirrhosis and portal hypertension, and also a huge burden of schistosoma mannsoni causing periportal fibrosis. We still have challenges. Currently, we've expanded the unit. We have a second endoscopic stock, so which has improved turnaround time as well. We've started training doctors and physicians in training as well on basic diagnostic endoscopy. We need to increase and expand on these facilities to district hospital level. We also need to go for long-term training and advanced training in endoscopy, which is the direction we are heading with in concert with the authorities. So the solutions to these challenges in sub-Saharan Africa and developing countries, they are not new. They are quite generic. We know we need to build capacity in terms of training. And this is where Merck Foundation have stepped up very well in terms of improving training across the continents and beyond. We need to improve on our budgetary allocation. We need to become advocates. So one of the benefits of also being a Merck alumni is at the end of the day, it's enhance your capacity to become an advocate and to be able to engage with authorities in seeking for better healthcare services. So now after completing my MSc, I've been fully talking with authorities concerned in terms of expanding endoscopic services across the nation, as well as training. We need to build infrastructure. Modern healthcare systems need modern infrastructure. You cannot have very old buildings with difficulties in wheeling patients here and there, transferring and referring patients here and there. So you need to improve on infrastructure and to make the healthcare quite better. We also need to improve on our healthcare finances. We need to put measures in place in terms of cutting down corruption and making sure people benefit from their local resources. So to the second question, what is the Merck Foundation through their training provided quality education to us by ensuring that we have global experts in various specialties. We were quite lucky. I'm here with some of my colleagues in the cohort of Gastro, Dr. Gideon and Dr. Lily. We had very good experts, and for me, it was quite good because coming back to a nation where I was the second gastroenterologist, and you don't have local mentors, and it was quite challenging sometimes when you're facing with difficult cases, but we have very good mentors like Professor Soldera, which we were able to contact, and he was able to provide adequate support for us in terms of endoscopy management and so on and so forth. In Sierra Leone, the Merck Foundation has provided about 46 scholarships in diverse specialties, and today I'm here with some of my colleagues in the other hall as well, who have been training different areas, especially areas in like oncology. The Merck Foundation has done a great job in terms of providing support in terms of training. Okay. So once again, on behalf of my team, I want to thank the leadership of the Merck Foundation, Senator Dr. Kalish and Professor Dr. Brand, and the entire leadership for their support they've provided for us in the continent and beyond. And today we are transforming healthcare services in our various settings. So once more, thank you for your attention, and we will see again in other conferences.
Thank you very much for that. Those are great words you pointed out. So the challenges are almost uniform for all of us. I think almost the same for all of us. It's just very important for us to have a political will at home, not for the commitment of all of us to make sure we implement it. Somebody was telling me one time that sometimes people in development fund, especially from my home, they're good in planning, but they don't believe. So that's something we have to improve. People who own us development funds. Yeah, thank you very much. So we move to Dr. Ama. Yeah, what? Yes, from the line of very knowledgeable people in Ghana. Studying for a long time as well. So, Dr. Ama, what is the level of awareness about hematological disorders in your region? How has the back condition training helped you monitor this case, especially in females?
All right, thank you very much. Forgive me, I know we are all tired. I am too, plus I'm so cold that my face yoga is not working. In terms of rheumatological conditions in Ghana, what's the awareness? Okay, so Ghana, yeah, this is the map of Ghana. We have a population of 34 million. And there are just 3 rheumatologists in Ghana. So 2 adult rheumatologists where these stars are in the capital city, Accra, and then 1 pediatric rheumatologist in the north, Tamale. So rheumatology is fairly a new field in Ghana. Started only in 2009 when one woman decided to brave it out and start a clinic, and then went out of the country to go train because there was no one to train clinically then. So she started, Dr. Day, she started rheumatology in Ghana, and then later on the 2 joined who did not train in the country. But yeah, so in terms of rheumatologists, that's all we've got, 3. And so you can see the huge burden for a population of 34 million with a growing number of patients who have rheumatologic conditions. So this is called the Boom in Accra, our biggest teaching hospital. The clinic number is up to 2,459 now. And of course, these aren't the only patients or the only people with rheumatologic conditions in the country. There are people in various places. I work in the central region here in the Cape Coast Teaching Hospital, and that hospital serves the central, the western regions. We can have people coming from all over as well, depending on what specialty they want to see. Okay, so in terms of rheumatology, there's a huge need in Ghana, and of course, if you have just 2 people training and the 1 pediatric rheumatologist is just recently joined, the awareness of conditions becomes a problem. So in medical school itself, we don't get very much exposed to rheumatology, really. The only 2 who are teaching are in Accra. There are other, there's a medical school here in Cape Coast, there's 1 in the north here, there's 1 in the Volta region. So it's either these 2 ladies go around these medical schools teaching, which they cannot always do because they've got their share of their workload here as well. And so you don't in medical school get a lot of training in rheumatology. Where you do would be when you are training as an internal medicine physician. In that case, you do some rheumatology rotations, but then of course it's not very long. It's better than you are exposed in medical school. So internal medicine physicians, yes. But like everyone has said, specialists are generally in the teaching hospitals, a few in the districts. So generally in the population, you have other primary and secondary care non-specialist doctors who are treating. And among these people, there's not a lot of knowledge in rheumatology. So what happens typically is that a patient would have one condition or the other. They would have gone to hospital several times and not found an answer because the doctor hasn't picked up the signs. And so they decided to say that, okay, if doctor can't solve it, then this must be spiritual. All right, so I'll go to the pastor, I'll go to the herbalist, I'll go to the witch doctor to seek help. So that by the time they see a rheumatologist, on average, they would have had symptoms going on for about minimum 2 years. And they would have developed complications along the line. So that is what we are dealing with in terms of awareness. Doctors, low awareness among us, patients, literally none. And even those whom we have diagnosed and tried to educate still don't really understand what they are dealing with. So it's a huge burden. And thanks to Merck Foundation, I did the postgraduate diploma and then went on to do the MSc. So in this, my little Cape Coast, what, how it helped me was that now I'm in fellowship training in Accra. Okay, but before I went to Accra, once I started the program, it became easier for me to be able to pick up these patients and diagnose. So in this, my little corner, I'm so happy to say that I had a lot of successes picking up patients, and then I became the focal point as well. So people in the hospital know that, oh, if you think somebody has something rheumatology, call Amma. All right, so I then began to give consults, and of course, because I have expressed interest, I had contact with the rheumatologists in Accra. So for difficult cases, I could always call on them. But locally, it became so much easier to pick patients and to manage. And that has been the biggest way that doing my postgraduate diploma has helped me with. Okay, so currently, this is actually where I am now. It's a small unit, but there's a lot that we are trying to do. And with help, hopefully we can do some more. Residency training, I am training, and there's 2 of us now in rheumatology and training. So hopefully when I go back to Cape Coast, then I hope that I can do a lot more for my people. Like I said, these are the things that I started to do. I wanted to start a clinic, but logistics was a problem, and so I couldn't do that immediately. But of course, that is the plan when I am done with the clinical fellowship and then I go back. Teaching medical students has also been so helpful. In terms of interest, people don't really have, our doctors don't have a lot of interest in rheumatology itself. So as we make a little more noise about it, we hope that people will pick up and then we'll want to specialize and help out. So for the challenges we mentioned, then there's no need to rehash them. But again, to conclude on the question that you asked, yes, awareness is a problem. As a unit, in terms of those who are consultants now and those of us who are in training, we are trying to rally ourselves together. We are in the process of registering a rheumatology society of Ghana. There's just a handful of us, but we hope that if we come together, then we can have a bigger voice and then we can make some impact. So yes, it's growing, and eventually, hopefully, all of us will join in to do some more big things.
Yes, so what he kept on saying, my little corner, that corner is bigger than my corner. Okay, thank you very much, Dr. Call on Dr. Timothy Mugabe. He was studying specialized treatment in the region. Please tell us about his feedback from your patients and the 5-year expansion plans for the clinic, and how the Merck Foundation help you in this novel process.
Thank you so much. Sorry, my voice is husky because of respiratory condition.
Sorry about that.
Yeah, so I'm from Uganda, and I did a PG in respiratory, PG in respiratory medicine. So basically, I customized this to respiratory care in Uganda and trying to get a picture of what is happening in Uganda as far as respiratory care is concerned. So it's quite a big population of Ugandans and a number of hospitals, but as you can see, there are only 4 registered pulmonologists. But there are pulmonology services out there, but the number of specialists are few. We have a number of services available in terms of investigations, as you can see, bronchoscopy, allergy tests and everything, but we still needed the specialists to run those clinics, to run, to be able to make sense of what has been done, So what is happening around? So we have the Makerere Institute, which is based in the National Referral Hospital, and it is basically a basis for research, and a number of research fellows are there. Those are not pulmonologists, but they are research fellows, but they're also contributing a lot to research. And as you can see, the last point down there is that there is no formal pulmonary training in Uganda. So that's when now Mark comes in. So because it saves us, the burden to travel and the cost to have this pulmonary training in another country, away from your family and everything. So that's what Mark did for us, and we managed to have the training back at home while I still maintain my job. So that's what Mark is doing. I want to go through this because I think it has been echoed several times, and the scholarship that Mark has provided. But as you can see in the second last bullet, so basically what Mark is doing is that these are sustainable development goals, which is attaining good health and well-being for all ages. So I think that is the great thing. So it has, so the doctors have been able to develop their careers in specialized medicine, despite the fact that in our own countries we have inadequate training institutions. So I think that is the plus for Mark. So, like I said, I added to a pool of respiratory clinicians. So I currently work with a hospital called Zambia. It is a private not-for-profit, plus another missionary hospital somewhere in the village. These hospitals are busy, and to add more spice to that, the hospital I work is also a training hospital for postgraduate medical school. That is Mother Kevin Postgraduate Medical School. So I trained in the same medical school, but by then we had the visiting pulmonologist who was teaching. So I was happy that after the training, I'm also now a part of the team that is training postgraduate students. So what we've done after the training, so I've started a chest clinic alongside the administration of the hospital. So we've got a number of patients, inpatients, outpatients, and everything. And just to consider the point that my colleague talked about the change in the nature of the medical conditions that we see in chest medicine. There's been a lot of change from infectious to non-infectious pulmonology. So those days, if someone saw a lesion in the chest, it would either be TB or Kaposi or something like that. But now things have changed so much. There's a change a lot to non-infectious pulmonology, interstitial lung disease, vascular lung diseases, COPD, malignancies, asthma, and all that. So without proper training, it is very difficult. As a doctor, you need to have a wide range of differentials. So if you have few differentials, for every cough, you'll treat it as an infection, and then you miss out. So I still think this was great training, and with this, we're able to make better diagnosis, and helping patients out of their despair. So this is the clinic. So we do a lot of training. bedside training, and that's where I'm running the clinic from, performing procedures. So things that we never used to do before, now we do better, and also train other people to do the same. So prospects, future prospects, what do you think we're going to do? I mean, what are we going to do in the future? So to me, by the time I began my training, I was already a physician, but this was a big plus on my side. So it has opened my eyes. Actually, I've learned more pulmonology ever since I did the training, because I see more patients, I get more challenges. I consult, I consult the book, I consult my colleagues. So there's a lot of interest which has been stimulated, and also have other people that are looking at me, being mentored, to do chest medicine. So we have respiratory services closer to the people. What we think we need to do more, we need to train, we need to gain more skills, especially in the field of interventional pulmonology, bronchoscopies, imaging guided pulmonary procedures. Those are the skills which we don't have so much in plenty, and we hope that we shall develop those skills better. And then, of course, research. Thank you.
Mugabe? Yeah, I almost said Mugabe from Zimbabwe. No, I didn't say that. Thank you very much. On our final speaker, this is Dr. Gideon Chongo. Chongo, please tell us about your experiences as a gastroenterologist working in the public sector, and how difficult is it to monitor gastro patients within the public sector? And is there any public-private partnership or anything? If I could better more about the situation here, especially for the public sector.
So thank you for the opportunity. Like it's mentioned, I'm Dr. Gideon Chongo. So it's very difficult to speak. Yes. Before I am. So I'll be very brief and focused. So what I want to do is actually just put what everybody else has said in terms of pictures so that we can appreciate that. So this is what everybody else has said. This is just putting a picture form. This is eye chart of the challenges that Africa and Asia are facing. Now, Africa and Asia are very unique continents. Why? Because they are the two largest continents. Of the 7 continents, the Africa and Asia are the largest. So most of the challenges in terms of healthcare that we face are probably because we are having challenges to meet the health demands of our these two populations. But as you can see, the pie chart is showing there, the largest, those 4 segments that we see there, borders on the biggest challenges that we face in terms of health. So leadership is a problem. Even though resources are not enough, but we don't have trained leaders to be able to utilize the resources very well. And then healthcare, workforce there, health workforce, that's the second one there, like everybody else has said. So you can see the bigger chunk of where the problems are. And then service delivery. So there's poor service delivery in Africa and Asia alike, probably because of poor infrastructure and not having enough trained personnel to be able to handle these problems. And then there's not deliberate policy to finance healthcare. So this was based on a study that was done on 11 African countries, and those are the challenges that were proposed by this study that was done in 2019. So I just want you to focus on health workforce there. It was the majority, and then the leadership and governance. So if we can tackle these two effectively, then probably most of our problems are going to be handled. Health workforce, how? Of course, having enough health personnel to be able to handle the challenges with populations that we have, and secondly, to be able to train specialists to handle specialist problems. If we can involve those that are given the responsibility to handle resources and leaders, train them to be able to utilize these resources better, probably most of this. That Make Foundation can. So like everybody else has mentioned, Make Foundation is making a difference. Remember we talked about the workforce, that shares the biggest, one of the biggest chunks there in terms of our challenges. The Make Foundation is bridging that. So it's giving opportunities to all of us to be able to bridge that gap and get better life care so that we can help with unique populations as they are in Africa, which are. To be very specific, or to give an example, like everybody else said, this is the country where I come from, about 19.6 million people, and about 10 provinces there. Now, of these 10 provinces, we only have 9 gastroenterologists. So I was given an opportunity by Make Foundation, by the way, to do MSc in gastroenterology, and this is the challenge that we have here. So these 9 gastroenterologists are public and private combined, and they are concentrated in this, the smallest province here, which is our capital. Probably because it has a density of about 100 persons per square kilometer. So the needs have not been met still. So all of them are there, almost all of them. So you can see the rest of the provinces there. I come from here. This is a distance of about 360 kilometers from here. And then, of course, everywhere else there is land. So, handling the population here, and probably somewhere around here, you can see what the region that is handled by reindustrial revolution. So, I'm doing a clinic after my study. So, this clinic is been established in the province that I showed you there, specific teaching hospital, and this is one of my clinics there. As young lady, had very concerning symptoms, abdominal swelling, but of course she's fine. And this is the shelter where this clinic is held. You can see the challenge of infrastructure. Like we mentioned, there's still but get it. What are the benefits that have been achieved? So that have been achieved by conducting this clinic with that province. I just mentioned to you that specialists, gastroenterology specialists are 360 kilometers away from there. Rest of the province is so you can imagine this lady here already on a wheelchair, financially having to cross about 360 kilometers to go to specialists, how challenging it can be, and how much you can reduce the financial burden and be able to locally handle problems. Because this problem is handled. So these are some of the benefits that we see with financial burden being less than people, local people around surrounding my area. The these patients against improved specialized healthcare. And of course, it gives me a lot of job satisfaction. Be able to handle this better than which I know every country, getting the financial background information, it makes you feel good and vision doing something.
Yeah, third one is the
all the not satisfactory of your patient. Yes. And my other problem.
Yeah. Dr. Gideon.
One minute.
That one, Timothy.
Thank you very much for this opportunity. I just wanted to say something about what you guys have all said, and also just to point out a very important point that some of you have mentioned, and just give a bit of advice of something that my professor always said. What our countries are going through is a lot, okay, in terms of healthcare provision, infrastructure, facilities, human resource, and all that. Make Foundation is trying to bridge this. And one important thing that Make Foundation has done now,
through these meetings is uniting us, which is helping us create networks. And these are the networks that are going to help us. And this is where my advice is coming in. From developing countries, a lot of people are really flocking. And that is because there is no support from the government. First of all, for example, if you get your master's in whatever course that is being offered here, most of these our countries are not recognizing this, okay? And people are leaving because they are not recognized. People are leaving because they do not get the support that they need from the government, whether it's setting up the facilities, whether it's giving them infrastructure. And this is where my advice comes in. Professor Amambo is research in Namibia. He always said, when you are faced with challenges in your country, do not run away. Do not leave. Imagine a country that everybody after specializing or after completing course needs, who is then going to save the nation? We all joined, I joined med school. I wanted to become a doctor because I had passion for saving. And I'm going to save in the health system. So the passion should be, this is the platform that we have gotten. So we shouldn't leave. And instead, we should help also support the government. And how are we going to support the government? We are going to support the government by forming networks. For example, if I know somebody that has helped set up a respiratory facility in their country, so we must form forces and we must find sponsors. Remember our first two speakers for today, I remember one said, first you must define who your enemy is, what you want to tackle, and then you must secure partners in funding. After that, then you come up with the guidelines, and that is how I think we are going to help our communities instead of trying to go to better places where the grass is already green. We must try to water the grass that we have at hand. Thank you.
Thank you very much for the invitation. That's a lot from all of you. However, I'm a Nigerian working in Sierra Leone. So I'm not running away. I didn't run away from Nigeria. After finishing my residency program, I had the opportunity of going to US and some other things. I've worked outside. But I realized something. When you go there, you are just a second feeder. You are following protocols. You are not going to Sierra Leone, I know how effective I am when you are there. I work in the provinces, but the advice I want to give is let's be part of the solution and not the problem. Majority of us are part of the problem. Without observation, majority are part of the problem. What do I say? I was a consultant pediatrician, fellowship West Africa College of Physicians, fellowship National Postgraduate College. I was the best overall in pediatrics. So what will I go and do in Sierra Leone? When I went there, I was working in Gambia, not even in Freetown. What I realized is that while working in that place, majority of the babies they bring in are treated babies. There are neonatal jaundice. We started estate blood transfusion in that same cubicle by a nurse. I have to make a table like this and put Loisette on that for phototherapy. What happened after them was I realized these babies that are coming in are bad babies. Where are they coming from? There's what we call maternal and child health assistants in the local places. That's where they are. And there is a school in the same hospital that train those nurses. So I started going to that school and start teaching neonatal resuscitation and newborn management. Because it is a course in which they will be graded, they have no choice than to learn it. It is not in the hotel. It's they have no choice than to learn. I went to the nursing school. Now I'm in Freetown. I think I'm even more useful in the provinces than in Freetown. But in Freetown now, I teach year 1 BSc nurses, year 3, year 4 in pediatrics. I restructure the curriculum to make sure that everybody start learning pediatrics from 100 level, 200 and 400 level, without collecting a penny. Although I work with UNICEF, so I'm being paid in dollars. However, it's something. But that's one of the ways to give back to something. When I started working in Sierra Leone, to God make it glory, in the last 2 years, 20 doctors have passed their families to go to pediatrics, and that includes the wife of our doctor. So I'm now in Ghana. The friend of mine invited me in Ghana to come and be teaching it online. Each student is to pay $600 for that preparation.